Is anybody else also here, or is it only me?
Ira, you are live, so just hold on.
Okay.
Ira, you can start, and meanwhile, me and Anup can also come in and speak. You can start the session now. It's 41.
Yeah. Yes. So, good morning. Namaste and welcome to the third day of Metabolic Health Conference from India. And this is the final day after 2 days, two marathon days of the conference. Today, we have a very special guest with us, Dr. Salih Saad Al Ansari, who is an assistant professor of family and community medicine and CEO, Health Promotion Center, Riyadh, Saudi Arabia. He was the Director General of School Health, Ministry of Education for 10 years. He was appointed at critical positions in the academia, and he has been an advocate of health promotion and combating non-communicable diseases in the Arab Gulf state and Saudi Arabia since more than 28 years now. He has written 2 books in Arabic on walking and translated more than 200 articles on walking, nutrition, health promotion, and NCD. So we'll welcome Dr. Ansari. And also with me is Shashikant Iyengar. Anup will be joining in a bit. Shashi and Anup are the co-organizers of India's second Metabolic Health Conference titled Metabolic Therapies. Welcome, Shashi.
Yeah. Uh, Dr. Ansari is yet to check in. So, meanwhile, Anup, get Anup in. Yeah.
Yeah, good morning.
Good
Good morning,
morning. So, I
everyone
think
watching.
Good morning.
so. Good morning to all. And I think we had a very exciting session in the last 2 days covering the metabolic ketogenic therapies in mental health disease, even the neurology space, of course, and more will be covered today. We had session on cancer and even CKD, chronic kidney disease. See, in generally in India, people think that when it comes to ketogenic diet, it means it is going to damage the kidney. So that's the immediate perception. Whereas we have seen actually 2 specialists coming and speaking. One was a nephrologist who is applying low carb nutrition, maybe not ketogenic, but low carb nutrition is patient to correct a lot of metabolic syndrome. We also had Professor Thomas Oimbis from Santa Barbara, who has actually done researches studies on how ketogenic diet can actually be applied to a condition called polycystic kidney disease, which doesn't have a very strong, very good prognosis. So people will end up with complete failure. They'll have to go in for transplant. But however, he found out through research, whether it is mouse model or for retrospective population study or specific study, then they are also going to conduct studies ahead. And they have found extremely encouraging results in terms of stopping the progression or even possibly reversing it also. So a lot of prospective studies will now be conducted, but the lot of excitement appears to be in this space. We have had Dr. Georgie Hyde coming in, Dr. Rachel Brown coming in, and Nicole also coming in, who's a licensed healthcare practitioner, and how they have very successfully applied the spectrum of low carb or ketogenic diet, or let us say even carnivore approach for the matter, to reverse some of those people think that, I mean, the common knowledge is psychiatric condition like bipolar or schizoaffective disorders may not be reversible, or they are consigned to a lifelong medication. So they have shown that by applying ketogenic diet, they're able to reduce the medication. Some are able to come off it, but nevertheless, there's a great resolution in symptom. People are able to get back to normal life also. So it's really a very encouraging thing which we are seeing. And also in the cancers, we had Professor Seyfried, Dr. Nasha coming in. So their concept on the metabolic approach to cancer, rather than the genetic approach, more of the metabolic approach to cancer, has also thrown in a lot of information that we can when it comes to cancer, we can take care of the metabolic part. Their uncontrolled blood sugar, that some of them may be having weight issues. And what they have seen is by controlling these factors, the prognosis seems to be better. So the cancer patients are able to get or they are able to withstand the conventional treatment like chemo or radiation in a much better manner compared to if they just go with the standard way. So while applying these dietary principles, they are able to have a very good success rate also. In fact, in many of the cases, some of the cases as expressed by Dr. Nasha herself, so she has brought her cancer into remission. She's a
Yes.
live example and doing a lot of
Yes.
work in this. And we had exciting talk with endocrinologists on diabetes. So we had Dr.
Mm,
David Kavan and Dr. Marila Gland, who are
mm,
qualified mainstream endocrinologists, who could come and tell us that this is the paradigm which they have suddenly learned,
mm. Yes.
and they have changed the practice from from the total medicine to now applying low carb nutrition. And they are using both the approach. Let us say that I'm not telling that they are totally into only prescribing dietary measures. No, they use medication also, but these medications are by far very less.
Mm,
But they're using very less medication. They're able to control, and they're able to get even 30 years of people with diabetes to a good level. So either reduce the medication, some are able to come off also. Of course, those success stories we have in DLF is totally different. But that is what we have seen coming from a qualified nephrologist, qualified diabetologist, qualified psychiatrist. So these things are going to be more encouraging for all of us. Yeah, Anu.
yes. Certainly.
Yeah, you talked of, carnivore and kidney condition. Now, one case that needs to be highlighted is from Dr. Kishle, where a kidney transplant case with other complications, like as he mentioned, vaginal bleeding, anal bleeding, and all. So he took up that case on his diet, and I think he mentioned creatinine dropped from 1.8 to 1.1, and all the
Mm,
other complication side effects, like anal bleeding or whatever is there, that is all gone. So that is one point. And second point is that this mental disorder. I mean, we have one case which we always talk. He was on, I think, three or four antipsychotic drugs. So of that, three were gone, and one was the dose was reduced to, I think, 50% or maybe 25%. So yes, besides that, he had the other complications of these medications, like being overweight, being diabetic, and his spleen had issues. So all those things were gone. Yes, till the time he reported, it was all perfect and fine. And as you said, there is a dietary solution for all metabolic disorders as long as we keep our minds open and not, as Dr. Kishle said, that in education it is either infectious disease or non-infectious disease. Infectious ke liye they have antibiotics and all those pills, that is fine. But for non-infectious, they start going on genetic side, and then how to control that through pills again. So this pill-centric approach needs a second thought, and that has to come from top-down, approach. But unfortunately, I don't think that is going to happen. So world over, as you see, it's a bottom-up approach with few doctors, yes, being large-hearted, or I would say, open-minded to accept that yes, they were wrong.
mm, mm. I think very critical points there. More such, I mean, it's a total, just to conclude what both of you said, it's a total shift in the perspective of how we have been looking at critical ailments like cancer or even mental health with regards to the nutritional aspect now. So it gives a lot of insight hearing these experts and doctors who themselves are practicing low carb on their patients along with the medicines. So I think.
I'll add
Uh,
one point here now.
yes.
This, mental disorder, I think nobody knows, or maybe only few know because I've never heard anyone talking of it.
Mm,
Dr. Richard Bernstein, before he became a doctor, he was an
mm,
engineer. And as an engineer, he had taken, I think, worst cases of bipolar or something.
mm,
And yeah, there is one case. And he had recruited doctors along with him
mm,
just to show that reducing blood sugar drastically, all those patients, I think I forget the number, maybe 5 or 10, all the patients improved on their whatever score, they evaluate. And that paper he wanted to publish. Everybody, I think, refused. Then he took up medicine, and I think that paper again went to some Israeli journal or somewhere. So this bipolar plus versus, or metabolic, mental disorder versus blood sugar primarily is not something very new, because it had been done by Dr. Richard Bernstein. If anybody goes to his channel and hunts through one of his videos, it is there. Thank you.
No, it is amazing, as Emmy also said yesterday. I mean, I really credit Emmy, for bringing the spotlight back on Alzheimer's, as I always say. And Emmy has talked about this in all of her videos, and a lot of her videos actually, that, when she started looking for research material or reading material while she was doing her thesis, she was completely shocked at the evidence that was there already of insulin resistance being a primary factor in triggering Alzheimer's later in life. So you already have symptoms manifested, symptoms going on from very early age, maybe 30s, 40s, which actually manifest later in life, and by which time it is a bit too late to completely reverse that. But yes, looking at insulin resistance and looking at parameters like diabetes does give an edge over, just treatments through pills. Shashi?
I think, see, the perspective of Amy, her research, especially on the amyloid plaques, okay,
Mm,
and then the metabolic part itself is quite quite groundbreaking for quite some time. See,
yes.
now the metabolic angle is being recognized just now, but then she has been doing it for quite some time. I think, I don't know. I think it is maybe 6, 7, 8 years or a decade. Anup may know better.
Mm,
And
mm,
you see the angle of even the perspective given by Angela Stanton on
yes.
on migraines. So it is in stark contrast to what we really think it is.
Mm,
So while there are no specific dietary advices, or a general dietary advice is usually given, you take fruits and vegetables, we actually seen that in in her initiative, especially her Facebook has millions or lakhs of people or hundreds and thousands of people. They are better health, or overcoming all these migraine episodes and symptoms by
mm,
going to ketogenic diet and taking bit more electrolytes, especially the salt factor. So in
yes.
these cases, we have seen that salt is actually the friend and not the enemy, as usual, as it is usually so said. And then sugar is the enemy in those cases.
Yes, and so whatever is the enemy is being pushed really, and which is a sad state of affairs. I think these sessions are completely groundbreaking and brilliant sessions, and every person who's going through such issues, and most of the people, do have issues of migraine. At least I know 4, 5 of them, and I forwarded them the link, and then they've gained, immensely through our sessions. So really brilliant ones.
Yeah, talking of migraine, no, we don't have many cases. We just have one case of Vivek Mishra,
Mm,
where it was all gone along with his diabetic medications, his weight coming down, and his migraine was all gone. He
mm,
shifted to low carb. We have a live case. We have his podcast also, so anybody can watch later on.
And
So
that's
we may not have the numbers, the big numbers, but we have specific cases of almost every, except for cancer, I think, because Shashi is
mm,
handling one bipolar case, if I recall
yes,
correctly, right?
I
yes.
think D Life already has one case where we have shown success, Rajneesh.
Rajneesh, yeah. So we have cases. We have cases to prove that it works. Rest,
Actually, in D Life, we have been having a lot of such cases. If you see, practically every spectrum is there. There is at least one case. So diabetes and obesity is one thing, but if you really see, there have been cases of remission of a lot of other conditions also.
Mm,
So I think, Ira, it's time that we can start session. Dr. Matthew is here, and
yes.
co-host Shilpi is also here.
Good morning, Dr. Matthew.
Morning, guys. How are you?
Good morning,
We are all
doctor.
good and welcome. And I'll move out from here.
Yeah,
All
Dr.
right.
Matthew, welcome. Get me in, Arti, Trusha. Yeah, we three will be here.
Yeah.
Dr. Matthew, welcome. And I'm Shashikant Iyengar, the co-host today, along with Ms. Shilpi. And welcome to the second Metabolic Health Conference of India. So we had the first conference somewhere in October 2023. It was a grand event. It was a general low carb or keto introduction, whereas this event is very specifically on the ketogenic metabolic therapies, specifically focusing on neurodegenerative disorders and mental health, CKD and cancer. So these are little unheard of in India. While we know about diabetes and the other spectrum or obesity, these are all little unheard. And we don't have a single metabolic neurologist across the span of India. So probably post these such conferences, we may have metabolic psychiatrists and neurologists coming in with special interest. And so me and Anup Singh, who was just here, so we are the co-organizers of this metabolic health conference. We have taken this initiative. We have been here from quite a long time, but we dreamt of this conference in 2017, finally materialized in 2023, and now there's a follow-up program. So Anup Singh has done the initiative of having the India's oldest, largest, and award-winning platform called DLife. So huge community with a lot of Indian recipes, so that it is tailor-made to India, especially the vegetarian segment. And he also runs certification course, so that a lot of metabolic health coaches can be churned out to help the rising tidal wave of metabolic disease in India. So that's how it is. So Shilpi ma'am, you can introduce yourself and you can introduce Dr. Matthew briefly.
Right. So Dr. Matthew Phillips is a clinical and research neurologist at Waikato Hospital, Hamilton, New Zealand. His foremost passion is to explore the potential feasibility, safety, and efficacy of metabolic strategies, particularly fasting and ketogenic diets, in creating alternate metabolic states that may benefit people with various neurological disorders. His team conducted the world's first randomized trials involving a ketogenic diet in people with Parkinson's disease, Alzheimer's disease, and is now applying fasting and ketogenic diet protocols in several people, Huntington's disease and ALS, in fact. He's currently conducting a clinical trial in glioblastoma, a type of a cancer which combines standard treatments with the most intensive fasting and ketogenic diet protocol ever applied to a group of patients with advanced cancer. We are really looking forward to gaining valuable insights from you, sir, in the session, and a very warm welcome to you, Doctor. Shashi, let us get started with our conversation with Matthew, sir, and then I'll talk about myself also in between.
Yeah. So how I'm very curious to know, you are a qualified neurologist. How did you enter into this metabolic space, nutrition space?
Yeah, well, I finished my training in Australia, in Melbourne, Australia, in 2012, or right at the end of 2012. And then at that time, I really didn't know what I wanted to do. So I decided to travel and volunteer and work around the world for 3 years. And during that time, I was actually actively pursuing what my next path would be. And I ended up looking at a lot of different things, and the whole fasting ketogenic diet space really appealed to me at that time. And after that, I decided to come to New Zealand and begin my work in metabolic therapies to see if these were valid approaches to helping people with the disorders that you mentioned.
So what all diseases comes into the neurodegenerative disorder? This is a very basic question, and this is meant the audience are going to be the lay people. So it's very, very basic question. What do we mean? Which are those disorders?
Yeah. So the number one disorder for neurodegeneration would probably be Alzheimer's disease, followed by Parkinson's disease, and then probably amyotrophic lateral sclerosis, or ALS, which is also known as motor neuron disease. And then you've got other ones that are rare, Huntington's disease, and then other ones with fancy names like progressive supranuclear palsy, PSP, cortical basal syndrome, CBS. There's a whole bunch of other rarer ones, but that would be the main ones. I guess multiple sclerosis is sort of a hybrid of neurodegeneration and inflammation. So sometimes people group it into neurodegenerative disorders, but many people don't.
Doctor, please tell us in brief how mitochondrial dysfunction plays a role in these kind of neurological disorders. We understand mitochondria as the powerhouse of the cell, generating ATPs, generating energy. And also, is there a way that we can rejuvenate or restore our mitochondrial health? I think that's the core topic of our understanding.
Yeah, that's a great question and a big one.
Yeah.
So mitochondria are, there's a few hundred or a few thousand of them in each of our cells, almost all our cells except red blood cells. And like you said, they power the cell, almost all of the cell's functions. But they do a lot more than that. We're just finding out in the last 1 or 2 decades that they probably control the metabolism or all the chemical reactions inside the cell to a very great degree. And they're able to help determine which genes in the cell get turned on and get turned off. And so that's sort of, they have this epigenetic function. And they also have signaling functions, not just in the cell, but outside the cell. So they can make hormones, which are chemical messengers that go from one cell to another, and so on. There's so many things they do. There are dozens of functions that they actually do. Now, the really interesting and cool thing about metabolic therapies, and when I talk about metabolic therapies, I mainly reference fasting and ketogenic diet protocols because I am most interested in our natural therapies that are natural in evolution for all people around the world, no matter where you grew up. So fasting and ketogenic diets, despite the fact they're very misunderstood things and thought to be a bit weird, they're actually far more natural for us than our current dietary lifestyle is. Even if you adhere to a cultural dietary lifestyle, that is not as appropriate for human beings as our ancestral one as hunter-gatherers before culture arose about 10, 15,000 years ago, and agriculture with it. So that's my interest. I want to try and apply very old therapies to people with a lot of these disorders, like neurodegenerative disorders and other things that are actually, they're not new, but they're becoming much more common. And I think they're becoming much more common because of a lot of the dietary lifestyle and other aspects of our lifestyle that we do now. So I want to try and restore our ancient dietary lifestyle, which is mitochondria, healthy for mitochondria. It promotes many good things in mitochondria that make them more resilient. And I think mitochondria are the key problem in these disorders that we're talking about, the neurodegenerative disorders today. And so if we can apply a fasting or ketogenic diet protocol to them, maybe we can restore the mitochondria to a degree and improve the disorder at a fundamental level. That's my interest.
Yeah.
And there's, before you go ahead, very interesting statement doctor has made, that the ancestral diet is more important than the cultural diet. I think this statement, it should be etched in stone. Yeah, madam.
Yeah. So sometimes, often it is seen that the pathologies are beginning somewhere else in the body. Say it's the gut thing, but it affects your central nervous system. It affects your brain and the environmental factors also, which are like playing a havoc when it comes to the mitochondrial dysfunction also. So doctor, what could be the other related factors which are not pertaining as such to the brain, but coming from the different areas of the body, or maybe externally from the other environmental factors?
Okay, this is another important question because these neurodegenerative disorders, Alzheimer's, Parkinson's, ALS, so on, we see the neurological symptoms in them. So the problems with thinking, the problems with movement, and so on. But in fact, they are whole body disorders. It's just that they affect the brain the most, probably because its mitochondria are the most necessary for energy functions, because the neurons in the brain require more energy than basically any other cell. So they get hit the hardest. But the whole body is affected. So we call this we call these things actually systemic disorders, if you want to look at them properly. They're not just neurological disorders. And so how does this all start? Well, nobody knows is the answer. However, I do think that it starts with the mitochondria throughout the body. And there are many things that can lead to damage in these mitochondria. They can compensate and adjust in many different ways. They're fascinating organelles, but there are many things that can damage them. And there are a lot of things that are probably associated with our current lifestyle. So one thing would be industrial toxins, for example, heavy metals, which are found in a lot of products. They used to be found in gasoline and things like that. They're in cleaning agents. They're in a little bit of everything, really. We get exposed to small amounts of these all the time. Another thing would be air pollutants. Another thing would be pesticides and herbicides, which are often used in agriculture, of course, and so on. So there are a lot of these chemicals around that we know damage mitochondria that we wouldn't have had this exposure to even 500 years ago. Another thing that's associated with our lifestyle, though, and I think it's arguably the biggest one, to be honest, is the dietary lifestyle. A lot of people focus on the diet itself. My main focus, I think the most abnormal thing about our lifestyle is that we eat too many meals a day. If you go back to all cultures and all major religions, fasting was a key part of those cultures and religions for good reason. And if you go before culture, so like the last few 100,000 years, which is a lot longer length of time than the agricultural era, we would have never had 3 meals a day as a regular thing. We would have been forced to go without food at times when there was a drought or food was not available. So our body got used to and needs fasting. That's the main problem with the dietary lifestyle. The other one, of course, is too many processed and ultra-processed foods, of which carbohydrates have been affected the most heavily. And because carbohydrates are sugary and sweet, we've made them that way through the processing. Most people eat far too many carbohydrates. So it's too many meals a day and too many processed carbohydrates. Other than that, other things associated with our modern lifestyle, which I'll just broadly mention, are things like we don't exercise as efficiently, and we don't actually know how to recover from exercise very well. We're often very stressed at work, and we don't know how to really get stress-free very well. We often have abnormal social lifestyles. A lot of it is online. This conference is a great example of something that's good about being online. However, there are many negative aspects of being online with the social media and all these things too. And so we don't have enough breaks from the screen and so on. And all these things, I think, injure the mitochondria to some degree, the toxins and dietary lifestyle the most, but all these other things do too. And you put it together, there's like dozens and dozens of things that can damage the mitochondria. If you do this for long enough, over decades, I think this is the perfect breeding ground for a neurodegenerative disorder and other disorders of modern lifestyle to arise.
Thank you. Thank you for explaining so nicely. I think this is a crucial factor which all of us are facing.
Yes.
So whether we are aware or not, this is still going to affect most of us. It is just difficult to stay away from all this. So maybe we need to incorporate some practices really. The best thing we can do is to stay with real food and practice fasting. So these are two very important tools which can be possibly done easily. Then let us say staying away from social media or screen, which is practically difficult to say. Now, coming back to the specific condition like Parkinson's disease. Parkinson's disease seems to be on rise in India. In fact, the experts say that there will be a 200 to 300% increase in the prevalences in the next few years. Currently, probably it is something like 300, 400 people per 100,000 are actually facing Parkinson's disease. How successful are the medications of Parkinson's disease? Does it keep worsening? And what are the other options? The 3 questions. What are the options available as for the medications? Are they successful?
Okay, so there are several medication options for Parkinson's disease. The best one by far is levodopa, which comes in different formulations that allow it to be delivered to the brain. So levodopa is the main one that people use, and it is the single best tool for the job. And it can work well in Parkinson's for a while. For 5 to 10 years, you get a honeymoon period whereby things are going pretty well, and then there is a decline. Other medications that can be used, there are many of them. There are dopamine agonists, which in New Zealand would be called, pramipexole, would be the most common one probably. And then there are other ones, other classes of drugs you can use. So MAOI inhibitors and COMT inhibitors and all these other medications, amantadine. There are a number of medications. With reference to the second part of your question, none of these medications slow down the process that is Parkinson's. So whether Parkinson's is a ongoing mitochondrial damage process that leads to slow withering and dying of neurons and other cells, or whether it's some other process, it doesn't matter. The medications don't actually treat the core process. They mask the symptoms of that process. So the medications are there to try and help people feel better, look better, move better for a while, but none of them actually heal or cure. They mask. That's hugely important because that is modern medicine, Western medicine in a nutshell. Medicine aims to mask symptoms, which can help you feel better and look and move better, but it doesn't heal the disorder at a fundamental level. So that's, again, my interest in the metabolic therapies, is that I think they have the potential to do that. And I'm not against using medications plus metabolic therapies to try and get the best of both worlds.
Thank you so much, Doctor, about the pharma drugs as such, which are there for treating Parkinson's. Now, if we talk about the dietary aspect, if we talk about the ketogenic diets or the fasting protocol for patients who are suffering from Parkinson's, how do we, I understand that when we change the metabolic shift from glucose to ketones as a source of energy, when we shift, the mitochondrial dysfunction is going to be taken care of, it is going to alleviate the symptoms. But my concern is how the dopamine levels can be increased when we are getting into the dietary intervention. Still, the patient needs to be on the drugs for increasing the dopamine levels.
Yeah, so I think with the metabolic therapies, we have to remember that the evidence is still very, it's still growing. So there have been several clinical trials last I checked, that are showing encouraging results for ketogenic diets, in particular in Parkinson's in people. There are none that have really looked at fasting. But the idea is that you're not going to get better right away with a metabolic therapy. A medication can make you feel better very quickly, within a few hours, within a few days, such as levodopa. But metabolic therapies don't work that way. What they do is they actually can make things a bit more difficult for your body and brain in the first few weeks, because it's a major dietary lifestyle change. Your body has to get used to the fasting again. It has to get used to a ketogenic diet, which is high in fat and low in carb again. Even though these are ancestral therapies, our modern lifestyle has made us, I'm going to use the word, addicted to a modern dietary lifestyle. And you have to think of it as breaking an addiction, and it doesn't happen right away. You're breaking your too many meals a day addiction and your high processed carb, i.e. sugar addiction. And that's going to take a few weeks, and it could be a bit painful. So it's normal when people start these therapies, particularly with Parkinson's, to get worse for a little while, a few weeks. And the key is you have to try and understand that what they're trying to do is make you better in the long term, but short term, it could be harder. Medications are the reverse. They make you better in the short term, but in the long term, you wait until those side effects arise, they get harder and harder to maintain. So I think it's important that you don't just stop your medications for Parkinson's if you embark on one of these therapies, and also know that the metabolic therapies haven't got enough evidence to be strongly recommended yet. But, what we have is encouraging. But I would say implement the metabolic therapies with your neurologist, ideally, who's helping you, and use the medications alongside them. And then maybe you can modify the medications in time, depending how well you're doing with the metabolic therapy. And remember, the metabolic therapy is supposed to get easier and easier with time. And after 6 months or so, it should be to the point where you cannot conceive of going back to your old dietary lifestyle. If you have done that, you have succeeded. So if you still think it's hard at 6 months to do a fasting protocol every day or a ketogenic diet, if your brain still thinks it's hard, you haven't done something correctly. And that needs to be addressed.
How about, I've been reading something about the other therapies, like let us say high dose thiamine. What is it? I mean, does it really work? I don't see much studies on this, though there are random case studies.
Yeah, I think there's some case studies, and there's a clinical trial or two out there. But I guess the theory behind thiamine is it's a vitamin B1, and it has a number of targets in the body. A lot of them are, so it helps enzymes function better in mitochondria, actually. So I'm a fan of thiamine from that standpoint. The problem is we don't have really good evidence for it, as you say. But also, I guess it's still just one piece of a greater orchestra. And although it helps the mitochondria at the time, if you're taking it every day, it's kind of like another medication. It's something that's sort of, it might be targeting the body at a more fundamental level, right at the mitochondria, but it's not actually helping the mitochondria get more resilient and become better inherently. So whereas a fasting ketogenic diet protocol forces the mitochondria to up its game, and it forces the mitochondria to repair themselves, allows them to repair themselves and so on, I think at a much deeper level. And a fasting ketogenic diet protocol affects so many more things. So I'm not against thiamine at all. I think there's some good theory out there behind it. Do I think it's going to be the crucial factor that can stabilize or reverse Parkinson's? No, I don't. However, I'm open to that possibility if I saw more evidence. So I'll leave it there with thiamine.
I think I just see that as a possible add-on to the fasting and ketogenic way.
Yes.
How about, I do see a few videos on stationary cycling. Does it really help improve the motor coordination? How is it? They say that Parkinson's, yeah.
Yes, it would. I mean, there are many different exercise therapies that have really good randomized controlled trial evidence, which is one of the best forms of evidence, if not the best, in Parkinson's. So stationary cycling is just one of them. Also, some of the ones with the best evidence would be like boxing, like sort of shadow boxing training sessions, strength and balance protocols, dancing programs, Tai Chi has very good evidence for it. Strength-based protocols, resistance training has a lot of good evidence, and so on. So there's basically, if you dedicate yourself to, I'm going to say almost any kind of solid exercise program, it's going to benefit your Parkinson's. And since the exercise, if you do it properly, is one of the it can be seen as a metabolic therapy in of itself that aims to help mitochondria become more resilient and restore themselves. This probably has a effect on the disorder at a very fundamental level. So I'm a big fan of exercise protocols in people with Parkinson's, and I advocate for them with virtually every single person I see in my own clinic.
Very, very important. I think it's very important information you are given. I think many of us are not aware much about this. Fine. Now coming to the other condition is ALS. In fact, it is said that maybe every 5% in 100,000 in India may be affected by this. Maybe the prevalence may not be big, but then there are a lot of complications, and we see a lot of morbidity, mortality in such people. So what is it about ALS? Do we have any good drugs which works for it? And how good is ketogenic diet in this aspect?
ALS, or motor neuron disease, is a very difficult disorder. And there are different kinds of motor neuron disease. ALS is basically the worst kind. And there are different versions of ALS too, depending where it starts in your body. We don't have any good treatments for it. We have one drug called Riluzole that on average gives you maybe 2 or 3 months, and it has a lot of side effects in a lot of people. So many people don't want to take it or continue taking it. That's all we got. Other than that, everything is supportive. So we don't even have a levodopa for ALS. A levodopa in Parkinson's is actually really good for a few years. We don't have anything even remotely like that in ALS. And of course, we have nothing that can slow down the ALS process. So in terms of ketogenic diet, fasting protocols, and so on, there is encouraging evidence in animal studies, mice and rodents, that suggests that this process can be mitigated or slowed down with these approaches. However, in humans, there's only one case report. That's it. And it's one we published 3 months ago of an intervention that was a fasting and ketogenic diet protocol in a man with bulbar onset ALS, the worst kind of ALS. and he is doing very well. His condition, as far as we can tell, has stabilized, and he was definitely declining before the intervention. And all he's doing is a 2-meal-a-day ketogenic diet. So he eats 2 meals a day. He has 1 hour to eat each meal. He picks the time of day to eat the meal. The other 22 hours of the day, he is fasting. So water, tea, a little bit of black coffee, that's it. And he's been doing that very consistently now for well over 2 years, coming up on 2.5 years, and he's doing well. And there seem to be many benefits on him with respect to mood, weight, cognition, breathing, which is a huge one, because breathing is ultimately what kills a person with ALS, breathing problems, and so on. So he seems to be deriving benefits. So I think the evidence is too weak to strongly recommend it. However, what we do have is very encouraging so far.
That's an amazing anecdote, yeah.
So in this particular case, have you seen the disease worsening, or is it stable?
I would say it's stable. So we assessed this man. His diagnosis, as is usually the case in ALS, was delayed by about almost 2 years. And, it's insidious. It creeps up on you. And often the person in the GP doesn't even know what's happening for the first year or two. So, and by the time he got referred to us and all the diagnostics happened and we confirmed ALS, he was at about 20 months or something from the start of the symptoms. So after that 20 months, he had declined a lot, and he had lost 10 kilograms of weight because ALS attacks not just your brain, but also your muscles. So your muscles waste away. We implemented the fasting ketogenic diet protocol, and he's been doing that for over 2 years. We measured him every 6 months for 18 months. During that 18 months, he improved or stabilized in almost all indices. You can see the paper. It's at our website, metabolicneurologist.com, if you want to go there and click on the paper. And he basically stabilized or improved in, I'd say, 90% of the things we measure with respect to ALS. Now, stabilization alone is impressive because the usual natural course of ALS is relentless decline month by month. You lose function, you lose strength, you lose weight, you lose a lot of things with this disorder. And he stabilized or improved in the vast majority of them. And so I guess there were so many things that we measured. If you want to go have a look at that, I would go to the paper and read it because it was all fairly laid out in a couple of tables.
Right, doctor. Coming to another serious problem, and I'll share certain statistics from India also, and that's Huntington's disease. Talking about specifically India, there are researchers at the National Institute of Mental Health estimate that 3 to 5 people per lakh in India have Huntington's disease, which almost translates to about approximately 40 to 70,000 people in the country. I think this is similar to the prevalence rate in the European populations. Doctor, we just wanted to seek your advice when it comes particularly to the Huntington's disease, how severe it is and what are the treatment options available? And B, what is the role of ketogenic diet when we talk about the dietary intervention?
Well, given those numbers, I should move to India and conduct studies on Huntington's there because it sounds like it would be easier to get people recruited. Okay, Huntington's is these are all severe disorders that we're discussing. These are the worst disorders one can get among the top 10, things like Alzheimer's, ALS, Huntington's. So they're so difficult. So Huntington's is 3 things. It's a neurodegenerative disorder that affects certain parts of the brain the most, but affects the whole body, of course. So it wastes away the muscles as well and hurts the heart and so on, which is a muscle. But it mainly manifests as a movement problem. So they get these extra movements that they can't control. We call them chorea, most of them, but there are other movements that can occur with the chorea. The second thing is it's a cognitive disorder. So you can develop cognitive thinking problems, which can culminate in a dementia process, like significant thinking problems. But the third thing is the most difficult aspect of Huntington's, and that is the neuropsychiatric problems. They get behavioral and mood disturbances that are significant. Things like excessive anger, excessive irritability, excessive apathy, depression, anxiety. And when you put all these neuropsychiatric things together, it is very difficult, not just on the person, but on the family and their friends. And they have very difficult time controlling these things. So it's, you know, Huntington's is a problematic disorder. And yes, again, the evidence is similar to ALS. There's a number of encouraging animal studies in Huntington's. There's only one case report of a person with Huntington's starting a fasting ketogenic diet protocol. We also did that one. It was published about a year ago now. And maybe a year and a half ago. And he did a very similar protocol to our ALS guy. And he showed improvements too over a 1-year period. We only measured him for 1 year before we published that one.
Very interesting. So we can just, just briefly touch upon, though the topic is very vast, the dementia and brain stroke aspect. So how far are these metabolic therapies useful in dementia and possibly in brain stroke?
Okay, so dementia is actually not a disease or disorder. Dementia is like a constellation of symptoms. So it's like saying dementia means you have a thinking problem or a cognitive problem, and it doesn't tell you what the cause of it is. Now, in most countries today, the number one cause is Alzheimer's, probably followed by vascular dementia, which is many different strokes over time causing the dementia. And you can get a mixed picture of Alzheimer's plus vascular dementia too. That's quite common. So again, if you want to ask how does ketogenic metabolic therapy work in dementia, you probably should look at Alzheimer's disease. And there are several decent trials. I think there were 4 of those out now, 4 or 5. And we contributed a randomized crossover trial as one of those a few years ago that showed that there's encouraging evidence to suggest that a ketogenic diet protocol can help Alzheimer's disease. They didn't look at we haven't looked at fasting heart very much yet. Nobody has, to my knowledge. So that's good. In terms of brain stem strokes, stroke is a disorder where usually a clot forms in the body, usually in the heart or in a blood vessel in the neck, and the clot breaks off the wall of the blood vessel, or it breaks out of the heart and goes up to the brain and blocks an artery there, and then whatever part of the brain was being fed by the artery dies off, and that's a stroke. It can be the brain stem in the back of the brain, but it can also be any other part of the brain. And really, when it comes to stroke, the core disease process is nothing to do with the brain. The brain is a victim of the disease in the artery or the disease in the heart. And so it's an important thing to be clear about when you're talking about stroke. Now, I don't know of any studies in people that have used fasting or ketogenic diet protocols in stroke. There is some animal evidence showing that if you have an animal, a mouse again, that's fasted and in ketosis before they are purposely given a stroke, they repair much better, and the stroke is much smaller than if they are not fasted when they have the stroke. So that suggests that fasting at least is protective in animals, and by analogy might be protective in people too. But the evidence is very weak with respect to stroke.
Doctor, just to tell you that I'm a researcher in the field of nutrition sciences, and I'm writing the textbook for the organization, and we mostly talk about the low carb and performance part. But when it comes to my private client, it not only includes the performance, but it's also the metabolic disorders and how the dietary intervention can have the remission effect on these metabolic disorders. So one of the questions pertaining out of the curiosity, because we talk so much about nutrition and the related health and the performance part, can the unrecognized B12 deficiency be mistakenly diagnosed as MS, PD, or AD for that matter? Do you think that there could be a disconnect? It's actually the B12 and people think that it's something which is on a larger scale?
Yes, a B12 deficiency is a great mimic of many disorders. So you get lesions in the brain or spinal cord, and you get a number of different symptoms and signs that could be confused with multiple sclerosis or perhaps Parkinson's and so on. This is a fairly easy thing to diagnose, though, if you measure the B12 levels and you talk to a person about their diet, because B12 deficiency usually occurs in the context of a vegan or vegetarian diet, where the person is not supplementing their B12 properly. And, if you have MRI imaging, so you can scan the brain or the cord, then you can usually tell between B12 problem and multiple sclerosis plaque or whatever as well. So I think a good neurologist should be able to tell the difference between a B12 deficiency and one of these neurodegenerative disorders or multiple sclerosis. And fortunately, B12 deficiency has a more straightforward treatment pathway, i.e. you have to figure out how to get this vitamin back into your body and brain.
Very interesting. I think, see, we have a neurologist in India, Dr. Sudhir Kumar. We often see him in Twitter. He keeps posting such case studies that people come with odd neurological symptoms, which they have been sent by the other doctors. And he found just by measuring B12 and supplementing, most of the issues get resolved. It could be something like tremor or something, borderline anxiety and various
Where
other.
does he work? Which hospital?
Oh, I don't recall. He's there in Hyderabad.
Okay.
So
okay, yeah, I worked in I was in Vellore Hospital for 2 months many years ago. So yeah, I wouldn't be surprised if there's a lot of people B12 deficient in India, because the vegetarian diet is very common, and that diet can be done very well. However, it's more difficult to do well than a carnivore diet, because you have to make sure you get certain things. B12 and zinc are both very critical things to get on a vegetarian diet, and if you don't know what you're doing, this can cause problems very easily, and I've seen it several times. So if I have a vegetarian in clinic who has funny neurological symptoms, I will absolutely measure their B12, their zinc levels, and a few other things to boot, just to be sure they're getting all the vitamins and minerals.
So, Dr. Matt, so can we just talk very briefly, which are the how many studies have you published? Just touch upon very, very briefly in few minutes.
Yeah. So in terms of the metabolic, not many is the answer, but I'd rather put a lot of energy into each and every study and get, one good study every couple of years than publish 10 a year. That's my approach. But in terms of the metabolic studies, maybe a dozen. And most of those, though, would be clinical trials or case studies, things that involve patients, and we implemented some kind of metabolic program. So as you mentioned at the start, we did the world's first randomized controlled trial of a ketogenic diet in Parkinson's. We did the world's first randomized trial of a ketogenic diet in Alzheimer's, where all the patients had Alzheimer's and there was no other condition in there. We did the world's first case studies of Huntington, ketogenic diet and fasting protocol on Huntington's and ALS. We've implemented the most intensive fasting and ketogenic diet protocols in people with glioblastoma. So we published a case series on that a couple of years ago, and yeah, and then there's a clinical trial ongoing right now that we've had 17 people enrolled in so far that is using that, and that's probably the strongest metabolic therapy program that's ever been implemented in any condition, actually ever, to my knowledge. I don't think I've ever seen any stronger protocol than what those guys are doing. And then I guess there are theoretical and review papers. I've published a few of those, not too many. The one that probably sums it up the best and sums up a lot of our work too is one called Metabolic Strategies in Healthcare, A New Era, where I basically try to tie together mitochondrial problems as the core disease process in heart disease, neurodegenerative disorders, and cancer, all the big lifestyle-related disorders, and of course, type 2 diabetes, which is very common. And I tie mitochondria dysfunction or mitochondrial problems into those disorders. And then I talk about what the best approach to this might be, which of course is a big discussion on all the fasting and ketogenic diet evidence in humans. I don't mention animals in that paper. And I basically advocate for a new sort of way of looking at medicine where these things are the first thing we should try. And of course, they're the thing we should do for prevention of all these disorders before we even get them. And then medications can still be used, but they should be used ideally temporarily. and for what they're supposed to do, which is mask symptoms. We should not pretend to patients that they are going to cure their disorder, their disease in any way. And we should be honest and say, look, these can help for a while, but the main game has to be something else that changes the disorder at its core, at a fundamental level. And that paper would be worth a read if you just want to see a broad brushstroke of my whole conception and where I think the research needs to go. It would be that Metabolic Strategies in Healthcare, a New Era paper.
Such an incredible thing to give some hope to your patients, doctor. That is really, really very, very recommendable. And especially to not only brain cancer, but the other neurological disorders as well. If we have to talk about the targeted cellular repair or the TCR and fasting in cancer, would you like to shed some light on that, doctor?
What's TCR?
It's the targeted cellular repair, which we understand.
Oh, okay. Well, the thing about these protocols, fasting, ketogenic diets, and so on, is there's so many targets. It's like I liken it to an orchestra. So there are many different instruments all being put together, and the body is the conductor that determines where the instruments need to go. So the idea is to change your whole body's metabolism into a state where it is less likely to promote neurodegeneration, is less likely to promote cancer, for the reason that you have made things nicer for your mitochondria. You're making them, not only forcing them to improve themselves more, but you're also giving them good rest periods, particularly with the fast, whereby they are allowed to do that, to improve themselves and restore themselves through processes that give rise to new mitochondria and get rid of old ones. So these are not really targeted therapies in the traditional sense. They are systemic therapies. They are multi-system therapies. They are designed to address multi-system disorders, which are the big ones that are killing most people today: the diabetes, the Alzheimer's, the cancer, the Parkinson's, the atherosclerosis in arteries, and so on.
I wanted to ask one question, that you have published quite a number of case studies. You may say it is not much, but we think it is quite substantial, because each case study ultimately gives a ray of hope, and possibly one day a large scale trial can be done. Everything starts with a case study. Did you face any pushback or criticism for applying these unknown therapies?
Yes is the answer. I did. However, at my hospital, Waikato Hospital, I've been here a few years now, and most people know me, and I guess there were initially a number of skeptics, but a lot of those people have changed their minds, I think, and there might be a few skeptics still out there. So there's always a bit of pushback, but I guess the trick is to make it a silent pushback and not to aggravate anybody outright. If someone is, I don't think I've seen anyone yet who's just violently opposed to what we're trying to do. And I think it's just focusing on the process, focusing on the constructive aspects of it, trying not to make enemies, and just being patient and not trying to push things too fast. That's the key element. But what really keeps me going, I got to say, is the patients. The patients love these therapies. The patients are very supportive. And of course, as you said, it is giving them a bit of hope, but I'm always realistic. What I try to do, and I've said this before, is I try to give them some hope, but also a plan. Hope on its own is not good. It's damaging and terrible, because if you have hope, but you don't know, if you just live on hope, you're going to, hope is not a strategy. But if you have a plan and it doesn't give you any hope, that's just as bad too, because why would you, what's the point of following a plan where there's no hope? And I've seen a number of my colleagues, unfortunately, sort of lean towards that strategy. So I think a bit of hope, realistic hope, combined with a plan that is implementable and ideally empowers the person with the disorder to adopt their own healing pathway themselves to a degree. That's the best thing, and that's what I'm trying to do here. So the patients are really awesome and help keep me going with these things.
Great. So, Dr. Matthew, what is your message to India?
Oh, my message to India. Well, I learned a lot in India as a medical student when I went over there and did some time there. So I want to thank India for that, and particularly Dr. Dilip Mathai of Vellore Hospital, if he's if he's still working. He probably is. So I guess my message to India would be look further back than the last few thousand years of your culture. Go back to the hunter-gatherer days and see what your ancestors really evolved on, not just for 5,000 or 10,000 years, but for hundreds of thousands of years. You'll find that meat was essential in that diet. Fasting was essential in that diet. And the fact is, most people were in ketosis most of the time because of the low processed carbohydrate content and the fasting. So I would say two things. Try to implement a daily fasting protocol, whether it's just 2 days, 2 meals a day, 1 meal a day, 16 and 8 or something. And then the second thing is knock down the processed carbohydrates. And I think the biggest targets in India, unfortunately, because they're very yummy, but I wouldn't eat them now. I wouldn't touch them now and haven't for many years. That would be the breads and the rice. Knock those right down. And of course, the sugars. Just remove those three things from your diet. Increase the meat-based dishes and the green vegetables and things like that more, and throw in some fasting. I think that would be the best service you could do to your health, and you will be seeing benefits within a few weeks if you do that.
Thank you, Dr. Matt. Very enlightening, and I think this session is going to make India take an informed decision. Yeah, Shilpi ma'am.
Thank you so much, Doctor. It was such a pleasure to have a conversation with you, and at the same time, we have those valuable insights which we were looking for. Thanks a lot, sir.
I'll just call in Anup Singh for a few seconds. Can you get Anup Singh in? So Anup Singh is the co-organizer of this conference. Anup, you're there? Okay, he may not be there. Must have been one or somewhere. The next in line is Dr. Don. You know him from Philippines. He's also a neurologist. Please get Dr. Don in and Prasanna in. Dr. Matt, you know Dr. Don very well.
It's the first time, Dr.
Very good. So I'm happy to introduce the next speaker. Dr. Don Akkorpa is a neurologist from Philippines. So maybe you can interact with him later on. So thank you very much. And Prasanna and Dr. Don can now carry on. Thank you.
Thank you.
Welcome. Welcome to India's second Metabolic Health Conference. My name is Prasanna. I am a metabolic health coach and a proud member of DLife.in, India's oldest, biggest, and the only award-winning low-carb platform. Shashikant Iyengar and Anup Singh bring to you this historic and scientific feast from India titled Metabolic Therapies. Let's meet our very special guest for this session, Dr. Don Akkorpa. Let me Welcome, Dr. Don. So let me give a brief introduction to our viewers about Dr. Don. Dr. Don, MD, is a board-certified neurologist and an adherent of therapeutic carbohydrate restriction and reduction, TCR, which is also known as the low carbohydrate healthy fats and ketogenic diet, done in conjunction with or without intermittent fasting for several years for reversal of metabolic syndrome, as well as ketogenic metabolic therapy, KMT, proven to significantly improve many other modern human lifestyle illnesses, including Alzheimer's disease, Parkinson's disease, fatty liver disease, polycystic ovarian syndrome, a number of mental health disorders, as well as certain cancers and malignancies. Dr. Don is the founder of Low Carb Health Doctor, LCHD, a clinic and research center located in northern Mindanao, Philippines. Welcome, Dr. Don, to this conference, and thank you so much for being here. We are really looking forward to this conversation.
Okay, thanks for having me around again in this second conference. I was there during the first India Metabolic Health Conference last year. It's organized by Shazi and Anup, and it's an honor to be here again with you guys to share this advocacy again.
Doctor, let me start by asking you, can you please explain how the ketogenic way of eating works in the context of treating neurological disorders? Can you just give a brief about being a neurologist? How did you get thinking and advocating and seeing the science behind the ketogenic way of eating?
As I always share it to everyone, not just my patients, I got into this low carbohydrate and ketogenic diet space, and specifically the ketogenic metabolic therapy space, because of my own personal and subsequently my clinical experience with my own set of patients. When I say it's both a personal and clinical approach, in my case, that goes back to the fact that, like, for the past 1 to 2 decades, I myself have actually developed metabolic syndrome. And that's why, as I have shared in my platform several times, for quite a very long time, I've been doing an almost perfectly vegetarian kind of diet. Eat mostly fruits and vegetables for so long, because that's what has been told to us, including me, during my earlier elementary and secondary school days, that carbohydrates are really important, supposedly and allegedly, for maintaining our energy levels and all that. So that's what I've been doing. And especially since I being a physician and I being the son of a physician, my father was a physician, was a doctor here in the Philippines. He was a family medicine physician. So he had his first heart attack at age of 52. And then he had, I think, 1 or 2 more heart attacks. And then the last myocardial infarction or heart attack that he had was at the age of 62, which was really fatal. And that incident really left an indelible mark in me, because I wouldn't like to follow his footsteps along that direction, to have a massive heart attack and succumbing out of it. So because of that, I did my best to really follow a supposedly healthy diet. And based on what I know and what has been taught to us in medical school and in our local and international conferences, supposedly the healthiest diet would be eating fruits and vegetables, the vegetarian, vegan way, etc., plant-based diet. So I did that, but surprisingly, I was gaining weight gradually through the years, and by about 3-4 years ago, I realized that when I was checking my laboratory workup, laboratory parameters, it looks like I had already developed metabolic syndrome based on the 5 criteria of metabolic syndrome. I gained weight. My waistline was already beyond what was the normal waistline. I was already pre-diabetic. That means my fasting blood sugar was beyond 100. And then I had developed hypertension, because by that time I was repeatedly having blood pressure readings of about 140 over 90 to 100. Then my triglyceride levels in my laboratory was high, and my HDL cholesterol, which is supposed to be the good kind of cholesterol, was way below the cap. So technically, I was almost a perfect score in metabolic syndrome, and that's how I got to ask around my fellow doctors, my fellow cardiologists and endocrinologists, diabetes specialists, if what I was doing was correct, because based on my own analysis and based on what I've learned through medical school and in our conferences every year, it seems like I've been doing the right thing. My diet was okay, but then I wouldn't like to start medications, because that's the main reason why I was doing my best to stick to a supposedly proper diet, because I wouldn't like to start medications, because medications are xenobiotics. They are not a normal and natural part of our body. But then when I was asking my friends, cardiologists, endocrinologists, internal medicine specialists, they said that I should already be starting on preventive medications, including statins, for example, hypertension medications, because that's what the guidelines accordingly are saying. And I knew based on the guidelines I should be doing that, but I was half-hearted in doing that because I really don't like to start medications. So I did. I dug. I went back to research because right now it would be much easier because of internet these days. And I went through all the research, what's available in the literature, and surprise of all surprise, I realized that there have been a lot of research articles that have not really been taught to us in medical school and have not been presented to our conferences, especially in terms of dietary modifications in relation to the low carbohydrate diet and how the low carbohydrate diet is the one that's really technically superior as compared to the low fat diet, especially in addressing the reversal of metabolic syndrome. So after unlearning and rethinking all that, I did give it a try, a bit skeptically at first, because I wouldn't like to have a heart attack like my father, because accordingly, if you eat more meat and more fats, you're supposed to have hypertension, heart attack. So when I started my low carbohydrate approach, using myself as my guinea pig, I did it initially skeptically, but then later on, I realized that everything that I read in the research papers were really true. And in 1 week's time, my hypertension normalized from 140 to 100. It became 100 to 110 over 60 to 70. And succeedingly, after 2 to 3 months of starting diligently the low carbohydrate approach, I reversed my metabolic syndrome. So essentially, that's how it all started. I applied it to my patients. That's why I'm saying personal and then clinical. I applied it to my patients, and essentially, I duplicated what I did to myself to my own set of neurology patients. So, like, I'd say it's a 100% effective. Yeah? Because for all those patients.
Okay. Yeah, please go ahead. It's all those things. That's what you said.
For all my patients who have diligently and with discipline applied the low carbohydrate diet or the ketogenic diet, I'd say it's 100% successful. The only thing that differs is the level of success. Some who are not as very diligent would have only limited improvement, but for those who really applied it diligently and with discipline, I really see repeatedly very, very significant improvement in terms of reversing metabolic syndrome, as well as certain neurologic diseases that are due to neurodegenerative conditions.
Okay. Thanks for sharing that. And so in the context of, let me move to the next question. In the context of treating and acting as a therapy for the neurological illnesses, such as Parkinson's or Alzheimer's, how effective is the, have you found out these ketogenic way of lifestyle and eating? And as small segue into that is, people usually, there is a conception that low carb and ketogenic is the same. I would like to hear from you. Is it same? Or is it a little bit, there is some difference to it?
Okay, so when we are talking about low carbohydrate diets, so there are different levels of approaching the low carbohydrate. So like, let's say, have you heard of the Mediterranean diet, for example? Mediterranean.
Yes.
And
Yes.
paleo diet. So in my opinion, these are already low carbohydrate diets. So like, for example, Mediterranean, it's not really very definite how you define a Mediterranean diet. But then in my own opinion and analysis, the Mediterranean diet works wonders because it is a low carbohydrate kind of diet as compared to the standard worldwide diet, standard American, standard Indian, standard Philippine diet, standard Australian diet, but whichever. So when we say low carbohydrate diet, it may be just a moderately low carbohydrate diet. So like, let's say if you ordinarily, the entire world, most of us have been used to eating like as much as 50 to 60 to 70% carbohydrate by caloric level already for the past several decades because of the guidelines. So when we say that it's like 60% carbohydrate, it would be not surprising if most people would be consuming as much as, for example, 300 grams of carbohydrates per day. But then if you do something to lower that to, for example, just 100 to 150 grams, for example, that would be, you can technically already call that some sort of a low carbohydrate diet. But for me, it would not be enough, especially when we talk about ketogenic levels of low carbohydrate diet. Because when we embark on the ketogenic metabolic therapy or ketogenic diet approach, the main issue here is that we need to lower down the carbohydrate consumption to very, very low levels, to as much as, like, let's say, less than 50 grams carbohydrates per day, because the primary intention would be for us to generate ketone bodies in the liver, specifically beta hydroxybutyrate, acetoacetate, those kinds of ketone bodies. Because when we talk about ketogenic diet, which we can also call ketogenic metabolic way of addressing these conditions, including neurodegenerative conditions, then our main purpose, as I mentioned earlier, would be the production of these ketone bodies, because not just lowering down the carbohydrates, because these ketone bodies, based on studies, even way back to the early 1920s, these ketone bodies have been significant in helping many brain conditions. And then first and foremost, I would like to emphasize epilepsy or seizures, or recurrent seizures, epilepsy or seizure disorder, because in the Mayo Clinic, they have already have documented that since the early 1900s, in terms of really doing something significant to control, especially those epilepsies that are hard to control. So the first important indication for the ketogenic diet, based on our neurology, would be intervening epilepsies. So because of these ketone bodies that are supplying the brain as fuel in lieu of glucose, for example. So I think the main issue here is, when it comes to ketogenic diets, our focus would be the production of these ketone bodies to be an alternate fuel for the brain. When we are in a state of nutritional ketosis, then our brain mostly runs on these ketone bodies instead of glucose, and that's where the significance lies.
Okay.
The replacement of glucose with ketone bodies for the neurons.
Okay. Understood. So just to state that you said it is early 1900s. This was significant literature is there, is it?
Yeah.
Okay. So I just wanted to point out that this has been there almost 100 years. So thanks. And I believe you have some information to share. So with a little bit more of scientific studies and data backing the ketogenic diet efficacy, right? So would you please share with us? We have about 20 minutes with us, 20 to 25 minutes. So
Okay.
I would request you to please share your screen so that we can go. You can present that, please.
Okay. So hold on a bit. Are you seeing my screen?
Yes, yes, it is visible.
cannot run my slides. There you are. So this is the slides were part of my usual presentation before in terms of low carb for the brain. So I'll just show to your audience some important things. So this one, as we were talking earlier, metabolic syndrome. So metabolic syndrome in my specific advocacy, why I as a neurologist have been really passionate about doing the low carbohydrate diet for my patients and ketogenic, especially ketogenic therapies for my patients. My main advocacy is focusing on the reversal of metabolic syndrome, because metabolic syndrome, which is, I think, many of your presenters in the past 2 3 days have already mentioned metabolic syndrome and insulin resistance. So these conditions here, like heart disease, lipid problems, specifically hypertriglyceridemia or elevation of your triglyceride levels, hypertension, type 2 diabetes, dementia being a neurodegenerative disease, including also cancers like, I think Dr. Phillips mentioned something about, for example, gliomas, glioblastoma, multiforme earlier. Then polycystic ovarian syndrome, fatty liver disease that is non-alcoholic nature, or what is currently known as metabolic syndrome associated liver disease. So these are significant offshoots of metabolic syndrome, which is primarily due to insulin resistance. So I think we need to talk much about insulin resistance. Many of the presenters have already mentioned this, the development of insulin resistance. The main reason why I emphasize this, because in the World Health Organization, the top 10 causes of death, this was 2020 figure, but it's still the same, not just globally, but I think this also applies to India. And I know this applies here in the Philippines as well. So these are the top 10 causes of deaths worldwide. So you can lump them together into non-communicable and communicable disease. So if you look at these blue lines here, these are non-communicable or non-infectious disease. So top 1 and top 2 causes of death worldwide would be your ischemic heart disease or heart ailments, specifically myocardial infarction, or what may be colloquially or in lay person's term, heart attacks, then stroke or brain attacks. Then more interesting to note would be, like, for example, Alzheimer's disease and its complications, which is a neurologic condition, and other dementias. Then you have number 9, diabetes, and number 10, kidney diseases. So most of these kidney diseases are complications of elevated blood pressure, hypertension, and diabetes also. So nephropathies or nephrosclerosis. So if you look at this closely, these are actually offshoots or complications of insulin resistance or metabolic syndrome. So technically, just looking at this slide itself, we know for a fact that the number 1 killer today for most people worldwide, leading to early deaths even in their 30s. Okay, we see more and more people having heart attacks and strokes in their 30s now because of metabolic syndrome. So technically, I would say, and I would claim, metabolic syndrome is the number 1 killer in the world today, not just Indians. Okay, so here, these are the corollary to metabolic syndrome. We're talking about the brain in this session, neurology, neuroscience. So I have a list here of illnesses, mostly degenerative diseases like Alzheimer's, Parkinson's, and multiple sclerosis. And as we have talked earlier, also potentially ALS or amyotrophic lateral sclerosis being a neurodegenerative disease to be impacted heavily with ketogenic metabolic therapies. So would you like to go into certain specifics?
Yes, please.
Rosanna?
Yeah. So with respect to the Parkinson's disease and the Alzheimer's disease and the epilepsy, which are all the neurological illnesses. So what is the mechanism of action? Can you please, see, people usually have the idea that neurological diseases can be treated, whatever we call as conventional medicines, right? So when we are talking about a way of eating or a diet, how does a way of eating affect and improve or give respite to people suffering from these illnesses? And of course, these are proven data, right? That's what you are sharing. So can you please throw some light on that?
Okay, so I was also listening to, in part, to Dr. Phillips' presentation earlier, him being a neurologist as well. So I think Dr. Phillips also extensively mentioned a lot about this being neurodegenerative illnesses. And then, have you heard of type 3 diabetes mellitus? Have you heard of that?
Yes, I have heard, but I believe many of our viewers might be new.
Okay, because when I talk about type 3 diabetes to my colleagues also, even in neurology, most of them haven't heard of that concept. Then even globally known researchers in Alzheimer's, for example, like those based in the US, for example, in significant centers researching on Alzheimer's. And I was asking them about the relationship of Alzheimer's with insulin resistance. Many of them really deny that, that, let's say, evidence-based fact so far. So it is becoming more and more, let's say, evident. There are many researchers already doing research along this line. So if you Google type 3 diabetes mellitus, for instance, so what will come out is like the insulin resistance of the brain. So in my honest opinion, these neurodegenerative diseases actually impacted a lot by the development of insulin resistance in the neurons, or what may be otherwise called brain insulin resistance. So I think the primary mechanism why, for example, based on what, going back to your earlier query with regards to ketogenic metabolic therapies, and how are they potentially and seemingly, and based on more and more evidence nowadays, how are they improving the brain, is because of this concept of brain insulin resistance. And there have been, as I said, many research articles coming out on that already. So when the brain is becoming insulin resistant, so that means what has been usually taught to us, that our brain runs on glucose, right? That's what is usually being taught to us, including us doctors, so that if we run low on glucose or we have hypoglycemia, then we supposedly will have syncope, or we may pass out, because it's like no more fuel, that is glucose, that's available to the brain. Which is, before, when I was having high carbohydrate diet, I used to repeatedly have that when I am hungry already and my blood sugar goes down. So I tend to have this syncope, like, or I feel like passing out, because my brain is running low on glucose. And I'm sure most people worldwide have that experience as well. So when we apply ketogenic metabolic therapy to the brain, so when the patient or the person doing the low carbohydrate, specifically the ketogenic diet approach, has already become fat adapted, and there are already higher and higher persistent levels of ketone bodies in our bloodstream. So by that time, the brain mostly runs ketone bodies already, and it's not dependent on glucose. So if that patient or that person is increasingly resistant to the effects of insulin in the brain, and thus the glucose is not any more efficient in fueling the brain, and that patient eventually has developed nutritional ketosis, and the brain has learned has relearned rather, because I am of the opinion that for a long time already, we as a human species have really been running ketones, have really been using ketones as primary fuel for our brain for a long time, like eons already. So when the brain relearns the use of ketone bodies to fuel itself, then essentially these manifestations of neurodegeneration somehow alleviated and seemingly improved. Like, for example, I had this dementia patient who has already been on a lot of medications, and he's severely demented, doesn't even identify her name when I was asking her, and was just mumbling a lot of nonsense. And then I placed her on a ketogenic diet, which is really medically guided, because I give them a list of foods to really prioritize, and foods to avoid, especially those that have moderate to high carbohydrate content. So that patient, when she came back to me after, I think, about a month, I was very surprised, really. Those were among my first few dementia patients on ketogenic diet, because about a month after, when she came back to my clinic, she was already able to identify herself and her name. So I don't usually get to see those kinds of patients before. When I was doing the regular neurologic approach, which is drug-based, like let's say Alzheimer's disease, you give them medications that are, like, for example, acetylcholine inhibitors, for example. So like all these kinds of dementia medication. I don't get to see them before, because what I usually tell my patients, because that's also what I have been taught in medical school and as well as in my neurology training, that when it comes to dementia, then the only best thing that we can do is to minimize the progression of the illness. So there is really no such thing as improving the manifestations of dementia when it comes to Alzheimer's dementia, for example. So when I get to see these patients who are technically improving, it's like we have this scoring system for dementia, for example, and then if they're even in the mini mental state examination, for example, before, when I was not using ketogenic metabolic therapies, it's like I really haven't seen a patient improving in the mini mental state examination, status examination, out of 30, out of score of 30. So like, let's say if they have very low score, like just 10 to 15 out of 30, and then they follow up with me being dementia patients, what I usually see is that their scores continuously go down. And perhaps, as what the pharmaceutical industry has been promoting, this decline would be lessened with the medications for dementia. But then it is quite surprising that some patients of mine actually, if not maintaining their previous mini mental state score, they actually improve like 2 or 3 notches or scores higher. Like, for example, that patient was able to identify her name already and can actually follow certain simple commands after about a month or 2 of strict ketogenic diet. So it's almost like, unbelievable times. But when I go back to evidences and research, and I go back to really applying this ketogenic diet in the real world, I see that it is really evidence-based and scientific.
Wow. Thanks for sharing that. And about the success story. And is there any thumb rule? Before going with that, can you please share some of the literature which is already there, research about this, which studies?
Yeah, definitely. So, like, you know, like, in the real world, if you see, like,
Okay, so I made here a list because I was telling you earlier, Prasanna. I do this because I know for a fact that many of my colleagues, physicians, doctors worldwide, are also not very aware about the low carbohydrate approach in terms of the therapeutic carbohydrate restriction, or TCR, to address these illnesses, for example. So that's why I made this list of studies that could give us an idea that there is really evidence in this direction. So, like for example, in epilepsy, as I mentioned to you earlier, so it's like 100 years counting already for ketogenic diet to address epilepsy. So these are studies here, human studies. Okay, so this is, for example, a randomized controlled trial, and we also have meta-analysis and systematic reviews, which is a notch or two higher than randomized controlled trials in terms of evidence. So in terms of epilepsy, ketogenic diet really is a lot of studies already to prove that it works. Okay, so I'll just go through them in passing, so we don't have enough time for that. Then these are the mechanisms for epilepsy.
Okay.
So enhanced energy metabolism. This is in relation to the production of ketone bodies, probably, and in lieu of the brain being dependent to glucose. Okay, anti-inflammatory effects would be important.
Okay.
So in Alzheimer's, we also have this. I proceed.
Yeah. So when people hear ketone, they think fat. Is it okay?
They think, okay, because
Yeah,
when you
ketones
go,
and fat. Is it fine to equate them?
why? What's your number one concern? Heart disease in
No,
relation to
no.
fat?
I'm just trying to see if there is any misconception, or that's it. That's it.
When you go on a ketogenic diet, of course, it would be a high fat diet relative to the standard diet. So the main issue there, especially in my clinical experience, like most people worldwide tend to be averse to eating fats, including animal fats, because what has been, let's say, propagandized to us for so long is that eating animal fats would be not really a healthy idea, because it would lead, for example, the saturated fats would lead to atherosclerosis,
Yeah.
and heart disease, strokes. But then I knowing what I now know, okay, I beg to disagree on that, because there is really no evidence to conclude that eating saturated fats from meat products, for example, would be, to our disadvantage.
Yeah. Thanks for clearing that. And yeah, so I just want to touch upon any thumb rule. Certain millimoles of ketone bodies should stay in the for just a thumb rule for people who are suffering with such and who are considering ketogenic way of eating. Just a thumb rule, what they can consider, what they should consider or aim at. Should they look for it, or any other thumb rules which might help them?
What I usually do with my patients, because when I go towards specifics, like for example, telling them to maintain this level of ketones in the blood, it's like you need to do ketone level monitoring, for example. So like blood ketones, and there is also a way of doing that using urine, the dipstick,
Okay.
the urine dipstick. So it's like it's like getting lost into the details when I tell them to maintain this level because most people would have a hard time really monitoring their ketones that way. So that's why I give them a list of foods that would have very low carbohydrates so that more or less nutritional ketosis would be maintained. So, and then another thing, when we talk about ketosis, many people also confuse it, even doctors, with ketoacidosis. I think your presenters have mentioned that. So nutritional ketosis is far off from ketoacidosis because when we say nutritional ketosis, just like a threshold level for ketosis or just enough to have ketone bodies to fuel your body and the brain. So like let's say perhaps 0.5 to 1 millimole per liter would be sufficient level of nutritional ketosis to as much as 2 to 3, for example, 2 to 3 millimoles per liter. Okay. But then when you do urine dipstick, you can already monitor that. But then I used to do that before, but lately I don't really pay attention much to my urine ketone levels already, as long as I know that I am really eating very low carbohydrate food, because by nature you would really be in nutritional ketosis. That way, if you know which foods to avoid, which foods to stick to when you are doing ketogenic diet.
Okay. And thanks for sharing the various ways of measuring it, and then giving a basic range or thumb rule, which might be useful for some of the listeners. Of course, I think it might be case to case. So the range, thanks for sharing that range. And usually, I just wanted to touch upon other neurodegenerative or neurological diseases such as ALS. Is there any evidence, or what is your thought about that? ALS, treating ALS with ketogenic?
I am not that very much aware yet ALS and in relation to ketogenic metabolic therapies, because for one thing, ALS is here in the Philippines. It's a relatively rare disease. I think Westerners have more of it. Okay, but essentially, when we talk of ALS being a neurodegenerative disease, so the mechanisms would more or less be the same as, for example, other neurodegenerative disease, which is due to damage to neurons, like in Alzheimer's, for example. Then Parkinson's. So these are damage to the neurons that are specifically concerned, for example, with higher cortical function, or in movement control, like in Parkinson's. Okay, so I think if in the way I see it, if ketogenic therapy works relatively well in many cases of dementia and Parkinson's disease, for example, because of the mechanism of insulin resistance of the brain, and ALS being also a neurodegenerative disease of the upper motor and the lower motor neuron. So I think if ketogenic therapy is given to those patients, more or less the same response of the brain will be evident in terms of the alleviation of neurodegeneration. I think Dr. Phillips mentioned some things in relation to ALS earlier. I was to pay much attention.
I got it. So just as a summary message to all your viewers, and what is one thing which you advise for people who are your patients, your patients, which what's the general theme and advice which you'd like to state to patients and the viewers who are considering ketogenic way of eating for treating or for alleviating some of the symptoms or better quality of life?
I primarily advocate low carbohydrate diets for all.
Okay.
Not just my neurologic patients. So some of my patients will ask, is it okay if I give it to my adolescent child or my elementary level child? I am of the opinion similar to Dr. Ken Berry, Dr. Sean Baker, well, Anthony, I think Anthony Shippey
Yes, Anthony
was here. Yeah. I am of a similar opinion to theirs that it is really the proper and ideal human diet, because babies, in the fetus is really in a ketogenic state. So when they are born, when they are breastfed, they are still in a ketogenic state. So that is the most ideal human diet for all. So don't be afraid to try ketogenic diet, and then do it diligently and with proper guidance, so that you are doing it the right way. Because I have many patients who are supposedly doing low carbohydrate diet or ketogenic diet, but then they have mistakes in implementing it because they are not properly guided. So that's where the important thing lies: proper guidance and the proper way of doing it, so that you will really know if it works or not.
Okay. Thank you. Thank you so much for coming over here and sharing all your insights and sharing your summary. So I'd like to invite Shashikant Iyengar. Yeah, here he is.
Can you please please get Anup Singh also inside? Yeah, Dr. Don, thank you very much for coming again in this second Metabolic Health Conference. This last time you spoke on the general low carb perspective, this time from a neurologist perspective, and I think it's going to help India a lot. So thank you very much.
Thank you, Shashi, for having me again, and Anup.
Yeah, thank you,
Nice
Dr.
to see
Don.
you.
I think we are interacting for the third time in all. And
Yeah,
many more interactions to come.
Yeah, we're in this together.
Yeah, for sure.
Thank you. Thank you very much. We'll see you again, Dr. Don.
You're welcome. Thank you.
Thank you.
Please get Craig inside.
Hello.
Hello.
Can you hear me?
Yeah.
All right, great. Thanks for having me
Hi,
on.
Craig. Yes. Hi,
Hi.
Craig. Welcome. Good morning and namaste from India. We are in the second Metabolic Health Conference held from India. The first one was in October 2023. And we are glad you're here, Craig. For our viewers, let me introduce Craig. Craig Emirate is an engineer and has spent the last 15 years researching nutrition and working with thousands of clients alongside his wife, Maria Emirate. He's an international best-selling author of Keto, The Complete Guide, and the Carnivore Cookbook. He uses his knowledge to help clients heal and lose weight, leveraging their biology to make it easy. Craig has helped tens of thousands of people regain their health back and vitality with a strong focus on the deep science of human nutrition. So I welcome Craig, and with me is Anup Singh, the founder of DLife.in, which is India's oldest and the biggest and the only award-winning low-carb platform, which now also has a diploma course in low-carb nutrition and metabolic health, which I guess is the biggest in the world with 60 CPD credit hours. So welcome, Craig. Welcome, Anup, and let's begin this session.
Thank you.
Let me ask you, Craig, begin with a very light-hearted question. Why are engineers increasingly getting into the nutrition and health space and changing it altogether? I have two of you on the screen, in front of me right now. So what do you think is the compelling need for, guys like you to get into the metabolic space, health space increasingly?
Yeah, and there's many in the US as well, in addition to myself, that have gotten into this space and been real influencers in this community. And I think it comes back to how we solve problems and how we look at problems. Engineers look at problems and systems to root out root causes of problems. And I think the human body can be treated a lot the same way. And I think in healthcare today, we don't do that enough. We don't root out root causes as much, especially in America. we put Band-Aids on symptoms so much. We give them a prescription that will help with the symptoms, but doesn't address the root cause. Why is this happening? Why is the body having these problems? Why are you having these symptoms? And when you come back and you peel back and look at the root cause and fix that, most of the time the body will do what it's supposed to do. It will give you the right outputs if you give it the right inputs. And the right inputs are proper diet, exercise, not smoking. It's like a negative input, all these inputs to the body. If you get them wrong, the body gives you bad outputs, it gives you disease, it gives you diabetes, gives you cancer, and these other, bad outputs.
Anup?
Yeah, before I, come to the question, I think I would like to add to Emerit's point of view. Engineers don't have a pamphlet given as guidelines to work with. They are trained to use their brains, and they are very open-minded, because once they get into a new field, they are more inquisitive to learn, experiment, and then see the output, how it helps. Now, coming back to question, same way, why do doctors never ask for diet, what a patient is eating, and what's wrong with the current, I would say, global American diet now, because it's no longer a standard American diet. And who do you think is benefiting from such a crappy diet, which has, pushed entire world into a, I would say, a hole of sickness?
Yeah, I'm sorry, are you asking me?
Yeah. That was the question.
It's a very good question. And who benefits from this status quo, if you will, of the healthcare system? Obviously, pharmaceutical companies do, because you're just pushing more and more Band-Aids, more and more pills to these problems, and you're not addressing the root causes. And on the root cause side, Kraft, Kellogg's, these big companies, they want to keep pushing their products that are hyper palatable. They drive more eating, more hunger. Literally, they have been engineered and designed to make you eat more of them, and that's more profits for them. And so on that side of the things, they don't want it to change either.
So to the first part of the question, why are doctors then not asking their patients to begin with, what are they eating?
I want to add in to that point. And when you said that, it totally triggered a memory of mine with my wife. My wife, Maria, she started down this path over 20 years ago now, 26 years ago. She started eating keto, low carb. And it started when she was going to the doctor for her own health issues. She had PCOS, polycystic ovarian syndrome. She had IBS, acid reflux. She had extra weight that she couldn't get rid of. And she was following all the guidelines, the healthy whole grains and the low fat and all this, and nothing was helping, even running marathons. And she went to the doctor with all these issues, and she was basically told, these are the cards you're dealt. And here's like 3 prescriptions to deal with these issues. The same week, our dog was losing patches of its hair, and we went into the vet, and the first question the vet asked, what are you feeding it? And the doctor never asked her this, not once. And so I think that is, again, back to the core of this problem, is they're not asking what the inputs are, what's maybe the root cause here. They're just slapping, Band-Aids on the symptoms that are resulting.
So Craig, extending that question now, how did you come into low carb and carnivore?
Yeah, so my own journey, obviously with my wife going down this path, it's been a very long time that we've been doing this, and about 4 or 5 years into her own journey for her fixing her own body and researching and studying and figuring out how to do it and finding this method and reversing her PCOS, got rid of her acid reflux, lost the extra weight, even though she stopped running marathons because it was hard on her joints. So she stopped running marathons and just changed her diet, and all of a sudden all the extra weight just fell right off, right? She was almost twice her size that she is now. And everybody was asking, how are you doing this? And so she started coaching people and coaching clients. It took me a little longer because at the time I had no health issues. I didn't have any of the issues she had. So I didn't have the pressing need to change 20 years ago. But about 18, 19 years ago, I finally realized that whenever I ate the food she made me, I felt way better than the other stuff that I would eat on the weekends or whatever. And I just wanted to feel better all the time. And I just transitioned over to eating keto type of lifestyle. And I've been that way ever since, 18, 19 years. It did change a little bit for me when my health did become a problem. I had Lyme disease, which is from a tick bite. That caused some inflammatory response in my body that then resulted in an autoimmune reaction. And at that time, I switched to full carnivore, and that actually improved. So I have a lot of chronic pain as a result of this condition. Going to strict carnivore from keto about 6 years ago really helps control my pain.
So I think we'll come back to your carnivore diet. Anup, would you want to take the next question?
Yeah. So why do you think, despite all the evidences in favor of low carb, keto, carnivore for various ailments, why do you think the system, I call system, which includes, everyone taking, looking into healthcare, are they against this science of, I would call it science of low carb, keto, and carnivore diet?
Yeah, it really depends a bit on, I know lots of doctors in this space that are doing great things. Dr. Ted Neiman is a friend of ours out in Seattle, and lots of doctors that are promoting a lower carb lifestyle because they see the results. A lot of times it's either themselves or one of their patients that decides to do it. They see the incredible results, not just in weight loss, but the health changes. And so they're forced to look at it as a doctor, like, wow, this worked for this patient. Maybe it's an option for another patient. And it kind of grows. It's a low, slow grassroots kind of effort in that way that, doctor by doctor, they're seeing these changes, and you can't deny the results, right? And I actually started collecting our own testimonies, I don't know, 12 years or so ago. I was like, we had all these clients that would send us these amazing results. And so I saved them into a folder, and we've got, I don't know, 4,000 or 5,000 testimonies now from people that have sent to us. And I can go in there and search any condition, and you'll see all these testimonies for huge improvements in that condition. Parkinson's, Alzheimer's, IBS, digestive issues, Crohn's, colitis, eczema, and skin issues. I mean, you name it. We've had clients that have seen amazing results. And that's what happens with this lifestyle, is that, the weight loss is great. And everybody kind of comes to it looking for weight loss a lot of time initially, but they stick with it because of the health benefits, because how good they feel, how they come off their medications, how they, have these symptoms reverse. The previous speaker, I just wanted to share this. We just shared this online. I don't know how well you can see it here, but this man right here.
Yeah. Yes.
Parkinson's and Alzheimer's. And he came into a
I think
clinic.
I saw this. Yes, I saw this.
Yes. He came in the wheelchair.
Amazing.
And really not able to speak or communicate very much. He left walking, and he signed his own forms and pulled off the the double sheets and took his, like, incredible change. And
that's so amazing. Yes.
Just ate our recipes. We were working with the clinic, and we sent them all our books, and that's the results you can see with diet change. And I think that has to get more pervasive across healthcare somehow. It's people like us here promoting and showing these results to force them to acknowledge that this works.
Great. What stage of Parkinson's was this gentleman at, and how much time did it take for you guys to work on him and get to this point?
It was 7 months. So I'm just looking at the testimony here. It was 7 months. He was nonverbal, could barely stand up. He was in the wheelchair, and in 7 months he walked out and signed his own forms. I mean,
that's
incredible. Let's put it in this context. Back to the healthcare. If I can make a pill for Alzheimer's and Parkinson's that could do these results, I would be a billionaire. Like, it would be,
absolutely.
Right? But this is actually kind of free, right? Just eat different fruit.
Yes.
I mean, it's pretty
Amazing. We've been
remarkable.
talking about all these conditions yesterday as well and today, and Parkinson's and Alzheimer's. Emmy was here, Emmy Burger, and we were discussing this. So I was very keen when I saw this post from you. I mean, it was, I was literally shaken because these kinds of results are very rare. I mean, there are some improvements, but to have somebody get up from the wheelchair and really sign something and walk out of the clinic is really incredible. Hats off to you, Craig,
Thank
for
you.
getting
And
those results.
Hal, who runs this facility, just a few months ago, we had on our YouTube channel too, we interviewed her, a woman that came in with dementia,
Mhm.
and we have the tests. She came in and on this standard dementia test form, 0 to 9 was dementia, and she was like an 8. She came in.
Okay,
It's
that's
like
an advanced
draw a
stage.
clock and these different, cognitive tests. Within a month or so, she was up to about 14, which is just mild. And then after I think it was 3 or 4 months, she was in the completely normal range, like scored like a 23 on that test. And she went home.
Incredible,
I
incredible.
mean, it's
It's
incredible.
great results that you're achieving. Yes, absolutely
Thank you.
incredible. Great. My next question to you is, not many people know, of course, those who are on Twitter may be knowing Craig's own personal journey, but for those who don't know, Craig suffered from Lyme disease and CISR, and he also has ankylosing arthritis, or which is an autoimmune condition. Craig, what were your reasons to give up on the vegetables completely? Because I saw your videos where you're talking about that. You used
Yeah.
to have them, and you gave them up completely and became a carnivore with reference to your autoimmune disease. Now, when I'm dealing with my own clients and largely who are autoimmune cases, I need to make a point, especially in a country like India, which is 40% vegetarian. And
Yeah.
even people who eat meat are occasional meat eaters. They are like accidental meat eaters, if you can call them.
Yeah.
So, what is the significance of leaving vegetables on an autoimmune condition? What was the journey and the personal learning that you got from when you were eating them to when you left them?
Yeah, I make a pretty good case in this book over here. And I also, there's a presentation I did, and it's on YouTube. It's called A Case for Carnivore. And I really break this down in detail. But my view on it is, well, first let's start out with plants. Plants have something called anti-nutrients. All plants have anti-nutrients. These are compounds that they're, anti-nutrients. So there's something the body doesn't want or need, or it can't use it. And so what does the body have to do with those things? It's got to detox them and get them out of the body. Things like oxalates, glucosinolates, lectins. These are compounds in plants that the body has to get rid of. If you've got a healthy immune function and you don't have any autoimmune disorders or those kind of conditions, the body does a pretty good job at detoxing them and getting rid of them. If you've got a condition like me, where I've got this suppressed immune function due to this chronic inflammatory response syndrome, SIRS, triggered from the Lyme disease that was undiagnosed for years, you got this depressed immune function, and the body's constantly fighting the way it is, and then you add a load to the detoxing and the system and more inflammation from these anti-nutrient compounds. It's just too much for the system, and it just increases the inflammation. My joint pain goes up. I literally can, if I ate a bunch of plants that I don't normally eat, the next day my joints would be terribly sore, the inflammation would be up, and I'd have to suffer for a day or two. And so I see it immediately. And so I think that's part of the reason why somebody like me, and there's other people too, a lot of autoimmune disorders can see some additional success when they go all the way to carnivore. Some brain conditions too, like bipolar, Alzheimer's, those kind of things. We've seen people have additional improvements when they go carnivore. And the other part of it, I think, is the other side of the coin when it comes to this is animal proteins are the most nutrient dense foods you're going to eat. And when I wrote this book, my wife and I wrote this book, I wrote half of it. I put a whole chapter in here about the vitamins and minerals in our food, because it's just not well known. You give a plate to someone with kale, maybe some blueberries and a steak on it, and ask them, where are your vitamins and minerals coming from? And they'll probably say the kale or maybe the blueberries. But guess what? I put charts in here of like the 13 top vitamins and minerals, and the steak blows them out of the water. There's like one thing the kale is higher in, everything else steak is higher in. Like it's this, and there's a study that I put in this one as well, which is a awesome study that I really like, because it was looking at gut microbiome, and it was a randomized controlled trial. So this is a really well done study, and it separated people into a completely vegan group, so they ate nothing but plants, and a completely carnivore group. They ate nothing but animal proteins. And they looked at the gut microbiome, and they saw the shift in the gut microbiome. Well, first of all, it shifted in 24 hours of having the new meal, the new diet. The gut microbiome shifted a lot for each one. But in both of them, they had the same gut bugs still. All the same bugs, just some of them went up, some went down, that kind of thing, based on what you're eating, which makes sense. You know, these gut bugs like this animal protein, different compounds in it, so they go up. The ones for plants go down. But what was really interesting about the study is they also looked at the genes responsible for vitamin biosynthesis. So that means the genes that are responsible for synthesizing vitamins coming into the body. In the vegan group, they didn't change at all from the standard American diet. In the carnivore group, they went shot through the roof. They went way up. Why? Because you're eating the most nutrient-dense food, and it's all in the most bioavailable forms of these vitamins and minerals. So the body's flooded with all these vitamins and minerals. And that's what we should want, right? We should want the food with all the vitamins and minerals and nutrient-dense.
So I'll just extend this, and then Anup, you can maybe take the next question. Now that we're talking about autoimmune, in the context of India, Craig, 40%, as I said, are vegetarians. Now, when we say vegetarians, it's not the vegan aspect of it, but they do have dairy and grains and lentils and legumes. Do you think an autoimmune condition can be bettered on such a diet? It's not a vegan, but a vegetarian diet, which is sometimes even eggs are added, but that's rare. But let's consider that out. Dairy, grains, legumes, vegetables. Do you think an autoimmune condition can be bettered, improved, or dealt with on such a diet? Or is this not conducive to autoimmune cases?
So it kind of depends on where you're coming from. If you're coming from the standard American diet, anything whole foods based is going to be an improvement. And you're going to see some benefits from it. I personally believe that for long-term health, you need to have enough complete proteins to maintain your muscle, to, especially as we get older. So there's an amino acid called leucine. Leucine is one of the amino acids that's kind of the trigger, if you will, for building muscle, triggering muscle protein synthesis. And animal proteins are all complete proteins. They have lots of leucine, and you can build muscle with them. A lot of plant proteins are not complete, and it's hard to get enough leucine to trigger that muscle building. For example, broccoli. Broccoli is, I've seen these memes out there where they compare broccoli to meat and say, oh, broccoli per calorie, or whatever. I figured out how much leucine, to get enough leucine to trigger building muscle. With broccoli, it was 9 entire heads of broccoli, not a floret, the whole head. 9 full heads of broccoli to get one, where with the steak, it was like 3.5 ounces of.
Yeah, but that's how the messaging is. Craig, if you look at it, they'll take, spinach has calcium or something like that. But how much? And whether it is even bioavailable to us.
Yeah.
So
vitamin
it's
A.
like it actually meme.
Yeah, vitamin A in a lot of plants is not in the form the body wants. Where in animal proteins it is. Plus all the anti-nutrients that are in the plants. So one of the things about oxalates that cause so many people problems, oxalates are like these tiny crystals in your food, in certain plants. And they can irritate the gut and possibly cause leaky gut and these kind of things. But what also is a problem is they like to latch on to minerals before they're detoxed. So they'll latch on to calcium. They'll latch on to magnesium or zinc. before they're detoxed out of the body. Well, what can that cause? The majority of kidney stones are calcium oxalate kidney stones. They're not because of calcium, it's because of the oxalates that are grabbing onto them and building up in the kidneys. And then another example, there was a study, and I put that in this book as well, as this study where you have oysters are a great source of zinc. And what they did is they tested blood plasma. So they tested the blood after you ate the oyster to see how much zinc was getting into the bloodstream, right? Because it doesn't matter if you put lots of vitamins and new minerals into your mouth. If it doesn't actually get in the bloodstream, what's the point? And so what they did is they did it with just oysters. And you had this big increase in zinc. And you had lots of zinc getting into the bloodstream. They then paired the oysters with corn tortilla chips. And like a third of the zinc ended up in the blood. And then they, or no, I'm sorry, the second one was black beans. It was black beans, it was like a third less. The third one was with corn tortilla chips, and none of the zinc ended up in the blood.
Yeah.
Because the oxalates are grabbing onto the zinc, and then it goes out of the body, and the body doesn't get it, right? And so that's a big factor here too.
Craig, just a short answer. A lot of vegan, people are claiming to reverse autoimmune on a vegan diet. Now, given the background of oxalates and the toxins that you've now mentioned, is it possible to improve an autoimmune condition on a vegan diet?
Again, if you're coming from standard American diet or something similar,
yeah,
you could probably see some nice improvements. I will say that typically there is a kind of vegan honeymoon when people go to a vegan diet. It can be a year, it can be a couple years, it can be 5 years, it can be 10 years if you're younger. But you're going to have vitamin deficiencies, and that's a fact. Everybody understands that. B12 and there's several vitamins and minerals that you're going to be deficient in unless you supplement them, because you don't get them enough from plants. But also, when you get older, it's also more of a concern, because remember the leucine curve we talked about for triggering building muscle? That leucine curve shifts with age. And so after you get 40, 50, 60 years old, it shifts. And so you need even more leucine just to build muscle. So it means you need to eat even more complete proteins just to maintain your muscle. And that's why a lot of elderly people will get sarcopenia and they'll lose muscle. And so it becomes even more important. So I would think if somebody's over 50, 60, and they go to a vegan diet, they might, again, from standard American diet, they might see some initial health improvements, but over time, you're going to lose muscle, and that's going to be detrimental down the road.
Anu?
Yeah, Craig, based on the, huge number of testimonials that you have, now, how effective is carnivore diet in relation to the broad spectrum of autoimmune disorders? And how much has it helped you? Have you recovered 100%, or is there something still to, job to be done?
Yeah, so with ankylosing spondylitis, when it gets progressed like it is with me, like I have fused vertebrae in my neck. So they're calcified and fused. So that's not going to go away. You're not going to remove the fused vertebrae. But my pain is very much under control when I stick to a strict carnivore diet, where if I get too many plants in, then my pain goes up. So it makes it much more manageable for me. And as far as keto versus carnivore, when it comes to this, we've helped tons of people with autoimmune disorders and all these types of issues with just a keto diet. And it's only in certain cases where they have to take it a little further and go to carnivore, where they still aren't getting to where they want to get to. They get better, but maybe not quite where they want to be. And then they go to carnivore, then they get, maybe full remission or remission of symptoms. And so we kind of treat it as a case-by-case basis and kind of like a tool. If you want to be in keto and you like some of the different plants for taste and texture and color and all that kind of stuff, go for it. If you're doing great, go for it. If you're not quite doing what you want and you're not seeing the results you want, try carnivore. Give it a try. Go down. And we even created a protocol, carnivore autoimmune protocol, in this book that gives them a process to eliminate everything and then slowly add back in things to see where their tolerance level is.
Typically, Craig, what do you see? What are the triggers that you commonly see in an autoimmune condition? For example, you said if you're doing well with vegetables, you can maybe go ahead with that. But what is the standard template like? What do you need to eliminate as a standard thing to be done on an autoimmune condition?
Well, in our autoimmune protocol, we start out at beef and salt, and that's it for at least a couple weeks, and then you add in other animal proteins that you want to look at, and then from there, on the next level, you add in eggs, and then dairy. So those are, at a higher level because both of those people can be sensitive to and have reactions to, and then from there you can add, more spices or low carb vegetables and things and see what your tolerance is. But that's kind of that's the protocol that we developed. And beef is just one of the most ruminant animals
means, yes.
are just the most bioavailable and most well-tolerated thing pretty much out there.
I've seen people reacting even to chicken and, as you said, eggs. So poultry and fish both. So what's worked well with them is just red meat. But I would really want to know what are the things that you, as a standard template, eliminate permanently from their plates? Is that the grains? Is that fruits or what?
Well, it depends on the person again. If they can come back in and add some, salads and lettuce and, low carb vegetables like peppers or, whatnot, and they're fine with it. They don't have increase in symptoms or inflammation, then great, go for it. For in general, we try to keep people low carb though, because we find it just has better satiety. You just have more mental clarity, better that even energy you get when you're in that kind of keto diet, keto state, where you don't have that afternoon dip where you're like, oh God, I'm so, I'm gonna fall asleep here after this lunch, in this meeting and that kind of thing. You just don't get that. And part of the reason for that is when you get the carbohydrates up too high, when you spike the blood sugar with carbohydrates, whether it's from rice or, complex carbohydrates are just glucose molecules linked together in a long string. As soon as it hits the GI tract, it breaks those apart into glucose. So glucose and complex carbohydrates are, sugar and complex carbohydrates are really kind of the same thing. And when you get too much of that, you get a spike in blood sugar. And so when you get this big spike in blood sugar, the body, it's in panic mode because it's not used to that. It doesn't want too much blood sugar can kill you. And so it ramps up insulin to drive it down quickly, and rapidly falling blood sugar will drive hunger, especially if it dips down too low, then you're ravenous. So what happens when you drink that, you have that big milkshake or whatever at or ice cream, you get this huge spike in glucose and then it falls down, even though you ate 1,000-calorie milkshake, 2 hours later, you're hungry. If you eat 1,000 calories of steak or eggs, you might not eat again half the day or more. So it's different for satiety. And I think, so that's why we always kind of keep clients in that low carb realm.
I think the larger point that we both will agree on is that it begins with elimination first. Why it complicates things in the context of India is that if a vegetarian comes to you with an autoimmune condition, he's not ready to let go of his food ideology, which is largely plant-based. And so, eliminating is not possible. And this was the point that I was trying to make through you, because you've taken the journey yourself, that unless you eliminate and better and then add things back to your plate, you will not know the improvement that you are going to be having from an elimination line. So being vegetarian kind of makes things a bit complex. But coming to the next question, Craig, one of the misconceptions is that in keto, one has to go high fat. But is that the correct approach, especially with regards to people who are doing keto to reduce weight? Also, a lot of people are now doing the high fat, low protein diet. There are lots of videos on YouTube who are doing butter diet. I keep getting references as a coach. Is this correct? Or, should we do it? So by the time they get to that high a point of fat, the protein intake goes really down. Is that a correct approach to nutrition to begin with?
I don't think it is for anyone other than maybe a couple of conditions like extreme Alzheimer's
Yes.
or maybe cancer patients. There might be some application there. But everybody else, especially if you're trying to lose weight, like trying to lose body fat, adding a ton to the diet is just going to slow or if not hinder completely your results. You got to bring it back to, I look at everything kind of mechanistically as an engineer, and I think if I put that fat in my mouth, where does it go? Right? It's going to go into the digestive tract, and it's either going to go right through the digestive tract out into your stool, or it's going to get into your bloodstream. Those are the only two places it can go. And if there was a study, and there's been a few of these, but it actually sampled everybody's stool, and they changed their diet from, I think it was 58 grams of fat in the diet to like 160 grams of fat in the diet. And they measured how much fat ended up in the stool. And on average, it changed from like 1.9 grams of fat in the stool to like 2.9 grams of fat in the stool. So it only went up like 1 gram with all that additional fat. So it's getting absorbed. The vast majority of the fat you eat is getting absorbed into the bloodstream. So now it's in the bloodstream. Where's it going to go? You don't want it to stay there, right? Because if it just stayed in the bloodstream, your triglycerides would be in the thousands. Nobody wants that. So it's got to be stored. Well, where's it going to be stored? It's going to be pushed into somewhere for storage. Your adipocytes, your fat cells, that's where you want it. You want it stored in there because the alternative is in your liver, in your pancreas, around your organs, the organ fats. That's the alternative. So you want it in your fat cells. So the vast majority of fat you eat goes into your fat cells. Well, if you're trying to shrink your fat cells, you're trying to lose body fat, and you're adding more fat to them, how does that help? It just doesn't. And we have had daily people coming from that, especially in the carnivore community where it's promoted a lot, tons of fat and that are just either stalled or gaining weight. And they come to our approach, they prioritize protein, get enough for their body. And that's the thing about protein too, is it should be for your body size. If, Sean Baker, he's about 6'2" and I don't know how much pounds of muscle. He needs a lot more protein than I do to maintain all that muscle. Where a 5-foot tall woman, she needs a lot less. So your protein goal should be based on how much muscle you have, how much you need to maintain. And then carbohydrates being low, the only variable now is the dietary fat, right? That's the only thing left to change. And so you change that based on your goals. If you're trying to lose body fat, just dial it down a bit in the diet and let the body burn more off the body. And then once you get to maintenance, dial the fat back up until you get that maintenance point. It's really kind of simple.
Anup, next question.
As an extension to this question, can you please talk of your protein sparing modified fast, PSMF, and to extend to that, how is it different from intermittent fasting? And between the two, intermittent/extended and PSMF, which one is better?
Yeah, so I like to first of all, I like to break intermittent fasting and extended fasting apart, because intermittent fasting is just time restricted eating. You're eating your food in a certain window of time during the day, and then you have nothing outside of that window. And generally speaking, most of our clients fall in naturally into an intermittent fasting cycle because they're just not as hungry all the time. And so they'll eliminate one of their meals and they'll just eat maybe a breakfast and late lunch or a lunch and early dinner, and that's it. And then they're satisfied. And so we promote that. We think it's great. And it comes naturally for most people eating this way because they're just not as hungry. Extended fasting is different because you're talking about, longer than 24 hours of eating nothing. And a couple things about that. There's, again, maybe only 1 or 2 cases where we promote that. One's cancer, because cancer is a very anabolic disease. It likes to grow. It likes growth. And when you eat nothing, you're very catabolic state. You're not growing anything. And so that possibly could be helpful in those situations. But you're going to lose muscle. And every study has shown this, that you're going to lose muscle when you eat nothing. The body still needs, even in ketogenic state, the body still needs glucose. Their red blood cells do not have mitochondria in them, so they have to burn glucose. There's no other option. Certain brain neurons need glucose. Well, a lot of that can be offset by ketones. You still need some. And what happens is the body can make the glucose it needs. If you, like me, I'm carnivore. I eat basically no glucose, but my body makes it from the protein I eat. And if you're not eating any protein, you're fasting, extended fasting, it's got to make it from your own protein, which is your muscle and tissue. And so that's why we don't really promote extended fasting, other than, again, that maybe cancer, something like that. Protein sparing modified fast is what we do in place of an extended fast. So instead of like doing a 2-day or 3-day fast where you eat nothing for 2 or 3 days, do a protein sparing modified fast for 2 or 3 days during that week. And what it is it basically mimics an extended fast without the muscle loss. So you're getting still your proper protein amount for your body, basically little to no carbohydrates, and then only like 20 or 30 grams of fat, just enough to absorb fat-soluble vitamins, just enough for, hormone production, that kind of stuff, but not much energy, so that your body's forced to tap your own fat stores a lot more for energy. And these can be great for breaking stalls, for speeding up weight loss. We don't recommend people do it all the time because it's very low calorie. And just like you wouldn't do an extended fast all the time, you just use it as a tool intermittently. But yeah, that's kind of where we land in all those spaces.
Craig, that's a very interesting answer. I think people should explore this more and try it. I'm surely going to try this. I've been doing it, but maybe the fat that I've been taking was a little more than what you've specified, but I'll definitely give it a try. Before we end the session, Craig, 2 things. One is, what would your advice be to people who have autoimmune conditions? That is one. And 2, I would like you to talk about your books that you have behind you.
Yeah, so one recommendation from me would be, if you can, and again, I understand that in the vegan or vegetarian space, it can be very challenging, but we like eggs if they can. If we really push eggs to, it's the most complete protein you're going to get as a vegetarian. So lots of eggs can really help. But if you can do carnivore or keto, at least keto, where you prioritize protein, it's really great for autoimmune conditions. And I have not seen an autoimmune condition where there wasn't at least some benefit. Okay, it might not be a full reversal of symptoms or remission of that autoimmune disorder, but I have yet to see, with hundreds of thousands of people we've worked with over the years and millions of people that have bought our books, I've yet to see anyone that didn't see some improvements. So why not give it a try?
Craig, in India, vegetarian means not even having eggs. So you know where I'm coming from. And I'm talking about people who come to me with autoimmune conditions and wanting to reverse it or put it under remission. I am talking about people who are grain-based, legume-based, and vegetables-based. Eggs are out of the question. So that, I think we get the larger point, but why don't you talk about the books that you have behind you? I think it'll be very relevant to people with these conditions.
Thank you very much. Yeah, we've got these books, which are kind of like, here's how you do carnivore, here's how you do keto. And then we've also got about, 12 cookbooks too, that really go into all the detail, every kind of recipe you can imagine, just a couple ingredients, change it out. My wife, Maria, is amazing at this. She's a chemist. She can figure out what ingredient to change to make it just like the traditional recipe, just healthier. And we've done cooking. One of my favorites is she makes this pudding, and it's made from eggs, but you'd never know it. Holly Berry did a joint cooking demonstration with my wife. She's been
Yes.
eating
Yeah.
keto for like 16 years for her diabetes. She has all her books, and we did this joint cooking demo. And she's like, before we went live, she's like, Maria, I am not eating a pudding made from eggs. And we were like, just try it. So we did, and they made it and they brought it out. And she thought it was like the most decadent mousse she's ever eaten. It was a chocolate pudding. So, you know, you can do a little chemistry and switch out a couple ingredients and have some really tasty recipes.
Yeah. So all these books are available on Amazon, I guess.
Yes, correct. And all of our information you can get to from ketomaria.com. We have all of
Yes.
our links there.
So I think we've come to the end of the session, Craig. Maybe we'll have one podcast, T-Live podcast with you sometime later after this MHC. I would want to have Shashi on the screen. And Anup, anything you would, like to add to
that's
the
it.
end?
It was very nice talking to you. You know, it's always a pleasure interacting with an engineer because they're all thinking on the same plane.
I love it. Thank you so much for having me on.
Yeah. Is Shashi there?
Yeah, please get Shashi in.
Yeah.
Craig, hello.
Hi. Thank you so much for having me on.
So happy to have you. And we have been seeing the success stories of you and Maria for quite some time. And I think it's all one of the amazing success stories. And the way you guys have transitioned, from various dietaries, from low carb to keto to carnivore, to a higher protein focused, protein spectrum diet. And I think that really provides very good option. And the kind of success stories you post are something which is amazing. What is very important is if that patient who is suffering from Parkinson, if he can walk back to his home, I think nothing can really express, the kind of happiness that the person gets and the kind of happiness content which you both get.
It's incredible. It's the most rewarding job I've ever had. It really is.
And again, as Anup says that you are one more engineer. So we know quite a lot of engineers are cracking the nutrition space only because of your engineering mind.
Well, thank you so much.
That I always say that no, I'm not an engineer, but I also know engineers as someone who will see this cause effect. The cause effect things always.
And root causes of problems. I always go back to the root cause. What's causing this problem?
And I heard once Ivor Cummins say that, if the nutritional way of science is applied to, let us say, aeronautical engineering, then plane will crash daily. And then you will keep telling that it is the fault of the passengers.
Yeah, there you go.
So that is how the nutrition space is like this. It is today the fault of us and not the dietary guidelines.
Yeah.
So this is how conflicted it is. It's wonderful to have you. Thank you very much, Craig. And
thank you.
Thank
Very
you,
nice
Craig.
to-
Thank you for coming. And
Very
our
nice to
regards
see
and
you
love
all.
to Maria as well. Thank you, Anup.
Thank you.
Thank you, Shashi.
So we three will be on the screen. Me, Ida, and Anu for some time.
Okay.
So yeah. So Dr. Penny Victory has not yet come in. I have sent a reminder also. I think she got delayed due to some reason. So Aarti, can you just post that we will come back? We'll be back in few minutes.
Yes.
Sure. Thanks, Craig. Thanks once again, Craig. So we'll just hold on for some time. We three will be on the top and let in the front end that poster be displayed. Or if you want, we can keep talking also. Anup and Ira, you want to talk on any specific subject? Are there any questions in the front end? We can address those questions.
Okay, let's clear a few doubts that a few people had, and they had messaged to me on X also, and I think that will appeal to a lot of people. Somebody had messaged me about seed oils, asking in particular, should we be eating mustard oil? We know that you should be eating ghee and butter and all of those saturated fats, but how good or bad is mustard oil? Any one of you can address that.
Anup can address.
See, my take is very, very clear. As far as cooking fat is concerned, no compromise. Only 3 fats allowed. Virgin coconut oil, desi ghee, not the ones that cost 400 rupees a kg. And of course, the last one is mm, butter, right? Anything beyond that is a compromise,
Hmm.
in my opinion. So mustard oil, cold pressed peanut oil, sesame oil, all are out.
So this question was in particular about cold pressed mustard oil.
No,
How good or bad is that, and should
I
we be
won't,
eating it?
I won't ever take, I have never taken it. I would never recommend. Yes, it's your personal choice.
Hmm.
If personal choice, dominates over the requirement of science, go ahead.
So I have 3, 4 questions. I'll ask them quickly since now we have time, and I'll keep some for the open session as well.
Yeah.
So Anup, maybe you can talk, and even Shashi can talk. How many eggs should one have in a day when we are talking about low carb?
As many as you can. It should be
Safe.
low carb. Yes,
Safe is the key
safe.
word.
Safe is the keyword. I'm taking 9 per day. So for me, 9 is safe. I want to ramp it up to 12, knowing that 12 will be very safe. After 12, I'll ramp it up to 15.
So safe is a
See,
sarcasm, basically.
I'll
Safe,
come to the,
yeah.
let me address in this way.
Hmm.
The very safe way to do is to start with 2 eggs. So let us understand, if people goes and takes 10 eggs at a time, if they're not used to it, they might face gastric discomfort simply because they are not used to it. Their gut biome is not developed to have so much sudden. So it is better to ramp it up very safely.
Yes.
Have 2
That is
eggs a day. Have 2 eggs a day safely, and then slowly ramp it up to 3, 4. See, we have seen studies have shown that the cholesterol from eggs are poorly absorbed. It is there in the PubMed. It is just that we don't know, and then we have some sort of dogma. Okay. So we just have to go and read those studies, and it shows that there is no issue with any number of eggs. But then, as we say, that ramp it up slowly, people can face discomfort if they suddenly go with 10 eggs a day. So I advise against that. Start with. There's one
So
question which is just
to add to what Shashi said, refer to studies. But then, if you have the intention of taking eggs, right? If such a question comes that how many eggs can you take? You can take 10, 12, 15, but ramp it up slowly, because sudden increase of fat, body will revolt. That is point number
related
one.
question. Yeah. Please
Point
complete,
number
and
two.
then
Point number 2 is, once you have made up your mind and you are on low carb, right? Don't look for studies that saturated fat will, block your arteries or it will cause heart attack. Ignore them. Start increasing eggs and follow your medical reports.
should we
They
be
won't
eating
lie.
only egg whites or with whole eggs? And why not just
I
egg
think
whites?
it is one of the most unscientific thing ever done in the world. It is one of the, I want to use very harsh word, but I don't want to use. See, the egg yellow or the egg yolk contains all the essential nutrients, vitamin A, B, D, E, K. In fact, these are all heart protective, heart friendly. So it
And
is.
choline. And choline.
And choline. Choline is protective against fatty liver. So the whole thing of, egg, it is a most foolish idea of taking out egg yellow and eating egg white only. In fact, the absorption of even the egg white is intensified if the egg yellow is there. So there is a study also to show that if some participants were put on egg white and some on the whole eggs, the muscle protein synthesis or the egg absorption was far better for those who take whole eggs. So that's
So there's no point in taking just egg whites.
it is all foolish unless there is
Okay.
someone
In fact, a lot of people are allergic to egg whites.
See, if people are allergic to egg whites, we found that they are able to tolerate the egg yellow much better.
Yes. Yes.
The protein sequencing in both seems to be different.
You
Yeah,
know
look,
what? You know what? This concept of egg white and discarding the yellow, it has come from gym bros. Now,
I
while
was going to come to
while
the
they-
extension. This question is in relation to the influencers who say take egg whites.
no, see,
that is because
let me add to the point, Anup. The gym bro may have a different
no,
reason.
that is because they are pushing in too much of carbs.
No, the other way, see, gym, what they do is they want to appear ripped. Okay, so they go low on carbohydrate and fat both to appear ripped. So they have a totally different thing which we don't want to discuss at all. we are in the space of metabolic health. So let us understand metabolic health that is required. Acha, Ira, one very important question for you. Dr. Penny is just joining. Before that, there's a question has come. Dr. Penny has come. So I think we will address this question later.
Yes, please.
Can you get Penny in? Trusha, please get Dr. Penny in.
Yes, sir. So please start your webcam.
Dr. Penny, please start your webcam.
Hi, everyone.
Hi,
Hello.
hi.
Hello.
Gosh,
Hi.
spontaneous, no time to prepare here. Let me just shut the door behind me.
Please.
Hello, everybody.
Hi, hello.
From
Hello.
India.
Yeah.
I'm
So-
so sorry. I thought it was in an hour. So here I am, all relaxed.
No
not
problem. I think
prepared.
there's some issue. I'd send a Google invite so that it translates into your time zone adequately. But I think it's all okay. So before you came, we were just chit-chatting on some of the common questions which are coming from people. So I think we had an opportunity. So Dr. Penny,
Yes.
I'm Shashikant Iyengar, one of the co-organizers. Me and Anup, we are both organizing this second Metabolic Health Conference of India. We had the first one in October 2023, and now we have the second one. So
Yes.
the programs focus more on the applications of low carb and ketogenic or even carnivore diet in the space of metabolic health, neurological health, mental health, CKD, cancers, diabetes, autoimmune conditions also. So we had carnivores also coming in and speaking. So I'm Shashikant Iyengar, a metabolic health coach in India associated with D-Life, and I have with me Anup Singh. He is the originator of D-Life, the India's oldest, largest, and biggest community. He will talk about D-Life in a couple of lines. Anup.
Yeah, it's just a platform now where community is just a small part. We started with community in 2014, and now it has grown to the extent that we are now offering, certification courses, and there are about 250 success stories on the community. And if you include all the, network of coaches, it's 3,000 plus. And the USP is that it has about 2,000 Indian low carb recipes. So in that context, we are the largest Indian low carb platform in the world. And I myself am a diabetic type 2 from 2011 and on 0 pills, running almost 14 years now, going to be completing 14 years, and no pills. So in short, I've eaten, in my estimate, I've eaten about 8 kg, avoided 8 kg of those pills that I had to eat if I was on carb.
Yeah.
Thank you. Welcome.
Fantastic.
Yeah.
So good.
So that Dr. Penny, we have exactly 33 minutes left. We'll have to compress that 45 minutes to 33 now.
Quick.
And we'll do it, no problem. So I'll give a quick introduction.
Yeah.
Dr. Penny Fictree or Penelope Fictree, graduate from the University of Sydney with the first class honours in 1993 and is a fellow of Royal Australian College of GPs and on the scientific committee of the Australian Metabolic Health Society. She began focusing on low carb and ketogenic nutrition to treat metabolic syndrome back in 2018. As a co-joint lecturer at the University of NSW Medical School, she has completed research projects, including one on the CKD or chronic kidney disease and very low carbohydrate diet, with a poster at the Australasian Diabetes Congress back in 2022. By using therapeutic carbohydrate restriction, Dr. Fictree allows to stop medication and watching people regain health. So she lives in Australia with a husband and 3 children. So please tell us how come you came into this low carb world?
Yes. Well, I discovered this 2017, 2018. As a family doctor, you get a bit sad because you see your patients about when they hit 40, they start getting sick and you just start giving them pills. And I always thought my job was about prescribing tablets. And so people just end up on more and more pills. And I tried lifestyle. I used to really try and get people to lose weight and did everything that I could, but nothing ever worked. And then one day I stumbled across that insulin carbohydrate model of obesity, which just made so much sense. And I discovered Dr. Eric Westman, who's got that white coat video on the internet, so you can watch that and figure out how to explain it to patients. And so I just started doing that in my practice, and it was incredible. People got better. Irritable bowel got better, diabetes went away, people lost weight. It's like a miracle. It really was a miracle. And this is someone who's been trying everything for years. Nothing else worked like this. And so then, of course, I became a low carb zealot and started putting all my patients on it. And so now that's all I do. I have a practice where I see people with metabolic syndrome, diabetes, chronic kidney disease. So I have a lot of fun because people get well, and I'm always stopping medications instead of starting them. So that's me.
Yeah, quickly, what are the root causes of CKD?
That's such a great question. So, of course, there are the odd things like an autoimmune disease, but the majority of people with chronic kidney disease, the root cause is metabolic dysfunction, high insulin, insulin resistance, high blood sugar. That's really, I think, the root cause of the majority of chronic kidney disease. And look, even in patients, say, who've got an autoimmune disease that's damaged their kidneys, when the kidneys stop working, you actually become insulin resistant as part of that kidney dysfunction. So really everyone with chronic kidney disease, no matter what the initial trigger was, it's driven by insulin resistance. And that's the thing everyone should be targeting if you're worried about your kidneys, in my opinion.
So whether it is diabetes or for the matter even CKD, the standard advice which is given is usually low fat, low protein, low salt, and there is no talk about carbs at all. Now, is it really effective in your CKD patients, or even for the you can generalize to the general population also? And what is the consequence of such standard diet?
It's really, I feel, a tragedy. Really, for the last 70 years, people with chronic kidney disease have been told to restrict protein, and often, low fat as well, because people get heart disease with chronic kidney disease. So they're told low protein, low fat, low salt, probably fluid restrict, because they get, fluid, they retain fluid. So the poor things, what are they left with? Bread. And so those carbohydrates, we know, are driving metabolic dysfunction, type 2 diabetes, high blood pressure. We're probably harming people by limiting everything, so they're just left with carbohydrate. And so that low protein advice, I actually think, has probably been harmful for people. And I'm actually really happy because I think that advice is beginning to go away. So now if you look on Kidney Health Australia's website, there's no mention of protein. It doesn't say limit protein. They'll say don't go under 0.75 grams per kilo, but they're not saying go low protein. They're actually highlighting sugar and refined carbohydrates. So there's a real change. And the international kidney body that, KD go, they came out and they're not limiting protein anymore either. So I think the American body still is a little bit, but they are moving away from that. And that is just good news for people with kidney disease because, guys, you're busy looking at protein. It's get rid of your metabolic syndrome and your kidneys will be so happy. And what drives metabolic syndrome? It's those sugars and starches. It's get rid of your diabetes, get rid of your high blood pressure, lose weight. Don't worry fussing around with this protein nonsense. And honestly, I think when people get right to the end, so say you've got your fistula in, you're going to go to dialysis, it's weeks away, your CKD5, it's the end of the line, which most people never get to. 90% of people never get that far, but say you do, that would be maybe a time where restricting protein might make you feel a bit better and keep dialysis away a few months. Because those proteins make, they make these uremic toxins that make people feel awful. But for the gross majority of the world, limiting protein does nothing except make you a bit miserable, sarcopenic, malnourished and miserable. That's my opinion. And luckily that's beginning to become mainstream and a real push away from limiting protein.
That's an information. I think I should visit the Australia site and see. It's
Yeah.
really encouraging and becomes a reference base for us. Yeah, Anup.
Yeah, I think lot many developments are taking place in Australia. I think, even Diabetes Association, I think they have tied up with the Defeat Diabetes.
Yes.
So
Yeah.
yeah, good to get to
Yeah.
hear all these developments. Now,
Yes.
for various levels of CKD or stages of CKD, what in your opinion should be the protein intake?
Whatever you like.
Let's say CKD 4, 5.
Look, I don't restrict protein. I would just go moderate. I'd keep myself, if it was me, I'd just go moderate protein. So if you're going on a low carb diet, just up more the fat rather than be upping a ton of protein. Would be just like, keeping yourself on your toe in each camp. But I wouldn't even be worrying about it, to tell you the truth. You'd be focusing on when your blood sugar level is doing, and eat to keep that low and eat to keep your weight down. Because the medications that we use, like the ACE inhibitors and the SGLT2 inhibitors, they stop this hyperfiltration that is the theory behind the amino acids being a problem. So, maybe, it probably doesn't matter that much because you're on the drug stopping the hyperfiltration. But if you're a bit worried about it, I'd just go, moderate protein, 1 gram per kilogram. I heard you talking to Dr. Gupta, and he was talking about how in India, everyone's low protein in any case. Would that be correct? So don't worry.
The average protein consumption of this population must be 0.5 gram per kg body weight. It is not even 0.8, which is required for the survival.
Yes.
And then we are made to hear that, restrict your protein.
Even further.
From the mainstream.
What are you told? I just missed that.
I said, we are at 0.5 grams per kg body weight.
Yeah.
National average. And even then, in cases like kidney dysfunction or something, they're told restrict protein further.
Are you serious?
Yeah.
You need to get this great paper that's called Protein Restriction in Chronic Kidney Disease, Time to Move On, by Obeid et al. In the journal Kidney 360. It was published in 2022, and they have a lovely table of all the randomized controlled trials showing whether protein restriction works. And the best trial ever, super expensive, multi-center randomized controlled trial, using a really accurate way of measuring renal function. So they use this radioisotope clearance, so not your usual estimated GFR, but an actual measured GFR every 4 months. And the study went out for over 2 years. There was no difference between the low protein and the not low protein group. No difference. So why are we forcing this on people? So that list is gorgeous. And there's one trial there where they sometimes show a bit of extra time to end stage kidney disease, so time to dialysis, but no difference in decline in kidney function. So the kidney function's dropping at the same rate, but if you're low protein, you can hang out a bit longer, maybe a few more months before you end up on dialysis, just because you're not as uremic. Do you see it? But it's just not evidence-based. It's really terrible. So I love that great table. It makes it so clear, and they just go through it beautifully. And I really think it's going to change. I do think it's going to change. So you show that to those nasty doctors that are killing their patients. And the thing is, when they end up on dialysis, it's like, oh my goodness, eat more protein, because it's a catabolic state. So it's like, become sarcopenic into your dialysis, enter dialysis really wasted and unwell from your low protein, and then all of a sudden, quick, eat more protein. It just doesn't make sense. It's harmful advice.
And I think rightly so. We are asked to restrict even further, and it's only going to harm. So you just talked about high protein or higher amino acid. They can cause intraglomerular hypertension, which may cause hyperfiltration, glomerular injury. First, if the patients are on ACE inhibitor or SGLT2 inhibitor, will this be avoided? If they are not on this, will amino acid cause this problem?
So, beg your pardon? So the medications stop hyperfiltration.
Okay.
So they'll reduce that glomerular hyperfiltration. So the benefit of having less protein isn't really there.
Okay.
But again, even before those drugs, they didn't show any benefit with low protein in any case. No sort of life-changing difference. It's sort of more almost like a religious belief that you've done your randomized control trial, it didn't make any difference, but let's keep doing it because we really think it's good.
In fact, there was a Cochrane review also on the same. It shows that there was hardly any difference between low protein and high protein. And
Yes.
it is there for everyone to see. Even the study you told is always there. And even I have read it some time back. Anup.
And there is a randomized controlled trial back, 2004, or, the one that was carbohydrate restricted, low iron, polyphenol enriched, randomized controlled trial. They had 91 people in each group, went out, 2 years. And there was a 40% people on the 50% less carbs did better than the low protein. And so no one's looked at that more. We've got that little trial there that seems to show low carb is good. And there's also a study in Israel. They did a feeding study. It was called the Direct study, and they did a calorie restricted, low fat, calorie restricted Mediterranean versus not calorie restricted, low carb diet. Long-term follow-up, 2 years, I think. And they looked at the renal function in those people, and it improved in all of the groups. But in the people with CKD3, it actually improved the most in the low carb group. So there's all these hints of evidence that low carb is good. So we just need someone to do a big trial. And I think Jeff Volek is doing a trial into chronic kidney disease. And I know there's a group in Italy that are about to recruit doing a ketogenic diet looking at chronic kidney disease. So the interest is there, but if you've got chronic kidney disease now, you sort of can't wait, can you, for these randomized controlled trials and for guidelines to change, because that'll be a generation, and it'll be another 50 years. So you just need to look at it. If it was me and I had that problem, I would be low carb. Like Virta Health, do you know the Virta Health trial? They looked at the kidney people there, and 6 out of 10 people with CKD3 improved. Did you know that? Up from 3 to 2. And the higher the ketones, the better they did. So again, there's these hints of evidence everywhere. And of course, you had Thomas Weems from Santa Barbara Nutrients and looking at autosomal dominant polycystic kidney disease. That's showing benefit. There's just all these little hints out there that this is the way to go. That kidneys like low sugar, low insulin, ketones if you've got some, and put that diabetes to sleep. The kidneys are happy. Don't worry about this protein business.
Nope.
While we are on protein, what's your opinion on plant protein versus animal protein in general and with respect to CKD?
So that's interesting, isn't it? Because there's something about plants that everyone thinks are magical plants. So there's 2 aspects to this push for plant protein. One of them is that the plants come with fiber and, your gut microbiome, and your LDL cholesterol is lower on a plant-based diet. So there's that sort of aspect. And I think, we can all agree that meat is pretty great we can see carnivores reverse their diabetes, it's great. So you don't really need those things. Secondly, some plant proteins are less acidic. So patients with chronic kidney disease, about 15% of them, when they get to stage 4 and 5, you'll see their bicarbonate drop and they get a bit of a metabolic acidosis, because the kidneys, they're important for maintaining the pH of your body. And so they're not working so well. So you can get a bit acidotic. And animal proteins, but also grains, are a bit more acidic because of their amino acids that they have. So they're a bit more acidic. So you might find that you need to add a tablet like sodium bicarbonate to get rid of that acidosis. So plants like vegetables and fruits are less acidotic. So you can treat an acidosis by upping your vegetables and your fruit, or you can take sodium bicarbonate. So there's that aspect to plant proteins. But again, remember grains, they're a plant, they're still acidotic. But it's only, you just give people sodium bicarbonate. So personally, I don't understand why you would be so worried about that. Again, I think it's theoretical. And for those people with late stage kidney disease, if you up the fruit and vegetables, then you bring in more potassium, and often right at the end, they're having to take, they're worried about potassium. And this is why people with chronic kidney disease get in a complete mess, because you're low protein, you're meant to do fruit and veg for acidosis, but that's too much potassium, and it all just becomes made up, not science-based mess. And that is why I feel if you've got kidney disease, just get rid of your diabetes that causes it, your high blood pressure, just keep your eye on the prize. Don't get tangled up with plants versus protein. I really just think it's glycemia, it's insulin. That's what's important.
So what are the precautions should we take when we administer carbohydrate restriction to CKD patients? Do we need to monitor the electrolyte and bicarb? What is your thoughts?
Yes. So it always depends. Like if you see CKD3, it's pretty easy, it's not that big a deal. Once you're down to CKD4, say your EGFR is 20, it's a bit more tenuous. And often, what I worry about the most is blood pressure dropping. Because when you put people on these very powerful diets that are as powerful as fluid tablets, as diabetes medications, you get big fluid shifts. And the kidneys do not like low blood pressure. So if you've got a fragile kidney, you go on a ketogenic diet, you're still taking your fluid tablet and your blood pressure drops, then you might actually hurt your kidneys. So that is where I'm very careful. If someone's on a fluid tablet, I will be warning them. I want you to check your blood pressure at home if you can. Tell me what it is. I'll be watching them carefully. And I've had many patients where I've had to get rid of their Lasix, a big dose, within 5 days, because it's a huge change in physiology and they get this monstrous diuresis. So I watch those. That's what I look. Of course, insulin, but we all know that. That's everyone. Watching those, that is what my special thing is for my my kidney people, is the blood pressure. And quickly pulling out those fluid tablets so that you don't get that drop in blood pressure. And the other thing is you have to be careful, because I don't know if you knew that with ACE inhibitors and those SGLT2 inhibitors, which are great for kidneys, when people first go on them, sometimes renal function drops a little bit. And it's actually a sign the drug's going to do good things for the kidneys. And Professor Karen Dwyer is a kidney specialist here in Australia. She wonders, when you first put people on low carb, you might just see that little bit of a drop, but don't panic, because then it just fixes itself. So my big thing to watch really is blood pressure. The other thing is uric acid. So uric acid can go up a bit initially, particularly if you go on a ketogenic diet. Then it gets better, but it can go up initially. And uric acid crystals are not so great for the kidneys. So if someone's got a high uric acid, I do put them on sodium bicarbonate or keto citra, just to keep the urine alkaline. But that's not science-based. That's just me thinking, I'll just watch the uric acid there. But for the most part, if you're CKD3, it's just the usual things that you do for everyone else. It's not such a big deal, I don't think. But you track it. I would do bloods at 1 month and 2 months just initially.
Do you have to measure the electrolytes, potassium, phosphorus?
Yes. Yeah. I've just, in Australia, you just write UEC as like a routine bloods, and you would be getting those at 4 weeks. So I'd be watching creatinine, EGFR, potassium, but you don't really see a problem with those. Yeah, so it's not so tricky, really. It's meant to be tricky, but it's just watching your person carefully. And the medications, I feel, are the most important thing to be watching.
How about SGLT2 inhibitor?
Yeah, that's great, isn't it? So SGLT2 inhibitors, I used to think, gosh, I must stop them. They cannot go with a low-carb diet. It's against the rules. Ketoacidosis, really dangerous. But I've since looked into it and realized that's actually not such a big worry. So firstly, if you've got chronic kidney disease and you do not have type 2 diabetes, you can take an SGLT2 inhibitor. You're not going to get ketoacidosis. It's seen in people with diabetes and diabetes with low insulin. So that's the big thing. Do you have low insulin? Are you a type 1 diabetic? Are you a burnt out type 2? So you would measure the insulin level or a C-peptide in these people and make sure they have enough. So make sure their fasting insulin, say, is above 10. Don't miss that latent autoimmune diabetes of adulthood. Don't miss that more type 1 person, because ketoacidosis occurs in people with low insulin who then have a trigger like dehydration. You need both to get this ketoacidosis. So you've got low insulin and then you fast for an operation. That is a trigger, but it doesn't happen. You need both. So if you've got enough insulin and you tell your patient, right, you're an insulin-resistant chronic kidney disease person, you're full of insulin, you're insulin resistant, you're fine, but always stop it if you're sick. So the sick day management plan is so important. And I feel I've met so many people, no one's ever told them, if you're sick, stop your SGLT2 inhibitor. Days where you're not well, don't take it. And honestly, if everyone did that, there wouldn't be a problem with this ketoacidosis. Stop it when you're sick. So I keep it going as long as someone's got enough insulin and they have a sick day management plan. And when I say insulin, it's endogenous insulin, not insulin injections. And there's a cardiologist in Australia who's used SGLT2 inhibitors and low-carb diets in over 1,000 people. And he said he hasn't had one case of ketoacidosis. So if you have chronic kidney disease, they are great drugs. So I would be on them, because I think they probably work beautifully with a low-carb diet, and together they're a really lovely combination, as long as you remember to stop it when you're not well.
Anup, I'll just jump to the question now. What is the benefit have you seen in those CKD patients where you apply low carb? What is the kind of reversal have you seen, like stage 3 to stage 1? Or have you been able to get someone off dialysis or any further advance to lower? How is it?
Yes, I think once you get to dialysis, it's probably too late. Those kidneys are scarred and it's too late. So no, I've never been able to get anyone off dialysis. Hugh Adams, who's a kidney specialist in America, he told me about a person who had CKD stage 5. Their EGFR was sort of 14, and he was getting them ready for dialysis and he wanted them to lose weight. So he put them on a ketogenic diet. And of course, they did beautifully, and now their EGFR is 30 and they don't look like they'll ever need dialysis. So that's the case from Hugh. For me personally, I've seen people whose EGFR is sort of 28 going up to 45. And I would expect your renal function to stay the same. And that's what I expect to see. And certainly all the low-carb doctors I work with often mention people whose renal function's improved. If you've got albumin in your urine, particularly a lot of it, it tends to indicate a poorer prognosis and a more rapidly declining kidney function. So in those people, you'd be wanting to be very diligent with the diet and really following it carefully, but it can still progress. So there are no promises, but certainly I usually see renal function stay the same and often improve.
Have you got anyone out from, let us say, 20, 30 EGFR back to 90?
No, the best I would have got is, well, the lady from 28 to 45. And then there's another lady, she was low 30s and now she's always low 60s, but not that miraculous up to 90, no. I feel there's a lot of inflammation in the kidneys, and that's probably what we're fixing when you go on a low-carb diet. But underneath that, those tiny little tubules are damaged, and they're probably never going to get undamaged. But that's okay. You just want to hold it steady. If you can hold it steady, then, you should be fine.
Anup,
Yeah, the cystatin C versus serum creatinine test.
Thank you so much for asking this question because I think it's really important. So, and you'll see there in those new KDIGO, KDIGO guidelines, they're mentioning cystatin C. So when we measure kidney function, we estimate it based on creatinine. But creatinine is dependent on your muscle mass, whether you've just eaten cooked meat or even if you've just taken a creatinine supplement because you're a gym junkie. And so there's all these inaccuracies. So we do this formula and it's based on your age and this creatinine level in your blood. So say you're a big Sean Baker carnivore lift weights, you're going to have quite a high creatinine level because you've got big muscles. So you've got more creatinine because this is in your muscles. So you've eaten a big steak, which puts creatinine in your blood. You got your big muscles. Then you turn up for your blood test and they're going to tell you you've got kidney failure because your creatinine level will be high for your age and it's a formula. And they'll go, oh, your kidneys mustn't be working well because the creatinine's building up in your blood. You've got kidney failure. And this actually happened to someone I know when they were told they needed a kidney biopsy. But cystatin C is another way of estimating your kidney function that does not depend on muscle mass or what you just ate. It depends on how many cells you've got in your body, how many nucleated cells. So if you're a big muscly person, it doesn't matter. It doesn't affect it. And that's another way of doing it. So if you're a big muscly gym person, I would recommend getting a cystatin C blood test, and then they'll give you a estimated glomerular filtration rate based on your cystatin C, and that'll be more accurate for you. So for example, the person who was told they had kidney failure, their eGFR and creatinine was 52, so CKD-B and 3B, and then they had their cystatin C done and their eGFR was like 115. So they had perfect kidneys. And I'm sure there's a lot of people who go to the gym, eat a carnivore diet and are worried about their kidney function. And if only they knew just to get a cystatin C, they wouldn't need to be worried. And at the other end of the spectrum, you've got the little old lady with no muscles at all, who probably thinks her kidneys are terrific, but she's got no muscle, no creatinine in her blood. So it sort of makes her look like her kidneys are terrific, but actually they're probably rubbish. It's just she hasn't got any muscles and gives her this falsely high GFR. So particularly for gym people, I think you need to know about this cystatin C blood test, which you can just ask your doctor to order. It's available from the pathologist. In Australia, you have to pay for it. But it's definitely readily available.
Is cystatin C associated with uric acid in the sense if it is slightly off the mark, will it be due to presence of higher uric acid or is it independent?
I don't think it has anything to do with uric acid. Not that I've read.
In India, we see that, cystatin C, and then they also add this uric acid along with that. So I was very curious to know whether there is some connection between these two.
Yeah, I don't know. I haven't read that, but I'll go and read it now.
I think that's one good way because we have a eGFR calculation via cystatin C also, other than the standard creatinine one. So very, very interesting. And your talk on low carb down under was very inspirational, and I learned a lot. I saw that, and I told Anup that we should have Dr. Penny in our program because the way you talk, the lot of information you gave, and we may want to discuss more probably because of time doesn't permit. We just
I'm so sorry.
Doesn't matter. I think we have covered well. And
yes, I think so.
We had Dr. Alok Gupta with us a day before.
Yes.
We had Dr. Thomas yesterday to talk on PKD and yours. So thank you very much. So Dr.
Thank you so much for having me.
Before we go, what is your message to India?
My message is keep your eye on the prize. It's low carb. Keep your insulin down for your kidneys and your blood glucose down. Don't worry about protein plants. Don't get messed and confused. It's about metabolic health. That's the most important thing for your kidneys. Thank you so much.
Thank you.
Lovely to meet you.
we will have you again in our future events, or we might invite you for our internal podcast to learn much more about the work you are doing in this space, because there are a lot of many other points which we may wanted to discuss due to paucity of time. But I think this becomes very important in the sense that today India is having 100 million confirmed diabetics, 126 million pre-diabetes, and the kind of kidney function damage we see in India is terrible, because we as health coaches, we come across all these cases where they have been having uncontrolled blood sugar, uncontrolled blood pressure, and then it whacks the kidney. That's what it impacts the kidney very hard. And then we cannot do anything when they come to dialysis stage, but the other stage we do take care. Personally, I have success stories of reducing from
Yeah, do
stage
you?
3B to stage 1.
Have you really?
Yeah, so I do take care of these kinds of cases. They have associated BP and blood sugars. We apply low carbohydrate and maybe not ketogenic, low carb, and then we get it very nicely. We have a lot of such success stories, not the extreme cases, but yes, the early stages we managed to reverse it nicely to
Yeah.
not crossing that 90 EGFR, but coming to that small. In fact, day before yesterday, we had one case where one of the doctors showed that the EGFR increased from around 62 to 87. So these are
good.
kind of success stories. So thank you very much, Dr. Penny, and we'll see you again. Anup,
Okay.
Thank you.
Bye-bye. Thank you so much.
Bye-bye.
Bye-bye.
thank you, and we'll see you
Bye.
again. Thank you very much.
Bye-bye.
Please get Dr. PV Satyanarayana and Sandesh.
So please start your webcam.
Yeah. Now I'm unmuted. Yeah.
Welcome to India's second Metabolic Health Conference, friends. My name is Sandesh Bhatt. I'm a metabolic health coach and a member of DLife.in, India's oldest, biggest, and the only award-winning low-carb platform. Shashikant Iyengar and Anup Singh bring to you this historic and scientific feast from India, titled Metabolic Therapies. It's my privilege and honor to have Dr. PV Satyanarayana here with us today. Fondly called as Dr. PV. Dr. PV is a renowned cardiothoracic surgeon based out of Hyderabad, India, with over 40 years of experience. His qualifications includes MS in general surgery, MCH in cardiothoracic and vascular surgery, and he's an MBA too. Dr. PV has performed over 20,000 heart surgeries, including heart transplants. Dr. PV is not only an accomplished surgeon, but also an avid reader with the mind of an engineer. He has created his own database of his patients, writes code to analyze that data, and believes in educating the masses on the power of nutrition and lifestyle for cardiovascular health. Welcome, Dr. PV, to the Metabolic Health Conference 2024.
Yeah, thank you very much. At the outset, I'm thankful to Mr. Shashikant Iyengar and Mr. Anup Singh for giving me this privilege to talk to you all the people. And also, I'm thankful for the kind introduction to Sandesh Bhatt. So, I am ready to answer some of your queries regarding the cardiovascular disease patterns where my expertise is there. And also, I applied low carbohydrate in personally, and also in various patients, they come to seek for our advice, and some of them listen and some of them practice. In that way, I can share in the last 8 years my experience with the low carbohydrate in this country.
Great. I think it'll be a great conversation, Dr. PV. Let's start with this question, Dr. PV. I think we'll start with the first principles and foundationals. Please, can you tell us what is cardiovascular disease? Is it a spectrum of diseases, and how should our audience think about it?
Yeah, am I allowed to share my screen with some of the slides? Sometimes
Yes,
I need
doctor.
some help.
Yes, doctor, please do. It's a privilege.
These are the things what are required. I don't know, I'm not able to get that screen now. This is not allowing me to. There is some problem for this. This is, we are not able to get that screen where I am supposed to be having this. Share and no. Yeah, okay. I don't have this luxury of
Okay.
having the screen. So what I will do is, I don't know why I'm not getting that one. I'm not getting that.
Okay.
No, the one is, are you able to listen to
Yeah,
me?
you can go on.
Are you able to see me that? Why I'm not able to share the screen is the question. Suppose if you look at the cardiovascular, it is a broad spectrum of diseases. It is not any one, and they're all heterogeneous group. But classically, most of the people feel the heart attacks and high BP are related to the cardiovascular disease. But if you look at the whole spectrum, there are like congenital heart diseases and some problems of the heart wall. And those are all the part and parcel of the cardiovascular disease. There are some less known are there, like cardiomyopathies, electrophysiological disturbances, and many of these things are included in this one. But for the sake of it, we will concentrate on effects on high BP and also effects on atherosclerosis, which causes the issue for us. So in that way, if you look at this one, what is important for us here, yeah, shall I try again the thing? The foremost, the condition, high BP, if you look at that one, the major concern, the BP is related to the multifactorial. But having all said done, the metabolic syndrome is the main culprit to cause high BP as well as the atherosclerosis. The high BP, if you look at this one, when once you take excess amount of carbohydrate, that produce insulin resistance, and that high insulin affects on the kidney by retaining the more sodium, and to compensate excess amount of sodium, the osmolality changes and retains more fluid, the preload increases, the heart starting higher amount of volume to push, it raises the BP. So this is one aspect. And also the insulin disrupts the mechanism of the aldosterone renin mechanism. And that also increases the more sympathetic activity. And that will increase the burden on the high BP. If you look at the distal convoluted tubule, where the sodium is reabsorbed, and that is the major concern for us. Similarly, this is a small diagram, excess amount of carbohydrate, the insulin resistance, and the hyperinsulinemia. There are two aspects of the insulin resistance. These are the two sides of the same coin. One is the insulin resistance because of ineffectiveness of insulin. Second is some of the tissues in the body, they don't respond similarly, just like what they are supposed to be responding to insulin. But at the same time, there are other tissues in the body, they over-respond to the high circulating insulin. So in fact, we will see both the things like the insulin resistance as well as the hyperinsulin. So we see the both effects in hypertension that results in the high blood pressure. Similarly, if you look at the atherosclerosis, it is a process of multifactorial again, having said that one, but most of us concentrate on cholesterol and its metabolism. And we know for good reasons or bad reasons, we know cholesterol is not a culprit, or maybe at the most it is a saver for us to prevent the heart attacks in a larger sense. But there is some controversies about that. But having said that one, The cholesterol is the one which is the result of, again, insulin metabolism and high amount of insulin resistance. The HDL will be decreased, and also the triglycerides will increase. The ratio of triglycerides and HDL alters, and the end result is a atherosclerotic process, particularly when oxidized small density LDL is present. This is how we get the disease pattern. And many of these things, having said that, multifactorial, but if you discuss in a nutshell, there are three important factors. One is for heart attacks to get the stress, two is the insulin resistance, three is the inflammation. And most of the people agree the stress and inflammation also increase the insulin resistance. There is a two-way reaction. It is not one way. So the insulin resistance causes stress, and also insulin resistance causes inflammation. Same way, the inflammation and the stress, they're all interrelated, and one after the other, they cause all these issues. And we know this is the basic pathophysiology, wherein the carbohydrate excess, particularly refined process, and insulin excess results in a high BP and also heart attacks. I hope I clarified some of the doubts about it.
Yes, doctor. I think it was very enlightening, especially the part that you mentioned about stress, inflammation, and insulin resistance. I think the common man always would wonder which comes first. But what you use the word multifactorial, I think that really helps address, and we need all three to be taken care. So thank you so much. I'll move on to the next question. If there is, which of the CVDs has been most associated with metabolic syndrome? Is there like one CVD amongst the total spectrum of CVDs where you think is most impacted?
Yeah, the question is almost all. The common is once if you know the Indian setting and various diseases, suppose if you are born in India, there is a more likely chance you have got nearly 6 times higher than the white Americans to get a heart attack. And when compared to the Japanese person, you got a 20 times more chance to get a heart attack. And similarly, about if you are Indian, there is a more likely chance that you are going to get a heart attack less than 40 years, 25% of the heart attacks. So even if you get a heart attack, another important question is the type of disease what we are seeing in India is much more severe form than in the Western. It is not an isolated block in one particular vessel or two vessels, but what we see is a more diffuse disease that is a much more difficult to amenable for even bypass grafting. Many times we have to remove the core of the atherosclerotic process inside, what we call as endarterectomy, and then they do the grafting. So that kind of a severe form of disease we see in very young people in India. This is not only, unfortunately, we don't have enough data in this country, but the people who migrated from this country to other country, when once they analyzed their data, and those people had a much more higher incidence, even in America or Australia or Europe, when they were migrated, they were not accommodated just like other European, other American. They behaved like Indian, and they are much more early prone for the various diseases. One small study like India, intra-heart study, that has shown from the 2010 to the 2015, nearly 27% increase in young population of India. That makes us worry. So in that way, what we have to look at the various studies, the metabolic syndrome and its relation to the heart attack, this is the commonest form. Probably the second commonest form, what you ask, is the high blood pressure and its related complications. That is the one result. The high blood pressure is the cause for kidney disease. High blood pressure is the cause for the stroke, particularly paralysis. And also the high blood pressure causes so many other ailments in the body, which may end up in so many other diseases like aneurysms, like peripheral vascular disease. Many of these things are closely associated. But the average person or a man on the street is worried about heart attacks more than any other thing, because the other incidence is less, but heart attacks are more. And if you look at if you look at the metabolic syndrome, is the one like enhanced study in America, they said nearly 80% of the American public who walks on the street are metabolically unhealthy. But the same thing can be extrapolated to this India, the same data. But once we say it is a lifestyle, when our lifestyle and an American lifestyles are different, probably we cannot extrapolate it. So if you can take this some amount of studies in India, and in some of the issues, if you look at that one, like for instance, in the world, for every 34 seconds, one person is dying with heart attack. It is a very, very staggering number. Every 34 seconds, one person is dying because of heart attack. Similarly, every 3 minutes, 17 seconds, one person is getting a stroke. These are the two significant morbidities that what we are getting. But both of them are having a significant relation to the metabolic syndrome. But in India, we have got another peculiar situation. We have got a triple burden. One is we have not solved the malnutrition. Still, about 20 to 30% of the people suffer with the malnutrition and hunger. And we have got that issue. And also equally, we are competing for the obesity in the rest of the world and the heart disease. So this triple burden, not only India, all the developing countries like India, China, Brazil, etc., many of these countries are suffering. If you closely look at the disturbing one, every 34 seconds, one person is dying, the heart attack. The heart attacks are not suddenly, they don't appear. They takes about 10 years before they manifest as a heart attack. But most of the people, suddenly they know they got a heart attack. And most of the people are aware, suddenly they're aware of it. But the disease takes about 10 years. The commonest risk factors, if you look at the heart attacks, nearly 10 times more chances to get a heart attack if you're a diabetic. To some of the studies, they clearly told if you have got a heart disease, that is equal to diabetes. If you have got a diabetes, that is equal to heart disease. Even suppose some people who come for a bypass surgery, when they say they're non-diabetic, and when once we test them more closely, like a more sensitive test like HbA1c and other things like insulin, some of them will be found. The same thing happened in a European study, Aspire study. If you don't find somebody who got a heart attack, and if he is non-diabetic, that is undiagnosed diabetes. It is not that he doesn't have a diabetes. It is only indicates undiagnosed diabetes. So that is the severe form of that. Similarly, not only diabetes, high blood pressure, 4 times higher, they get a chance of heart attack. Similarly, metabolic syndrome, that's what we call insulin resistance syndrome, that acts another 4%. In addition to that one, somebody is obesity and somebody is smoking. Nearly about 70 to 80% of the causes for heart attack, these are the ones. Unfortunately, most of the people concentrate on cholesterol, like LDL cholesterol, and they start taking statins, that contributes only 5%. So nearly 95% of the hazard risk factors are neglected, and they're concentrating only 5%, thinking that is the one which is going to protect their heart, and that's how they are going to live. Even if you look at the metabolic syndrome in this country, somewhere years back, Srinath Reddy from RNA Institute did a study. He could not identify from various criteria of metabolic syndrome, not more than 40%, and as low as 13%. Of late, somebody did it from Karnataka, that showed equally not more than 35% of Indian origin people in India are having metabolic syndrome, those 3 out of 5 criteria. And most of you are aware of it. So if you can find out those things to qualify somebody to be metabolic syndrome, the studies, of course, there may be some limitations, and we cannot extrapolate this Western data to Indian because their diet is different and their lifestyles are different. Probably we have to give a more concentration of our Indian studies. Yeah.
Fantastic. I think, I think some of the stats that you just shared is just, eye-popping. And I think one common thing I, learned from what you were sharing, I think the elephant in the room is definitely, the diabetes and the metabolic syndrome, and not necessarily, cholesterol. So thanks for sharing that insight. Very, very useful. I think especially for the common man, we generally do not associate one disease with another. We generally associate each separately, but I think the way you're teaching us to look at it holistically is wonderful. I'll move on to our next question, Dr. PV. And this one is in everybody's mind, and we were all told to eat in the past a low-fat diet to avoid atherosclerosis, and that's something you already called about atherosclerosis. Everyone followed it. We all follow rules. But things have only worsened all over the world, and India is no exception in the last 30, 40 years. What is really going on here? We know that people under 40, 30 are also getting heart attacks, but we are generally following a low-fat diet, which was given to us by the authorities. Can you elaborate a little bit more on what we are doing wrong here?
Sure. If you look back, the first myocardial infarction heart attack was diagnosed in 1920. Before that, we don't have a diagnosis of heart attack. Even the so-called great aspiration, like William Osler, has seen about a handful of cases in his lifetime. A disease so rare in 1900 has become a #1 killer today. So there must be people attributed to genetics and in the lifestyle. To genetics to change within about 100 years is difficult to assess that. Maybe epigenetics, as you all agree. The epigenetics come from our environment, our diet. So in that way, they may change the genetics too. But once we have to understand more the lifestyle, but initially we blame the refined processed carbohydrates. But there are some studies they clearly showed that may not be correlating to our particularly red meat and also the seed oils. These are all the things now they are blamed major contributing factors for the heart attacks. Similarly, diabetes. But there is in between what happened 1921 is the year where the insulin was discovered and in the management of diabetes has been changed. Before that, the diabetic management was low carbohydrate and healthy fats. But once in the 1920 till Second World War, heart disease was not so common. When once the Eisenhower got a heart attack, the whole world paid an attention to that. So some of the scientists were pressed and they given a short time. And some of the people are more enthusiastic. They identified by limited study, and also they studied from the herbivorous animal like a rabbit, and they extrapolated when they fed the rabbits with a cholesterol diet, and they produced a heart attack. And so that is an evidence to believe heart attacks are caused by the cholesterol. So ever since then, and also his voice is powerful. He's a charismatic leader, and also he's got a big voice in the American government, and he proposed this theory, and he conducted the data from the 22 countries, but ultimately he published it in 7 countries, which focused only on the cholesterol. And at that time, we don't have a statistical powerful methods. We are like a multivariate factors. We did not understand. So we identified that factor. We accepted that. So since then, we demonized the fats and we avoided all the saturated fats and we started eating carbohydrates. Then the problem started. Instead of solving the problem of heart attacks, this has increased and reached to the level of #1 killer. And it is not even coming #2. So that is the situation, whether it is a developed country or underdeveloped country. So now there's so much of research has been put in, and they question the original theory of enthalpy, whether is it true or not. When once retrospectively analyzed the statistical methods and the data and all the corrected 22 countries' data, is been not correlating. So now they're rethinking about the contribution of saturated fats. But still, some of the people like Goldstein had a theory for which a Nobel Prize was given. It cannot be easily brushed off. So they started more research into that, and then identified not only just cholesterol, there are some other factors that are influencing the cholesterol. That is the one where we are much more lower fractions like a SDLDL, that's what a small density LDL cholesterol, lipoprotein little a, and many of these factors, lipoprotein B, various fragments we are identified, we are able to correlate now probably the cholesterol is not the main culprit. The other fragments are culprit, and for which the diabetes is contributing. If it is not oxidized, if it is not glycated, and the sugar is not sitting on the lipoprotein, probably that cholesterol is not bad. So now we shifted our thinking, and now we are concentrating more on other aspects of this. Right?
Yeah, fantastic.
So,
Thank you. Thank you so much for sharing. How would you think of the significance of a low carb, high fat or a keto diet with regards to our cardiovascular health? As we were talking through before the session, you have your own personal journey. So I think people will definitely associate personal stories that to coming from a cardiac surgeon like you. Can you talk to us a little bit about the LCHF and keto diet and how it helped you and how you've gone through the personal journey yourself?
definitely, I'm a well-disciplined man. Like Rama is a good boy, and always studied well, and then got through the various exams, and then reached the highest levels in our field. So we followed the book, and for that, I practiced nearly 35 years the same thing, cholesterol theory, and then I believed I have done nearly 20,000 bypass surgeries to the people whosoever come. We fixed their bypass surgery with a new graft. So for some people, we put it 2 times, 3 times also. The same person has to undergo the bypass grafts. So then at that time, we all believed this is all what we can do. Then in which the process, I developed diabetes. And very short period, within 5 years, I became insulin dependent. And 80 units morning, 80 units in the evening. So, and also I developed so many other issues like a BP. And total I was on 13 drugs. So in the process, I'm not able to manage my own diabetes with the insulin, and I'm getting hypoglycemic episodes and getting a difficult. Then I look for the literature, how to control the diet and then the insulin to rectify the inadequate performance of my blood sugar. In the process, I ended up in one of the journalists, science journalists like Gary Talk, just like many people. I read his book, Good Calories and Bad Calories, and opened up my silos, and then I went to so many other books, and then I realized, why can't I do it? All my colleagues, all my family members are doctors, they are opposed for my starting a high-fat diet, because every day I'm operating at least 2 to 3 people whose arteries are clogged with fat. So I had took nearly 9 months time to recoup and to get a courage. After reading the literature, I started experimenting on myself, and within a few weeks' time, I could see some changes. I lost in the process about 9 months, 23 kgs weight, and also I gave up all the medications for diabetes, but still continued some medications for the BP. And my journey started like that. When my colleagues, my friends are cardiologists, when you could achieve that one, why can't you extrapolate it to the other people? So we started that one in 2015, and up to the 2024, I could, in between the COVID disrupt so much, and our data collection, so many other things also were disturbed. So in that way, if I look back, many people were patients who come to us having undergone a bypass surgery, they got a reasonable faith in us. So some of those people, when they start listening, when once we persuaded them, there are other methods, some of them listen. Like that, if I look back my data, except the COVID period, my data became noisy. And then there are more than about 2,000 cases I have got in my database. Nearly about 881 I could recollect immediately from the database, this one. The diabetes is the highest number of cases. Next is the obesity. These are the 2 major components they participated. And then I looked for that, how many people got benefited and how many people came for a second visit at the end of the 1 year. If I looked at one, not more than 23% of the people came for the second visit after first year. If I press hard, if I look for 8 years, probably my figures will be much more disappointing. So that's how we thought how best that we can implement, how best that we can persuade the people to continue about this one. And in the process, I have to write a book, and then I have to publish it to make the people. And this is the book. Unfortunately, my slides are not seen. So this book we published, and this is a book for a recipe to recipes, and then the people to prepare their own diet and also to measure it, to collect the data, what they are eating, how many carbohydrates they're taking, and they can frequently visit us and revise the fine-tuning of the diet, depends upon their performance, depends upon their test results. This is how we are implementing for the last 80 years, and a fairly success story. And at the same time, we had so many unsuccessful events because so many family members used to persuade them not to continue this one because of the apprehensions and the fear. So just like any other low carb practitioner, I'm also facing some health distractions to our patients. That's why I start doing a family counseling. I call all the people, even though they're not came for the counseling, even though they're not got tested, but still ask them to listen to us what we are saying so that they don't be persuaded them not to do the test. So at least if they're not obstructive, if they're not helpful, they're not obstructive. So that is the philosophy in which we adopted, and we reached a stage we are able to get a more number of all these people. And the most important limiting factor, what I think, is the majority of us, we say the carbohydrate predominant diet. But if you look at that one, we are not predominantly taking a carbohydrate. What is required for any body is the protein requirement. Till you get your protein requirement, you have to eat protein, then only your brain gets a signal you are satisfied. And then you'll stop eating afterwards. So when once your primary item is the grains, like a rice for a South Indian or a wheat for a North Indian, roughly if you look at 100 grams of the rice contains about 7 grams of proteins. So for an average person to get a 40 to 50 grams of a protein, you have to eat at least about a half kg rice. That's how the people are eating half kg. But the problem is not the protein we are getting, okay. Then everybody thinks nutrition, we are not getting protein. It is not true. We are getting protein, otherwise we might have died. And then probably many people might not have reached to the, even bodybuilders are there. Many people who are pure vegetarians also, they build their muscles.
Yes.
So it is the question of essential amino acids, how to take in a combination. Like a South Indian person, if he mix with the dal and the rice, probably they can compensate. That's how they used to do. But at the same time, the protein requirements, if they don't follow because of economic reasons, because of some other reasons, it is the one which formed a addictive process. What we are facing now, how to replace that protein from the rice to the other areas. If I can substitute protein from the all other areas, probably I can persuade the people not to eat so much of rice. I'm not able to do that in spite of doing so much of a hard work from which component, which dietary food we can supply those proteins. Fats are, of course, they are needed, but not so much, as most of the people realize. At the end of the day, you can limit even fats. Otherwise, they themselves, when once the excess amount of fat, excess amount of energy in any form, they release the free fatty acids. That is one of the cause for insulin resistances. Many of us think only refined processed carbohydrates. When once they become the fat, that fatty tissue liberate the ceramide and diacylglycerol. These are the two things. Similarly, like inflammatory products like IL-6, many of these things, particularly ceramide, is the one compound which can cause problems to the most of the insulin and also insulin receptor. That's how we end up in insulin resistance because of the diacylglycerol and then the ceramide. To reduce that one, we have to limit even up to the extent we have to give a priority to the protein and don't afraid about the fat and take adequate amount. And also when once we are removing the carbohydrates, particularly refined process, we have to give them some other alternative for energy source. For us, the energy, only carbohydrates and fat. You can't get energy from the protein. It is an expensive process. So the body doesn't prefer a protein as an energy source. So when once we are cutting down carbohydrates, invariably we have to give some fats. So how much fats to give in also is equally important. It is not just a fat diet that is important. It is the more important healthy fats. As I told you in the seed oils, they are the unhealthy fats, and everybody is focusing on seed oils. Particularly, it disturbs the ratio like omega-6 and omega-3. And omega-6 is nearly 20 times or 70 times, particularly like safflower oil. Even like the best of best, what we can get, like olive oil, like a omega-3 is slightly more. But even then, if you heat it, you will get a disproportionate amount of omega-6, and that may not be most suitable. So in that way, if we can avoid seed oils, at least about 20 to 30% of the problem is addressed. If you avoid refined processed carbohydrate, another 30%, 60% of the problem is immediately addressed. So for which we design the various methodology, various tastes, depends upon that. And we give a recipe how to cook from their own homemaker or a spouse, or the other people who are helping them cooking, so that we can give the guidance and we can implement this one so that they don't have to give it up by the listening to some Subbulakshmi, Venkatashmi of next door girl. So they can pursue this one for a longer time so that they can get the results. Once they get the results, they get motivated. This is how we are planning.
That's great, Doctor. Just if you can, a follow-up question on the fats that you mentioned. For you, what are the right fats that we should be using, from an Indian or an Asian context for our cooking?
The dairy is good enough if they can tolerate. If somebody is not able to tolerate, dairy is bad. But somebody is tolerating dairy like paneer, like the one that comes from the butter is equally good. Similarly, the ghee, which you don't require a preservation like a refrigerator to keep the butter. Suppose, but only one thing is, by the become butter to the ghee, the casein protein will be precipitated in the process of clarification. When once the butter is melted, the casein gets precipitated, and it will be less amount of protein. But that's what we want. That's how it doesn't become rancid, and you can keep it outside. And the ghee is one of the good sources. Similarly, for a South Indian, the coconut oil also is very good, and I strongly recommend coconut oil, particularly the medium chain triglycerides. They are not there in any other thing. Maybe they are there in kernel palm oil, which is not supplied to us. Once if you remove the kernel, the plant dies. That's why it's very expensive. Kernel palm oil or a coconut sugar, these are not available for us, but coconut oil is freely available. Particularly if it is a virgin and cold pressed, the medium chain triglycerides will be preserved, and that directly goes into the portal circulation and enters into the liver and will be converted easily into ketone bodies. And these are the ones which are signaling factors, helps you to mental disorders, even once the general ketone bodies are less, even though if it is 0.6, 0.5 most of the times. Even then, when once they consume coconut oil, they will have a higher amount of ketone bodies circulate, and they go to the brain. So in that way, the coconut oil is better. Next is the butter, next is the ghee. Like that, they can choose.
Fantastic. I think that is very specific guidance, Doctor. Thank you. Thank you so much for that. I want to go a little bit away from the science, and I also want to hear, at this stage of your career, I was told your colleagues, students have been wanting you to not do as many surgeries, but help coach and, transform the society, encourage the LCHF and lifestyle changes in the masses. What are you planning in this regard, and where's your mind at right now?
Many of the sports personalities inspired me. They should retire when they are performing well. They should not wait till the people ask them to retire. So I was able to do very well the cardiac surgery, and at least 2 to 3 per day comfortably. At that time, that is one of a high record of mine. And at the same time, if I wait for too many years, probably my performance will come down. So I took an advantage.
You're very modest, Doctor.
No, I took an advantage of that one. I quit 2 years before when I had a COVID. I suffered the COVID disease, and I was forced to take rest. At that time, I thought if I don't do the cardiac surgery, the whole world is going to collapse. That was my concept. But COVID opened my eyes. Even when I did not do surgery, the world is going as usual. So probably only I am exaggerating my position rather than my need for the rest of the society. And all the time, and once they saw me, all my colleagues and other things, you stopped for 2 years not doing major surgeries. Why don't you continue and do the low carb diet where you are helping more number of people and more families and also more diseases. Previously, I used to do only 5 types of surgeries: one bypass surgery, one valve replacement, or closing some holes in the heart. But now I'm able to treat mental disorders to the bowel disorders to the autoimmune disorders. So in that way, the scope has increased and also satisfaction level have improved. This is how we want to continue. Still, I have got a physical ability to do more of this one. Till as long as I can do physical and mentally, I'm agile. We want to continue in this low carbohydrate movement.
I love your passion. When I speak to you, I hear the term learn, unlearn, relearn. I think learning is such a integral part. Where as I speak to you, and you were also telling me about all the data that you are collecting about your patients and what all the studies that you are doing. So on that note, I also wanted to ask one more question here. You have designed a computer-based cardiac surgical database, and you've used that data for a long time. Can you tell us more about this and where you want to take that data in the future?
Yeah, initially I am academic. I'm a professor of cardiac surgery. When we wanted to publish the data in the foreign journals, once we send the data, they told me that we cannot publish this kind of a data. We need a database and a validation properly. At that time, that is 1999, I never heard what is a database. And also we are intimidated to look at the computer also. So once we asked them to supply a database, then even not only me, another 3 generations of my family earned money. I cannot purchase the database at that time. So that forced me to learn the database and computer, and I constructed a database equal to a state database for cardiac surgery in a cardiac surgery, and I became a national coordinator for cardiac database. So for all the diseases, nearly about more than 15,000 cases data we have got in the cardiac surgery. Similarly, once we extended our journey to the low carbohydrate, we extrapolate the same thing. Here the problem is initially we did in Oracle, which where we thought robust. But once we started distribution of the application, many people did not own the licensed version. So that became a big limitation. So then I have to learn a VBA, relearn that, and then I have to create in a Microsoft Access, which is bundled with most of the Windows-based the Microsoft Office. So in that way, I moved to that platform, and we created in that, and we are well versed with that. Anybody can be trained in this VBA-based Microsoft Access database, and they can analyze their own data and they can publish.
Thank you, doctor. I think that is extremely interesting, because even in D-Life, we have so much data of our own D-Life members and clients, and our founder Manup Singh has collected a lot of data across spectrum of the metabolic syndrome. So it was very pleasing to see, and data speaking through the data has given us so much credibility for the total low carb space. So thank you so much. I really appreciate your time for sharing your knowledge with us, your time with us, your interest with us, and I was very fascinated with how you want to see the future unfold. I'd love for Shashi and Anup to join us here for a last couple minutes.
Dr. Previous, thank you very much. I think thank you very much for joining. I think you have one of the vast experience, and that too being a cardiovascular surgeon. I think it's all the more important that we realize that how the metabolic syndrome affects the cardiovascular system. And with all the database you have and the kind of surgeries you've done, you have a vast experience and the whole knowledge. And I think we need more such doctors like you. Not only that, but you need to get everything published. So all your case studies. Maybe you can start as a case studies, get some publication, but I think you need to, there's something which will be very, very important. Even if it is just a few case studies, itself is very important. And rightly so, you have that correct idea also. Yeah. Yes, doctor.
Yeah, we appreciate that. With that mode only we started. I started presenting in various conferences. We have a lukewarm response, just like as most of the people feel it. That's the reason why even the publishers like a mainstream journals, they don't like this kind of a thing. That's the reason why I have to book my own, and then I have to publish that book under my name so that nobody else can be interfering with that. So similarly, if we can do it collectively, even the main journals may not publish it. You are have so much of experience like D-Life. If there is a structured way database, we can write books on the diabetes of Indian experience. All the time we are quoting about American experience or Australian experience. That is again a big gap, their lifestyle and our lifestyle. For an Indian perspective, we have to collect our data and we have to publish our own. Even they may not be published in the mainstream journals. We can publish our own books and we can circulate it. So that is my strong suggestion. The only thing is everybody has got data, anecdotal, but that is not unless it is structured, unless statistical analysis has been done, that has got no meaning. So please take forward. And if anything is required from my side, I'm reasonably good at statistics and also database. We can take it a logical end to up to the publishing.
We'll do it, doctor. Thank you very much. And we'll stay connected, and there's a lot more work to do in this space.
Yeah.
Thank you very much.
Thank you so much, doctor.
Thank you very much for giving this opportunity.
Thank you, sir. Thank you, doctor.
Bye.
So please get Dr. Josephine and Kunal.
Kamusta? Namaste.
Namaste. I'm okay. I hope you are well as well.
Thank you so much. Welcome to India's second Metabolic Health Conference. My name is Kunal Jain. I'm a metabolic health coach and a proud member of DLife.in, which is India's oldest, biggest, and the only award-winning low-carb platform. Shashikant Iyengar and Anup Singh bring to you this historic and scientific feast from India titled Metabolic Therapies. Let's meet our very special guest for this session, Josephine Grace Rohotan, MD. Dr. Josephine Grace Rohotan, also known as the Diet Doctora, is a practicing rhinoplasty, facial plastic surgery subspecialist in the Philippines. She is a fellow of the Philippine Society of Otolaryngology, and her specialty is diseases of ears, nose, throat, head and neck surgery. She also specializes in root cause medicine. On the side, she studied nutrition and discovered the benefits of a low carb eating method and therapeutic fasting for healing and health optimization. She has a large following on social media platforms like Facebook and YouTube, where she posts valuable content to educate people about the benefits of a low carb and fasting lifestyle. She has LCF masterclass programs for lifestyle diseases like diabetes, hypertension, obesity, asthma, multiple forms of allergies, fatty liver, tumors, and even cancer. She has authored the Perfect at Last book series and has also organized the National Low Carb Day NLCD Philippines, which is the largest in-person gathering of low carb practitioners in our country. So before we begin our discussion on metabolic therapies, would you like to greet our audience, Doctor?
Hello. I hope you can hear me well.
Yes, I can hear you well.
Yeah,
Thank
Sir
you.
Kunal, thank you very much for that very nice introduction. And first and foremost, I would like to thank you and the rest of the team, Sir Anup Singh and Sir Sashi, for inviting me to be a part of Metabolic Health Conference 2.0. I'm very, very proud of you guys for doing this, and I'm very honored to be a part of this conference.
Thank you, Doctor. It's our pleasure to have you here. Thank you. So let's begin. I would like to ask you this question first, that being a mainstream doctor, what compelled you to come into low carb and fasting lifestyle for yourself, your family, and your patients?
Yes, so thank you so much for that question. So I know I also studied the same way as many doctors, studying the standard diet, the recommendations, especially by American Dietary Guidelines. But after graduating medicine, I think I've been practicing medicine already for around 5 years, that time, 4 to 5 years. I've come across one video educating about the importance of fasting. And from there, I already saw many groups from all over the world, international groups, and I have seen a lot of almost miraculous healing, something that we've never seen before in standard medicine, like a person weighing 300 pounds after just 3 months lost the whole half of his previous weight, and people who've had cancer, who've had diabetes, who've had hypertension, cardiac problems, who've healed their conditions based on just lifestyle change, just changes in food and also incorporation of fasting. So from there, I did my own research, especially that my family also had a long history of diabetes. My father and three of his siblings all died of diabetes complications, all before 60 years old. And they were very, very compliant with medications. Before, I feel like I'm failing him as a doctor, knowing that I'm a doctor, but I can see his condition deteriorating, even if he is very religious with his medication. That's when I start to ask, maybe there is something wrong with just our standard recommendation of pharmaceutical recommendations, medicines. Maybe that's not enough. And true enough, when I discovered about low carb nutrition, I went back to my biochemistry book, first year biochemistry book in medical school, and it is still there. It's all there. Low carb nutrition really supports healing through, as we will discuss later on, through the lowering of insulin triggers in our body. So from there, I started applying it with myself and together with my mom. Just too bad my father already passed away that time, for around a year ago already, before we discovered low carb. But the whole family is now practicing low carb, especially our in-laws. And as you have said, many in the Philippines are now practicing low carb. And there are hundreds of thousands of testimonials saying from their own experience, from their own experience how they were healed with this kind of diet. So for me, it started with just curiosity. And from there, I experienced the healing myself because I've had health issues also before. I was diagnosed with pre-diabetes in my early 20s. And that one I also reversed with low carb nutrition. And I cannot help but also help my patients. So I practice low carb together with my specialty as an ENT doctor and as a facial plastic surgeon.
Right. That's great. So since you have your specialty in ENT, I would like to ask you, how can ENT patients benefit from low carb?
Yes. So as an ENT doctor, actually, I myself is an ENT patient because for the longest time, I've had allergic rhinitis. And I've been maintaining antihistamines and intranasal steroid sprays daily. And sometimes I even need to overdose myself with antihistamine. Usually it's just given once a day. But in order to control my symptoms and in order for me to be able to do my work on a day-to-day basis, I need to take more than what's just recommended, because after a while, my body seems to have developed some kind of tolerance with antihistamines. And only with low carb nutrition, clean low carb nutrition, and therapeutic fasting that I experienced reversal. Since then, I've never had bouts of allergic rhinitis the same way before. And as you all know, allergic rhinitis is now part of one airway disease. So sometimes it may represent just as allergic rhinitis, but it can also fall into asthma. And from an asthmatic attack, if there's if there's severe cases of asthma, sometimes the patient will have a degree to have developed pneumonia, and that can be a very big problem. So allergic rhinitis is one, but generally, when it comes to the same way as fatty liver, type 2 diabetes are affected by inflammation, the same things are also affecting a lot of ENT conditions, except maybe for infections like ear infections. But even with infections, low carb nutrition can help because the body's response to infection is actually much better. And with just mild antibiotic, not needing high doses of antibiotics, the infection can just resolve like right away. Another experience of mine when it comes to low carb was with vertigo. As you all know, maybe if you know anyone with vertigo, it is considered already as an ENT concern that's going to be their lifetime. Like there's no cure for it. There are many medicines to help it, like beta-histine, but patients with vertigo know that it cannot be completely eradicated. The symptoms will just be milder, but it doesn't really go away. But only with a healthy, clean, low carb nutrition was I able to see patients really have no symptom at all. And just like diabetes, it can be reversible in two ways. The moment you go back to your inflammatory way of eating, inflammatory kind of eating, then those you can expect that diabetes, just like vertigo, can also come back. So it's a two-way process. So if you want to improve those conditions, then you might want to really stay on a healthier kind of eating. If you can forget about sugar, if you can forget about inflammatory foods, those toxic seed oils, then much better. So many cases in ENT and head and neck surgery, even just wound healing when it comes to trauma for those patients that have fractures. I see it on my own with patients that their swelling after surgery and their recovery will actually be much faster. Their swelling will be gone in only 3 days time, and the bruising even, it's not so much as compared to those patients who are not compliant with my dietary recommendations, and as well as other conditions in head and neck like thyroid problems, thyroid cancers, thyroid nodules, or goiter. Those are also caused by many others, including nutritional deficiency. So I know that they can all benefit from low carb nutrition, and I've seen it myself in my practice.
Thank you. You are a firm believer in intermittent fasting. So
Yes.
how does intermittent fasting help in your area of medicine, ENT?
Yeah, so as what I've mentioned a while ago, I actually discovered intermittent fasting first. And from there, I also learned low carb. So I really believe that if you want to get the most out of this lifestyle, you have to really practice both, not just intermittent fasting, but also low carb nutrition. If you do low intermittent fasting alone, you might have a hard time during your fasting window because your body has fluctuating blood sugar levels because you eat high carb during your eating window. But if you eat low carb during your eating window, then there will be no fluctuations in your blood glucose. So you can just go on in a day eating only one meal, maximum 2 meals, because for those, especially for those that needs to lose weight, they can easily just burn their own fats and make it as a source of energy. So intermittent fasting really helped me as my practice also with ENT. The only challenge that I only encounter would be when patients need to take antibiotics, especially strong antibiotics that needs to be taken with meals, or else they might have GERD or hyperacidity that can cause a lot of stomach discomfort. So for these patients, I try to give them, if possible, the twice only dosing of antibiotics so that at least they can still fast for around at least 12 hours in a day. But for those who are needing antibiotics, say for example, every 6 hours, then I tell them that it's okay if you cannot do intermittent fasting for now. What is better, what is more important now is for us to take care of the infection, and that can be well taken care of if you can take your medicine at the right time and you can complete. Anyway, most antibiotic therapies is just around 1 week, maximum 2 weeks, and then they can just go back to intermittent fasting right away. So those are exemptions. So I am a believer of intermittent fasting, but I also believe that there can be a right time for everything, including intermittent fasting. So I don't force intermittent fasting on patients who are breastfeeding, for patients who are underweight, and also for those who are still growing, like children or babies or pregnant women. But the rest, if they can accommodate, if they can do intermittent fasting together with low carb, then I really recommend it. Just a minimum of 12 hours to 14 hours, it can already do wonders. And patients have been very happy with the results themselves. They were surprised actually how they can easily adapt to intermittent fasting. Before, they cannot imagine going on more than 8 hours without food, even after an overnight fast.
Right. Thank you. You have been doing amazing work in terms of low carb and fasting lifestyle in your country. Can you please tell us about what changes you can see happening at the grassroots level, and how is the low carb and fasting movement picking up in your country?
I am so happy to be one of the first doctors in the Philippines to really be open and loud about low carb and intermittent fasting. And after 5 years, it's been 5 years now since I've been openly talking about low carb nutrition. After I first published my books way back in 2019, it's available in Amazon. So it's a 3 book series. It's Perfect at Last Weight, about fasting. It's Perfect at Last Health. It's about what foods to eat in order to heal. And lastly, it's the wellness. So it's an overall package. And those books I published in 2019. So it's 5 years now. And right now, I'm so happy that whenever I go to especially major cities, and even in cities that are kind of rural in area, in origin, there's already low carb food providers. So it's already an option. And every time I see in the grocery with label of keto or low carb or sugar free, it's already, for me, it's already a victory. It's already a start. So, and I can hear like the last time, because we are currently on vacation, that's why you can see some people passing around behind me. And last time, while we were at the airport, we can overhear people behind us talking about low carb, the saying that whenever they do like dirty or not so clean low carb, they feel bad, but they go back to clean kind of low carb or strict low carb. So these are fathers or other common travelers or workers that are already practicing low carb. So hearing that and knowing that they're already stores with franchise of low carb products all over the country, for me, that's already a victory that we can see. And I'm so happy that the number of doctors also who are practicing low carb now is getting plentier and plentier. Not everyone is as loud as me yet or as open as me, but I've seen patients that are telling me that their endocrinologists actually recommended watching my videos. They have obstetricians who are also giving away the food list that I made, the safe, caution, and danger list, the food list that I made in order for them to be guided on what to eat. So that's basically a low carb food list, the strict low carb food list, and the caution one would be the food list on you can consume on low carb but on moderation. And the last one would be the ones that you really have to avoid as much as possible when you can, or take it as minimal as possible. So those are the ground root level of changes that I've already seen. And we are so happy and proud that many people, like right now, we have more than 300 live Facebook viewers in this platform for when I share this our interview right now. And people are also commenting their own journey, posting their before and after photos, not just on weight loss, but also on their laboratory results, how from the longest time they've had HbA1c of 10, 11, 12, 13. Now it's down to 6. Now it's down to 5.5. Even, and my brother's friend, close friend, who's as young as just 37 years old, very athletic and very fit, but had SGPT liver enzymes elevated, and only after a month or two of low carb, it's now down to normal. So those are the stories we hear every day. And even if I'm hearing it every day, I still cannot help but be thankful and be grateful. And it doesn't stop. It doesn't stop to surprise me each time, because I'm just so happy of this kind of health improvement that we see on an everyday, day-to-day basis.
Thank you, Doctor. It's so heartening to hear that the impact you're creating with your work and educating the people. And congratulations to everyone who has benefited from low carb and fasting lifestyle. It's amazing. So coming to the next question, you had recently organized the International Low Carb Awareness Week conference, where Anup Singh and Shashikant Iyengar participated from India. What was the impact of that conference in your country, and how was it received across the world?
First, I would like to take this opportunity again to thank Sir Sashi and Sir Anup for participating. It was received very, very well in the country, in the Philippines, knowing that there were international speakers, there were international doctors, and even the head of the Carnivore, the leader of the Carnivore in the world, also participated in that, Dr. Sean Baker. And yes, we were able to achieve our goal of making an awareness, increase awareness. We scheduled that on the first week of December, just before the start of the holidays, the December to New Year holidays, because in our country and in many countries, those really are time to celebrate and eat a lot. So we want people to be somewhat aware, or so that they can choose better on what food to eat, especially on those feasting times. And in the world, I believe that it also made an impact, no matter how little, knowing that people from first world countries and even to third world countries are already aware of low carb and are already practicing. And it's regardless of your financial capacity. Anybody can do low carb nutrition. Just like an event that I held last month, we had a meet and greet and book signing event. And one person I met there was someone who is working in construction as a construction worker. But he'd been on diabetes medications for so long, and he had been praying that he doesn't want to take medications on diabetes anymore because it's financially disabling, and he can feel the side effects of diabetes medication. And that's when he learned about low carb, and he's very, very thankful. So with a minimum wage, still he was able to do low carb nutrition successfully. So I'm happy that you guys were able to be there on that conference, and just like the same way that we are all in this conference right now. So I believe these are contributing well to our low carb community, wherever that may be. And I hope to continue this kind of conferences in the coming years.
Definitely. So, Doctor, what is the consumption trend of fast foods or all the high carb, low fat foods in your country? And are they impacting any ENT issues in your patients?
Yeah, so I think all countries, all places are just affected by this, not just in the Philippines, because the moment that a certain city becomes a city, a certain place becomes a city, it becomes more urbanized. There's just an influx of fast foods, from local fast foods to international fast foods. Way back in residency, there's already somewhat a running joke around that the moment that there's this top 3 fast food chains in a country, the moment that their number is increasing in a certain place, the number of dialysis center will also increase, because it's like it's not a direct cause effect, but there's a strong correlation that having these fast foods, inflammatory foods, generally eaten on a day-to-day basis, then there's going to be so much toll in the health of the people consuming it. So I'm not saying that it's directly the fast food that's causing it, but it's the kind of food that really people are choosing. So whether it's fast food or it's home cooked meals, but if it's loaded with sugar, if it's loaded with starch, a lot of carbohydrates that can still spike insulin, and together cooked in toxic oils. So the seed oils, the factory seed oils, and those are really the worst combinations. And the moment there's already inflammation in the body, then everything can be affected, including the ear. So there can be ear pain. We've had even patients who've had hearing loss out of nowhere, no direct cause. Again, that's the one I mentioned, vertigo, allergic rhinitis, polyposis, the occurrence of polyps in the nose, and all of the other things that are a byproduct of inflammation are surely affected. So yes, there is an increasing trend. That's why it's a little disheartening that as these fast foods and urbanization indicate improvement on the financial status of a certain place, sometimes it also equates on the worsening or decline in the health also of those communities. So that's why we are being very vigilant, and we are doing our best to make people as aware as possible in order for them to choose wisely, to choose better on what they consume every day.
Right, doctor. Next question is on insulin and insulin resistance. So the question is, why is insulin resistance never taken into account by the doctors, and how? And do you think testing insulin resistance early on can be a game changer?
Yes, I really think so. So, one of the reasons also why I think, speaking on a personal note, why insulin resistance are never taken into account by many doctors is that not many doctors actually understand insulin resistance, because it's already like somewhat a complex idea, a complex concept when it comes to medicine. It's only the specialists in medicine who are actually somewhat more adept on insulin resistance, especially the internists, internal medicine specialists, diabetologists, and the endocrinologists. But for general practitioners, general physicians, insulin resistance is not tackled much. It's only when I started learning low carb nutrition and studying it on my own that I really begin to fully understand insulin resistance. And that's when I became serious in making sure that it will not develop in me or in the patients that I manage. And I think it would really be best if we can directly assess it. It can really be a game changer, because people sometimes it will be easier for them to believe if they have an objective marker, the one that they can see in the lab. The problem right now here in the Philippines, there's it's not as wide open, and it's not as widely available, the testing for insulin level and insulin resistance. Usually it's just an indirect measurement. Like, say for example, the persistence of elevated blood sugar, the increase in HbA1c, and the presence of other signs of metabolic syndrome, the increasing abdominal girth, and the presence of dyslipidemia. But otherwise, the direct measurement of insulin is not that widespread nowadays. And I think even if, although it would be best, it would really be a game changer if there's a direct measurement of that. But I think it shouldn't stop us to still do our best to avoid it, because it can be avoided even without direct measurement of insulin in the person's body.
Right. That's right, doctor. So how can one avoid getting insulin resistant and detect it early on? You mentioned that there are like looking at the person, you can see if the person is getting insulin resistant uh, by the central obesity, etc. So similarly, what other symptoms are there which can be diagnosed early on, and is it possible to reverse insulin resistance, if at all?
Yes. So first things first, insulin resistance, if we can just a short recap about it, it can actually develop when a person is continuously, regularly, and frequently trigger insulin release. So if you always trigger your pancreas to produce a lot of insulin, the receptors in your body, the receptors in the cells that will uptake the insulin, eventually, in a simpler words, it will already no longer work. It will be numb to insulin. So the standard in medicine, that's the reason also why I believe it's not tackled so much. It's because what we do is just give medicine that will force the pancreas to excrete more insulin or force the cell to take in those excess insulin. But that is not sustainable because the effect of insulin in cells will also be not without side effects. There will also side effects, and that's just like development of tumors, of cancers coming from the anabolic effect of insulin, the building effect of insulin. So the more sustainable way to reverse insulin resistance or to avoid getting insulin resistance in the first place is to give your pancreas an insulin break. Make sure your pancreas will get a rest. And how can you do that? Very simple. You just avoid eating foods that will trigger insulin spike. And those foods, number one food would be the sugars. The sugars, the fructose, the starch, which of course we know when broken down will still be turned into glucose. So the moment you give your body that rest from needing insulin, your insulin resistance will go down and you will reverse back to insulin sensitivity. So if you don't have any marker, any way to check if you have insulin resistance, just start with getting a tape measure or a metric. You measure your height on the vertical height, and then you make sure that your abdominal girth is or the size of your waist on the umbilicus level and the navel level is not more than half of your height. So if your height, say for example, is 6 foot, make sure that 6 feet your height. Make sure that your abdominal girth is no more than 3 feet also. And if you can make it even less, then that is much better. Okay, so other signs of insulin resistance, darkening of creases. So that's those are the ones that you can see in the nape and also in the you have your elbows and the other creases. So those things you can check if you have that. And the moment that you feel that you're already gaining more weight, more than your intake, maybe there's already insulin resistance. And yes, it can really be reversed. So for those with insulin resistance that's been going on for, say, for example, 10 years, 20 years, it might take a longer time for it to be reversed. But there's no benefit from you delaying giving your pancreas a rest, because the best way that you can do now is at least no longer worsen that insulin resistance. And that alone can already do so much, and slowly it can be reversed.
Right. So one part of the question is how can we avoid getting insulin resistant? Some of it you have covered, but in short, can you just tell the viewers how it's easy to avoid this situation?
Yes. So very, very much. It can be avoided. First, I think, is if we are educated, if we educate ourselves on how insulin resistance begins in the first place. So as what I noticed, as what I said a while ago, it just begins with a little sugar. When you are still young, say for example, you're still in your teens and 20s, your body can easily process all those sugars, all those carbs. But the moment you reach 30, 40, especially for those who are not physically active, not burning all those extra calories, extra sugars that they are taking in, then you can see that even if they eat the same way, even if they eat even less, but they are already gaining weight more than they did before. And the worst, there are even people who are not gaining weight at all, but who are having signs of inflammation. For others, it can be in the form of tumors. Others, it can be in the form of blurring of vision. Others, in the form of hearing loss. Others, in the form of allergies, adult onset asthma, and all those other signs of inflammation, aches and pains, arthritis, early onset. Now we've seen before arthritis is only seen among elderlies, 60s, 70s, 80 years old. Now we already have people in their 20s or 30s. If you go to a spa, it's seldom you can see senior citizens there. The most people who are going to spa are actually the young ones who's always having achy backs, achy bodies and joints. And they even work in the office. They're not even lifting a lot of weight. And it's because of the inherent inflammation that is in their body. So how to reverse it, how to avoid that? Try to do a food recall, 24 to 48-hour food recall. You can tell me those foods are, and most likely 99% of the time, it's because of the high sugar intake, high carbohydrate, starchy intake, and even those with toxic seed oils, because seed oils may not directly increase insulin, but it can make the cells not respondent to insulin so much. So it can actually worsen insulin resistance without triggering insulin release. Unlike the sugar, who's increasing insulin resistance by increasing so much insulin release. So that's why, as much as we try to educate people on eating low carb, low in carbohydrates, we also educate them in making sure that they also take low toxic oil intake. So it can be reversed. I'm sorry, I cannot hear you. Wait.
Sorry about that.
Okay.
Can you hear me now?
Yes, clear.
Okay. So a common question asked is low carb sustainable? In the Indian context where 40%, about 40% vegetarians are there, they consume dairy and sometimes eggs as well, but they don't consume other meat-based items. And similarly, in the Asian context, um, we all have a lot of grains and seed oils in our food items. So how can we sustain low carb practically in these areas of the world?
So it's really quite challenging, especially for those vegetarians who's consuming mostly just carbohydrates. The way to make it low carb is still possible, but it's going to be a lot more challenging as compared to non-vegetarian. So the hardest part for the vegetarians would be making sure that they get enough proteins and healthy fats from their diet. So the healthiest sources of proteins would be the nuts and seeds when it comes to vegetarians, but they should also be aware of the effect of oxalates that can also have an inflammatory effect in the body. It can increase incidence of renal stones. It can increase incidence of arthritis, even urate arthritis, and also for those who are going into vegetarian, they need to make sure that when they do low carb, they don't go on low calorie. So one way to sustain it, making it a good enough calorie when it comes to the amount of food that they will eat, is to get it from fats. So the healthiest fats that we can consume in as plant-based fats would be coconut oil, especially virgin coconut oil, olive oil, and also the healthiest one would be avocado. So if you can eat avocado on a day-to-day basis, mostly you can already cover your at least 50% of your required fat allowance for the day. And then you can just add nuts and seeds especially those and others that you can add also a good kind of protein for vegetarians would be our mushrooms. So mushrooms are almost 100% proteins. So those things, although for me, there's only very few mushrooms that I can take because other mushrooms are too strong for me. But I think there's already, with the advent of the internet and all the cooking videos, you can already make it a very sumptuous meal. And what's good about vegetarians are those who are taking in eggs and dairies. So you have this it's like a cottage cheese. I forgot what's the name of that one. The
Paneer
yes,
in
paneer.
India.
Yes,
Yeah.
paneer. Yes, yeah, that one. So it's paneer. It's a high protein kind of dairy that you can actually substitute in meat, especially that meat, the paneer can easily absorb the flavor of your spices and all those. So those things you can do. I think the challenge only for these subsets of people who are not eating meat would also the flavors, because they get what we call in Filipino umay, or they get oversaturated with these flavors. They get tired of these flavors. It's just the same way over and over again. And I suggest they experiment on making different dishes, different spices, using different kinds of way of cooking in order for them to have a variety of meal. So one thing also is for them to believe that if there's a will, there's really a way. So for me, it's really sustainable. I've traveled a lot in many countries, and there was also a time together with my mom that we tried doing vegetarian for about 2 weeks. So we tried it and it was okay, but it's just that our body is not so used to it. We felt inflamed after, even if it was a low carb vegetarian. So it's good for those who eat eggs. So eggs, especially the free range eggs, the organic eggs, those are the healthiest kinds. And they shouldn't be afraid of the egg yolk, because as much as it is cholesterol, but cholesterol is a healthy kind of cholesterol. And even if we don't eat cholesterol, our body is still going to make cholesterol because we have a daily requirement for cholesterol in our body. So it's really necessary that we eat that. If we consume enough cholesterol, actually, our liver will no longer overdo. We will no longer make so much cholesterol. And that's why egg is a really good addition to these meals. And as compared to other Asian countries, like here in the Philippines, rice is an everyday staple. So what we do is just remove the rice, replace it with low carb vegetables like greens, lettuce, salads, kale, spinach, all of those. Or for those who are not fond of eating vegetables, they can just remove the vegetables, and their viand or the meat, they can just double it or triple it until they are satisfied. You will be surprised, for those who are not yet practicing low carb, you will be very surprised that the moment you do low carb, you no longer feel hungry every 2 hours or every hour. The moment you do low carb, you can sustain 12 hours, eating only once, eating only twice in a day, and that's already good enough. You don't need to always reach for that sugar high, because we are no longer dependent on sugar, on glucose as a source of energy. We can shift from ketones as a source of energy, fatty acid as a source of energy, and also glucose. But it doesn't need to come from sugar and starch and other high carb foods. Our body can actually create glucose through the process of gluconeogenesis. So
Definitely.
those things.
Right.
Yes.
Thank you, doctor. A lot of questions to ask you, but we are drawing to the close of our session. So I would like to bring in Shashi and Anup.
Anup is here. Okay, anyway, so
Hello.
if Anup is here, Dr. Josephine, thank you very much for accepting this invite and coming to India virtually to address us. And we love your work, the kind of work you are doing there in Philippines, and you also organize the largest in-person gathering, and your low carb program before the season. the New Year season when people will binge on all those sugary processed stuff was very interesting. And we really enjoyed talking in your program also.
Thank you so much, Sir Shashi, and thank you for inviting me.
So we look forward for more and more such associations and collaborations in coming time. And I think we being in Asia, we have the common issues of more and more ultra processed coming in, foods coming in, and more metabolic disease spreading in. So everything seems to have a very common foundation. So let us collaborate with each other and fight this metabolic disorder or fight the metabolic demon.
Yes. Definitely, we will fight metabolic disorder. And of course, I want before I end, I would like to highlight Dr. Don Agpopra, who's the one who linked us. So Dr. Don Agpopra, I listened to his talk a little while ago. It was very enlightening. Him practicing neurology and also low carb. So we live in different parts of the Philippines, but we collaborate, especially on the National Low Carb Day. So hopefully, I know it's quite a stretch, but if ever you can come on October 6th here in the Philippines, we will have our National Low Carb Day. It's already going our year 3. It's already on the 3rd year of National Low Carb Day, the biggest gathering of low carbers in the country. More than 1,000 going to 2,000 all in all for live face-to-face attendees and hundreds of thousands of online attendees. So thank you so much.
Thank you very much. And hope to see you in person someday. Thank you very much.
Hopefully. Bye-bye. Thank you very much. Thank you for having me.
Thank you so much.
Namaste. Thank you.
Please get in Akmal and Mandar.
Hello, hi. Hi, everyone. Welcome to India's second Metabolic Health Conference. My name is Mandar Gadre. I am a metabolic health consultant and a very proud member of DLife.in. DLife is India's oldest, biggest, and the only award-winning low-carb platform. Shashikant Iyengar and Anup Singh have brought to you this historic and scientific feast from India titled Metabolic Therapies. And now let's meet our very special guest for this session, Mr. Akmal Al-Bhatti. Akmal is a health coach and he has put his own diabetes into remission by studying nutrition and following first a keto diet for 2.5 years. And then currently he's on the carnivore diet since last 1.5 years. He has a very interesting personal story that we are going to ask him more in detail about. Thank you, Akmal, for joining. I'm looking forward to the conversation.
Thank you very much for inviting me.
Thanks for joining. So let's get into it. So first, I want to ask you, could you please share your background in brief and especially on your health journey? And what was the trigger for you to start taking a deeper look at nutrition?
It all started, I started my journey into learning about health and nutrition in March 2020, immediately after I was diagnosed with type 2 diabetes with an HbA1c of 11.7. And my commitment to health intensified further when I was unexpectedly told I had melanoma, a type of skin cancer, which fortunately stopped from spreading. While illness is often viewed as a suffering, I see my diabetes diagnosis as a blessing in disguise. It prompted me to learn about health and diet, a path I might not have explored otherwise. As you have mentioned, for the past 4 years, I've been following a ketogenic diet, 2.5 years being on keto, and since last 1.5 years on a carnivore diet, healing myself with every bite. Being passionate about health optimization, I preach what I learn and practice on myself. I help people in my community with advice related to their health and diet-related issues. So that's a brief intro about me.
Perfect. Thank you. It's quite an inspiring story for all of us, and I'm going to get into some of those details. But I also noticed that, in your online persona, you call yourself carb-free, right? Carbs-free. So, how did you first come across this way of eating? Because this is not what is generally told. So can you please develop that contrast for us, for our viewers, that what was the typical advice that you got and how did you find out about how to eat and start healing yourself?
In mid-2020, while diving into the world of diabetes and keto, I was binge watching different intermittent fasting and keto experts on YouTube. During this period, Sean Baker showed up as a recommendation. I watched a few videos of him, but hesitated to explore Sean Baker's content more due to the usual brainwashing about cholesterol, saturated fats, and later on protein being converted to blood glucose. But as time went on, in the same time, I noticed that keto influencers were pushing more and more of greens and not recommending enough red meat. In fact, the quantity of red meat they suggested to eat was very small. Almost every video was focused on veggies, greens, nuts, and seeds, etc. I started to feel uncomfortable with keto, as I felt that somehow vegetarianism is being pushed more and more into keto. Me personally, if any day I had more veggies or greens in my meal and no or less meat, I was not feeling well. For example, hunger pangs would kick in quicker and stronger than otherwise. I started to question the need of plant materials in my diet, and then something clicked in my mind that I'm doing keto and have reduced carbs intake. Most of the fruits are avoided as being non-keto. And I was only consuming berries occasionally. Starchy vegetables are non-keto, and I was consuming above the ground vegetables. And this made me feel good compared when I was on a standard diet. Now, what would happen if I completely eliminate the remaining carbs and plant materials? This time, luckily, 3 different carnivore experts, including Sean Baker, showed up as a recommendation on YouTube. And then during the last quarter of 2021, I started listening all the videos in their respective playlists, starting from the oldest to the newest. I was listening these videos whenever and wherever I could, while commuting to and from the office, while walking in the evening, while having my meals. This took around 9 months. And then I found some more experts who are a wealth of information on the carnivore diet. So in September 2022, after increasing my meat consumption since a month and feeling significantly better, I made a decision to switch from keto to a carnivore or a zero carb diet. And I have been having red meat and eggs ever since in all my meals and feeling much better than the keto days, even though keto was much better than a standard diet.
Very interesting. One question I have is that these days I notice that there is all kinds of information floating around. So as you mentioned, you have been going to these YouTube videos and some other social media platforms as well. How did you start filtering some of those? Because all kinds of information will come to you, and every author or every speaker speaks quite confidently about their own way, right? So how did you go about filtering that information? Because I think that is going to be interesting to some of our viewers.
Yeah. It started in March 2020, just few days before the lockdowns in the United Arab Emirates. So I was admitted in hospital for 3 days, and throughout those 3 days, I was being administered drips and was discharged after being informed I have type 2 diabetes. On the day of being discharged, my fasting glucose was 252, CRP was 30.76, and HbA1c was 11.7. Additionally, glucose was 3+ in the urine. I was prescribed 1000 mg medication and told that it is for lifelong. And also that dosage will increase and additional medications will be added, including insulin, because of diabetes-related complications will surely arise. This news came as a shock to me. The doctor also conducted tuning fork and joint tests and informed me to come for follow-ups for joint tests every 2 weeks for about 4 sessions to monitor my condition. As I learned more about diabetes later on, I understood that those tests were conducted to assess the extent of diabetes-related complications, with amputation being a potential worst-case scenario. Upon leaving the hospital and with all that in mind, and having no prior knowledge of what is diabetes and its causes, I felt as if I have been left blindfolded in a forest, and I'm searching for a way out. So within the first month, I started noticing that blood glucose levels were linked with carbohydrate intake. So I became extremely strict with my carb consumption by using an app to keep a log of my food.
Okay.
And in this process, I ended up eliminating sugar, grains, beans, starchy vegetables, most of the fruits and factory-made products from my diet. I even lost the urge of tea and coffee and eliminated it. For me, since childhood, I was a meat lover.
Okay.
So I still continued consuming some red meat, although it was lesser in quantities now. But later, a nutritionist advised on completely swapping it for steamed, skinless chicken thighs or breasts. However, instead of swapping all days, I swapped it on some days only. I also was having low-fat yogurt and low-fat milk as advised by the nutritionist due to the known false fear surrounding animal fat. I relied on very few items from the carb exchange list provided, as most of them were carb heavy. So unknowingly, I was following a keto diet. So now when I look at my logs, it was 20 to 30 grams of carbs in a meal in a day. I began to feel better as my body fat decreased and my blood glucose levels gradually normalized. I just wanted to not only avoid getting any additional medications, which I was told I will surely get, but to also get off the single medication I was prescribed. Now here's the interesting part. After a few months, I visited the doctor. He, noticing my rapid weight loss, he asked me if I was following a keto diet and added that it is not safe. I honestly replied that I wasn't aware of what keto was. Upon returning home, I started searching about keto on the internet and realized that my dietary habits aligned with it. So thanks to the doctor for unintentionally introducing me to the world of ketogenic diet. And after 3 months, doctor had to reduce my single medication dosage by half as HbA1c fell to 6.3.
Okay.
And from 11.7. And after another 3 months, he deprescribed the medication, saying I don't need it any longer. HbA1c was 5.3.
Very nice.
And just one more, how they diagnose diabetes. Like later, I learned about the importance of fasting insulin and fasting C-peptide numbers. No doctor had checked it earlier, not a single doctor. Now with normal HbA1c, I was curious to find my C-peptide and insulin numbers, and I remember having to argue with the doctor to have them checked. He dismissed my request, saying I have a normal HbA1c, hence there is no need for the tests. He further said that many people with HbA1c exceeding 10 were managing their conditions with medication and insulin while enjoying normal life, and that I should stop worrying and start enjoying life, even suggesting I reintroduce rice, bread, sweets, etc. into my diet and not be strict and stubborn. I just could not believe what he just said. I then went to another doctor who initially dismissed the need for further testing, saying that once diabetes develops, insulin and C-peptide levels remain elevated indefinitely due to the genetic nature of diabetes. The normal what they say usually. However, I insisted him to conduct the tests, to which he finally agreed. I was mentally prepared that no matter how high the numbers come, I will at least have some benchmark to track.
True.
The results revealed a C-peptide level of 4.99 in October 2022.
Okay.
Followed by subsequent tests showing declining levels, 2.78 in January 23 and 1.58 in April 23 last year. I then remember the doctor's words that diabetes is genetic. And once you have it, it stays with you. And that fasting, insulin, and C-peptide numbers will always remain high. I can only imagine what the numbers would have been when I was admitted in hospital in March 2020.
Right. No, this is, I think you have been on a very interesting self-taught journey, I must say, right? Because you have explored the information yourself. You have clearly experimented on yourself. and proven, first of all, to yourself and then to others, that you can put it in remission. So I think this gives hope to a lot of people who are listening. Also, if I may ask, what was your fasting insulin level? If you tested it, sort of, is there a contrast that you saw there as well?
As I told you, fasting insulin when I was diagnosed was not tested.
Okay.
So, however, the last 3 tests which were done, I have the C-peptide numbers. If you want, I can pull up the details.
No, just ballpark is okay. But got it. We can come back to that. That's fine. Understood. So I have to ask. So you were maintaining sort of a ketogenic range of carbohydrates, right? About 20 to 30 grams.
Yes.
So which naturally meant that you were eating a lot of protein and fat, of course, right? And then, as you know, in our subcontinent, there is a lot of fear of eating that protein, right? And we tend to over rely on carbohydrates, and people are afraid of proteins. So how did you get over that? Because people around you must have asked you, or your, caregivers may have warned you about that.
Ever since childhood, I liked meat. I cannot deny that. For me, a meal without meat was incomplete. And whenever my mother cooked a meal void of meat during my childhood, she used to say that today Akmal will say he is not feeling hungry. As that was my excuse for not having a meal void of meat. So for me, the switch from standard diet to keto was an immediate decision one fine day. And then from keto to carnivore again was immediate one fine day. In both instances, yes, I faced some initial challenges, but I was having the willpower to go over it. Like I remember once I was in my office having my eggs, and a lady seeing and saying to me, "Do you know that the weekly consumption of eggs is around 3, and you are eating 10 in the meal?" Right. I just kept quiet. So there is a pushback, yes, but personally, I've noticed that while there's some fear surrounding protein intake in people in Pakistan, but it's not as significant as the over-reliance on carbohydrates, especially grains, which is surely one of the primary culprits for various medical conditions. In the northern and northwestern regions of Pakistan, people still, especially the older generation, still primarily consume red meat cooked in traditional ways in animal fat. In Pakistan, some influencers and nutritional experts spread propaganda against red meat and animal fat, citing various nutritional studies, which obviously are biased and purely executed. Unfortunately, many people tend to believe what these people say, but some return to their usual meat consumption after a few days. It's a common practice here in Pakistan to have meat at least once or twice a week, especially on Fridays. Whether it's beef, mutton, chicken, fish, and dishes like nihari, organs, brain, testicles, liver are also popular. But another thing which we as Muslims, we fail to notice, that our religion itself has a very significant emphasis on meat. For instance, during happy occasions, like when a child is born, or something great happened in your family, bringing happiness, etc., our religion instructs us to sacrifice ruminant animals like a goat, sheep, lamb, cow, or camel. On Eid al-Adha, also known as the Big Eid in South Asia, we are told to sacrifice ruminants and divide the meat into 3 more portions. One for ourselves, one for relatives, neighbors, and friends, and one for the poor and the needy. There is no mention of cooking and distributing plant items. So in my personal view, consuming carbohydrates is nothing but a waste of time, money, and resources. Furthermore, it only leads to illness, resulting in additional expenses on medical treatment. It is clearly stated in medical textbooks that humans require 0 gram carbohydrates provided that adequate amounts of protein and fats are consumed. If we eliminate carbohydrates from our diet, we will live a healthy life. However, if we keep carbs and remove or keep protein and or fat, our body will only be getting sicker by sicker.
Definitely.
But also many people are not aware that even spices, pepper, etc. contain carbs. For example, turmeric. is 72% carbs. Black pepper is 71% carbs. And in South Asia, almost everyone cooks using turmeric and pepper. We have ruined our taste buds so much that having a food without the laundry list of spices, the food is tasteless. So it will take time for the general public to overcome this over-reliance on carbohydrates.
Understood. Well, one thing I'm curious about is that, as you mentioned, you were a meat eater, or rather meat lover. But help us understand. So, had you tracked your carbohydrate consumption levels, before you were diagnosed, or maybe can you estimate for us so that we get an idea? Because you still had to sort of go through the diabetic journey, right?
It was basically a mixed diet, standard diet. My favorite dish used to be a Yemeni dish called mandi. You have the roasted cut of lamb placed on a platter of rice. It was typical carbs and proteins and fat mix, standard diet.
Understood. So this actually illustrates a good point that, as you know, in the subcontinent, even people who call themselves non-vegetarians, a lot of times they are eating meat, as you mentioned, maybe a couple of times a week, typically, in fact, once a week. That too also in one meal and a few pieces, because it's still not the king of your plate, right? The protein and fat is still not the king of the plate. It's still a lot of carbohydrates. So that's why I was curious about, those levels. Another thing I want to ask you is, you mentioned the right cooking practices, especially the animal fats. So, and I know you also create a lot of interesting videos on cooking, and you spread awareness. So, what are your go-to, cooking oils, or what do you like to use?
During my carnivore journey, I started using tallow, homemade tallow. Then I switched to ghee also for a change. And now recently, since past 1 year, I'm using just chunks of suet, the fat around the kidney of the cow, the fat chunks cut into bite-sized pieces. So I just put it in the frying pan, and the oil comes out, and I put my steak in it.
Perfect. Understood.
And during keto times, I was into coconut oil, MCT oils, and all these things.
Got it. I also have seen sort of your weight transformation photos. So I want to ask you about that as well, because you experienced not just the blood glucose, which I imagine you are tracking, but also you saw differences in how you look. And so, can you please tell us what was the the weight loss journey as well?
Yes, the biggest portion of weight loss happened in the first year.
Okay.
Between March 20 to March 21. And I was before being diagnosed, I was around 120 kg.
Oh.
So currently I am around 80. And during keto, I even reached, someone won't believe it, I reached 53 during keto.
This is very interesting, because here you are saying that you ate a lot of fat and protein, but you lost fat. So it's good for our audience to understand that it's much more a hormonal issue than just a caloric issue.
I'll just add one point here about the fat. Body will keep the fat required. Any excess will be excreted. Hence, you get the loose stool when you're on a carnivore diet. When you have excess fat, it comes out. It doesn't get stored.
Very interesting. So, as you mentioned in the intro, we want to come to your, diagnosis of cancer as well. And then maybe I'm going to just ask the two questions together, and then over to you. So, first of all, please help us understand that journey, and what happened, and how did you find out about it, as well as what's the relation between sugars or carbs in general and cancer? How do you look at it now?
During a routine visit to the doctor in December 2020, the doctor was not feeling okay with my rapid weight loss. He was unaware I was following a ketogenic diet, because he told me it's not good for health. So he told me he wants to do a physical examination of myself to see if he's able to find any abnormality on my body associated with the rapid weight loss. So upon examination, he found an abnormal dark colored patch with an asymmetrical shape. It was located between my two shoulders, slightly towards the bottom. He asked me whether I was aware of it before, and I said I don't recall noticing anything, as it is not a location which is seen easily or daily. He then suggested me to check with the dermatologist to be sure it is not something abnormal. So I went to the dermatologist, and after examining the patch, she suggested conducting a biopsy to send a sample to the lab for further analysis. When I inquired if it was a cause of concern, she just explained that it didn't resemble a typical mole due to its shape, and that we can only know about it once the lab reports come. So I got the biopsy done in January 21. This was approximately 10 months after being diagnosed with type 2 diabetes. A few days after the procedure, I received a call from the dermatologist informing that the lab report is confirming it is melanoma. I inquired further, and she asked me to visit her, and during the meeting with her, she explained that melanoma is a type of skin cancer. It shocked me. She advised me to consult with an oncologist as soon as possible. I was feeling very overwhelmed by the successive health challenges within the past year. I couldn't help but think about my luck, wondering why, unfortunately, I seem to be encountering a new medical condition each year. Like previous year was diabetes, and now I've got melanoma. I then scheduled an appointment with an oncologist, and the oncologist said that I started developing melanoma, and luckily the cancer cells died where they started and did not spread. I asked the cause of it developing. He said long exposure to sunlight is the likely cause, to which I replied that my job is office related. So, and there is no significant outdoor work here or where I can get exposed to sunshine for long durations. And then he said that sometimes exposure to sunlight, even for shorter periods of time, can result this developing, especially in brown skinned people like South Asians. To which I replied that the part where it is found is always covered, whether I am in my house or outside. So I could not get a clear-cut answer for it. I then asked him also, like, if it is possible to know, like, approximately when did it start or when did it die off. There's no answer from that. Anyhow, then the oncologist now advised a precautionary measure of conducting a full body PET-CT scan to ensure that it is not somewhere else. For the scan, I was injected with a radioactive material tracer, sugary tracer, normally it is. And thanks to God, the results came back clear. However, as a further precaution, doctor recommended surgically removing the flesh, fat, and skin surrounding the area where the dead cancer cells were located. Around 3 square centimeter area. So I then started to search more about cancer and its causes and cures online, and found interviews of people who have cured cancer on ketogenic diet. And then I understood that the reason it did not spread and in fact went away is most probably it had started around the same time when I started my ketogenic diet. So because I had that time strictly removed sugar and carbs from my diet and following intermittent fasting as well, which I actually did for diabetes. And in the end, it turned out to be curing my cancer as well.
Got it. Akmal, sorry, we sort of lost you just for a few seconds. Could you please repeat the last couple of sentences? When you, just to the sugar and the cancer connection, please.
Yeah. I then started to search about cancer and its causes and cures online, and found interviews of people who had cured cancer on ketogenic diet.
Right.
And then I understood that the reason that it did not spread and in fact went away in the early stages was most probably, coincidentally, I had restricted I had actually strictly removed sugar and carbs from my diet and following intermittent fasting, which I actually did for reversal of diabetes.
Right.
So it helped me there.
Perfect. Perfect. Now, this is, I think, first of all, congratulations on putting these conditions in remission. And it's very interesting to know how they are so closely connected. The weight loss, it's a significant weight loss, then diabetes, as well as your personal story on cancer as well. So yeah, very inspiring, and I think it's going to be helpful for our audience. Now I want to sort of come to a macro picture, right? In the subcontinent, as you know, a lot of people say that, okay, I'm sort of using lentils. We view them as, a lot of people view them as source of protein, and they want to sort of mix it with rice, and then they will say, okay, I'm getting all the amino acids. So does it really work for us to get that enough nutrition? How do you look at it?
Before answering that question, is it okay I just go back to the cancer part a little bit?
Sure, absolutely, yeah.
I just share some information.
Sure.
First of all, we have to note that one of the contributors to cancer is the consumption of any factory-made cooking oil, like seed oils, vegetable oil, etc. These were originally used as engine or lubrication oil, as we know. And then someone greedy and unethical decided to sell it as edible to make not some, but tons of money. As per experts, these oils stay in the body for 8 to 10 years. And during this period, they are continuously damaging the cells to become dysfunctional. And then the cells become what is a cancer cell. And a cancer cell requires many times more energy to function compared to a normal cell. So consumption of cooking oil and carbs leads to medical conditions showing up. For some, it might be kidney issues, for some blood pressure, for some diabetes, for some heart disease, for some cancer, etc. But all these issues can be cured if we remove the things that cause and feed it. So I see it this way: the oils, along with other factors, will help create the fire, which is cancer. And the sugar is the fuel for the fire to spread. So, and regarding the second part, like for the fuel sources of cancer, they basically have two main sources: glucose and then amino acid, glutamine. So the easiest way for us to make sure that the cancer cells are well fed is having carbs through the mouth. So in theory, we ourselves are happily feeding cancer cells one bite at a time or one sip at a time. So if we just eliminate the carbs and as for the glutamine, the glutamate, the amino acid, it's very frequent. It's abundant in the body. So for those who are in advanced stages of cancer, can use glutamine blockers strategically, along with some supplements like fisetin, etc., and multiple day fast to get the GKI index lower than 1 or below. It can help a lot. So that I wanted to add there about the cancer part. Now, your second question was about?
So mixing of, so when you do a mixture of lentils and rice and sort of looking at it as a protein source, so what do you think about that?
It's unfortunate that people who have been misled to believe strongly that lentils, beans, chickpeas, or what is known as in South Asia as chana, etc., the go-to staple for health and nutrition. Fats and proteins are a fundamental requirement of the human body. Our body does not know fat and protein. It knows individual amino acids which combine to form protein and individual fatty acids which combine to form fat. However, when considering plant-based sources of protein, it's common for them to be void or deficient in certain amino acids, resulting in an incomplete amino acid profile. Some amino acids act as limiting factors, meaning that if one amino acid is insufficient, a specific metabolic process requiring a certain ratio of that amino acid cannot happen as needed. So what is said is to consume a diverse range of plant-based food items in your daily meal to achieve a well-balanced diet to get all the required amino acids. So we have a platter of what is called a rainbow plate. Then comes the issue to get all the vitamins and minerals. So add in more items to the daily mix of a well-balanced diet. But here, what people fail to notice that under the context of completing the amino acid profile, vitamins, minerals, we are increasing the carbs in the plate. Then there is the issue of amount of nutrients, vitamins, and minerals in the plant items, which as per a report published in USA, is on decline since last 70 years and getting worse. As per the report, there is at least 25 to 50% average reduction in vitamins and minerals in fruits and vegetables so far. Then you have the issue of the effect of anti-nutrients, including fiber, which block the absorption of vitamins, minerals, nutrients by the body from the food we eat. This has been shown scientifically and published. So what we do instead, we increase the portion size. And what we are actually doing, we are increasing the carbs by many folds, just to cover the daily requirement of nutrients. And anyhow, we still cannot get enough of the nutrients from plants, no matter how much we eat. So we are only getting undernourishment, wasting money, and getting sicker and sicker with each morsel and sip.
Excellent point. Also, I noticed that in your way of eating that you have been doing currently, there is no fiber either, right? Virtually no fiber. So, but isn't fiber essential? And, that's what we have been told. So what's your experience on it? And how do you look at the science of it?
Yeah. On a carnivore diet, due to the absence of anti-nutrients and fiber from plant items, body is effectively absorbing as much of nutrients, vitamins, and minerals as possible. Therefore, there is very less waste generated for excretion. Now, note that I'm against keto, but as I was having lots of fiber on keto, as people normally do, my bowel movements were same as that when on a standard diet. Some days even bad, very bulky stool, hard to pass, etc. This was inspired me having too much dietary fat than on a standard diet. But switching to a zero fiber diet, my bowel movements are best since decades. Less frequent bowel movements, easy to pass, less time, meaning saving a lot of time for other things in life. During the initial days of carnivore, it was around 7 to 10 days, but now it is somewhere around once in every 2 to 5 days. Then some people say that fiber softens the stool. However, it has been found that moisture in stool does not vary irrespective of how much fiber and water is consumed. Then a small percentage of, some people say a small percentage of dietary fiber gets fermented in the gut, and this releases gases. And since our gastrointestinal tract is very small compared to a herbivore animal, even a small amount of this gas then causes bloating in humans, which we complain of frequently on a standard diet. Then also, one interesting part here about fiber, during fermentation of fiber by the good bacteria in the gut, a short-chain fatty acid is released, which is important for the functioning of the cells or colonocytes that are in our colon. Like these cells are what are lining the walls of the colon. These colonocytes can get exactly what they need in an easier way through ketone bodies on a ketogenic diet, through consumption of animal fat, especially pure butter. So is saturated fat bad for health?
Right. No, thanks for thanks for that explanation as well. So I think that helps us understand the role of fiber. I want to also ask you, in our subcontinent, so just like in India, I was also looking at the numbers of diabetics in Pakistan as well, and unfortunately in both these countries those numbers are increasing. What do you think the primary reason is? Because we have been told, I mean, you were just like you were told it is genetic, but how do you look at it now after your journey?
Let me say it this way. The primary reason for this is the widespread misinformation spread by medical professionals and nutritional experts. The conventional ones, I mean. Okay. And then religious clerics are also doing their part by misinterpreting the various aspects of diet mentioned in our religion. So, to support those false dietary claims by medical professionals. Like doctors and nutritionists don't even understand hypoglycemia is not a signal that it's not a signal that it is time to eat or drink something, but rather what is being consumed is not proper and sustainable for the body. So we as Muslims have a golden chance every year to reset our dietary habits when we dry fast from pre-dawn till sunset for 30 days straight. But what happens is our average daily consumption of carbs increases compared to the remaining 11 months of the year. For example, if a person consumes 2 samosas a week for 11 months, that makes 88 samosas. However, during Ramadan, if we assume if a person consumes a minimum of 2 samosas per day, that is 60 samosas a month. Add to that paratha, roti, rice, pakoda, jalebi, fruit, sharbat, etc. And all this is consumed at least twice a day if no snacking is done at night. All this because we have been brainwashed to believe that these are part of the local or cultural food and are important. And additionally, for us as Muslims, I would say the clerics, the religious clerics, are spreading misinterpretation of the religion from the dietary point of view. For example, they say dates and honey are a must-have commodity in modern times, especially if you have medical conditions, including diabetes, and that it is a cure. Under this excuse, diabetics binge on these items, especially on dates in Ramadan. There's a country which, compared to Pakistan, has a higher population density, no significant natural resources, suffers more frequent and severe natural calamities. Percentage of people having diabetes in that country is 78.5% less compared to Pakistan. But if we look at the food, in Pakistan, people consume 80% less meat and 83% less eggs compared to that country.
Okay.
Additionally, that country has the largest number of centenarians in the world. And this number has been increasing since past many years. And then we have the problem of roti and rice as a way to have the food getting into the mouth. Well, I see it like this, that if there is a need to use something like roti or rice to place food in the mouth, or you require an ingredient to make a food palatable, either the food is not food or is being cooked in a wrong way. Then, but people then say, "Nah, okay, we have these issues, medical issues, but eggs are costly, meat is costly." They have this excuse. But they fail to notice that, a roti from a bakery or tandoor, a cup of tea, handful of nuts, seeds, any snack can easily be replaced with a single hard-boiled egg and be healthy, nutrient-dense option in the same price. But they don't mind wasting, or consuming 5+ rotis in a meal, or having multiple cups of tea in a day. For them that is okay.
Yeah, very well put. And we also tend to measure how much we ate by the count of the rotis, right? We say that, okay, I ate 3 rotis or I ate only 1, so I ate less. Unfortunately, that's the reality. So yeah, thanks for such an illuminating discussion. We are drawing close to the end of the session. May I request Shashi to join in, please?
Yeah, Anup is also there. Anup, get Anup in.
Anup, yes.
Yeah, Anup is here. Akmal, thank you very much for accepting the invite and sharing your inspirational journey. So what started as a diabetes recovery or remission journey, in that you also found that you had cancer and you were able to successfully get it under control, or it got control automatically, since you are following almost sort of a dietary pattern which is now recommended as a protocol for cancer patients by many top thought leaders like Thomas Seyfried or
Yes.
Nasha Winters. We had them couple of days, and then today we are going to have one more Dr. Alex talking on cancer. But I think it's a very inspirational story, and that's why we thought we will get you, even though you are not a doctor. But nevertheless, we need individuals who will come and tell us their success stories with this. So and you also gave us some insight about what is happening in your country, where the diabetes prevalence is very high. It is more than 20%, whereas even India is having 11%, but yours is very 26%. Something is seriously wrong with the food, the kind of excess carbohydrate, sugars, and even, let us say, the kind of seed oils you use, which everything really exacerbates everything. So thank you very much. Anup?
Yeah, Mr. Akmal, first of all, congratulations for being healthy again by
Thank you very much.
dumping the industrial diet dressed as standard diet or standard dietary recommendation. I have no hesitation in saying that that diet is crap, right? And we concur on to many points, especially on fiber. You highlighted the fact that fiber, I normally say fiber is not intelligent. If it slows down glucose, rise, it will slow down everything. And you highlighted through numerical data that increase of fiber, it is impeding minerals, vitamins, everything. So fiber
I'm with you about this thing. Like I personally believe complex carbs is nothing but a tool for deceiving people.
Yes, yes. Because at the end of the day, carbs in any form, if they are being converted to sugar, body will need same amount of insulin, whether you drink pure glucose or you eat, equivalent amount of tons of vegetables. Thank you. Thank you again. And thank you for coming.
Thank you very much for inviting me.
Thanks, Akmal.
Thank you, Akmal. So we'll keep meeting and we'll keep collaborating with each other. Thank you.
Yes, thank you.
Please get Dr. Dpti in. Dr. Dpti, welcome.
Hi, Shashi. Good to see you again.
Welcome, Dr. Dpti.
How are you?
Yeah.
So you're meeting Anup Singh for the first time. So I'll just kick off the session. So welcome everyone to this second Metabolic Health Conference of India, where we are showcasing some of the experts in the metabolic front, especially in the metabolic low carb, ketogenic or carnivore front, in the space of metabolic management. So with this diabetes, obesity, but this time it's focusing more on the mental health, neurological health, cancer, and of course diabetes has always been an integral part of it. So Anup Singh is here. So Anup Singh, please give introduction about D-Life.
Yeah, D-Life is basically I would say the largest and award-winning Indian low carb platform. It started in 2014, and it was as a result of me being a diabetic since 2011, and till now I am not taking any pills. I'm surviving on low carb, high fat diet primarily, and my A1C has been 5.6 max all these years. So approximately 8 kgs of pills I have not eaten in all these 14 years. And as we progressed, as we evolved, now we offer, certification courses. So primary aim is to build an army of metabolic health coaches centered around low carb, high fat diet. That's about it. Thank you.
Thank you. So we too being the co-organizer of this conference. Welcome, Dr. Dpti.
Thank you so much.
So I'll just give a brief introduction about Dr. Dpti. Dr. Dpti Arora is an established and highly skilled physician with significant experience in the internal medicine geriatrics. So she's a gold medalist from Pune and has been trained in geriatric medicine from Christian Medical College, Ludhiana. She did her fellowship in diabetes and thereby pursued the advanced course in diabetes from the Royal College of Physicians, UK. Thereafter, she completed a post-diabetes from Royal College of Physicians, UK, a postgraduate diploma in clinical nephrology, Royal College of Physicians, UK. To further her knowledge, she is currently pursuing an advanced course in the management of diabetes and related disorders from the prestigious Harvard Medical School Executive Education Program. She is also founder of HealthWise Clinic, where she facilitates people to live healthy, possibly through a novel approach in the management of chronic disease like diabetes, hypertension, fatty liver, with innovative research-based intervention like therapeutic fasting, therapeutic carbohydrate restriction, customized eating habits, and other lifestyle intervention. With her empathetic and professional attitude, she has been regarded in the medical fraternity for her approach in diagnosing and strategizing the best customized treatment plan to treat chronic disease with positive lifestyle intervention and minimal medication. So once again, Dr. Dipti, welcome to this conference.
Thank you so much, Shashi. That was, that remarkable introduction. I am also thinking, oh my God, wow. So, hi everybody. I am, as Shashi told everyone, I am Dr. Dipti Arora, and I'm a physician specializing in internal medicine with a lot of focus on diabetes management. I'm actually really passionate about finding ways to prevent diabetes and make sure that people stay healthy. That might mean helping them to lose weight with various methodologies. The methodologies once you have been hearing about in the 3 days of conferences, low carb and therapeutic carbohydrate restriction. So I would not ask somebody to refrain from using other strategies like losing weight. Some people who are very heavy, maybe 150 kilos patients I have, which we refer for bariatric surgery. And there are also weight loss medications which are being, promoted these days. So ideally, weight loss is what the focus of managing diabetes and the chronic decisions. When I'm not working, you'll find me reading on the ancient health texts, the ancient seers who have written about how to lead a healthy life. You'll find me reading about those and how we can use it today. I'm excited to connect with all of you and share about health and diabetes management, whatever I have learned in my short experience.
I think I'll mention that Dr. Deepthi is practicing in Chandigarh, India.
Yeah, I'm in Chandigarh.
Yeah, Anup.
Yeah, Chandigarh, India, which has got, I think, highest percentage of diabetics, if I'm not wrong.
Yeah, no, you're absolutely right. Chandigarh, India is the diabetes capital of the world, and Chandigarh is the diabetes capital of India.
Okay, Dr. Deepti, it's always a pleasure, interacting with like-minded doctors. When I say like-minded, means they are practicing low carb, by and large. So being a, mainstream doctor, what made you enter into this low carb or TCR, as an option to be given to patients?
So, as shared by you, it was basically my own personal experience which started it. And as a diabetologist with a family history of the disease in the family, I knew I could not afford to overlook the warning signs. So I was in my own, body, I was having those warning signs of gaining weight. And then I had to polyuria, polydipsia, all those were there. So I found myself at crossroads. I was very clear that I don't want to be a diabetic. The fear of succumbing to the same fate as all those people, it was a dark cloud. So with the support of my friend, I shed around 14 kilograms and witnessed a remarkable improvement in my blood work numbers. It was a moment of triumph, actually, that fueled my determination to chart a new course, not for myself, but my patients as well. Guiding my family through the same journey wasn't easy. As a trusted family member and a healthcare provider, I felt the weight of responsibility on my shoulders. I couldn't afford to falter or let them down. Despite the doubts and fears, I pressed on. Delving into research on therapeutic carbohydrate reduction, I armed myself with the knowledge and insights that would allow to revolutionize my family and my practice. Advising my patients to embrace a low carb lifestyle wasn't about managing their diabetes. It was about empowering them to reclaim their health and vitality. But as you all are aware, the road ahead was fraught with challenges. Skepticism and raised eyebrows greeted my unconventional approach, but I refused to waver. As the word spread of my patients' remarkable transformations, my practice flourished. The trust they placed in me was humbling, and they started calling me a doctor who removes insulin. I was grateful for this opportunity to make a difference in their lives. Today, as I reflect on my journey while talking to you, I am really filled with gratitude for the lessons learned, for the challenges overcome, and the changes that I have been able to make and touch lives along the way.
This is really very impressive. I mean, any doctor who will discontinue insulin is going to be a god for that patient.
So actually, in Chandigarh, they call me doctor who removes insulin. They'll come to me in Hindi and they'll say, "हमने सुना है आप insulin हटा देते हो." So that is, every time such a patient comes, it's like a pat on my back. Okay, fine, and I feel proud that I've been able to help them. And
I
I've
think
had patients who are taking insulin on maybe 4-5 times a day. And my success story is removing a patient of insulin who was on more than 100 units of insulin.
we call them industrial dose of insulin.
Yeah.
So I think for the viewers, the clarifying factor here is what Dr. Dpti says is it is in type 2 diabetes patient, not in type 1. So in type 1, insulin is required. What she means is in those patients who are not controlled adequately with nutrition and they have been pumped with a lot of insulin, and she helps correcting the nutrition, the baseline, and helps either lowering or removing insulin. So there's a caveat which I wanted to add.
Yeah, thank you so much. Yes, type 1 insulin is where type 1 diabetes is where your body is not, making insulin. So how I put it across to my patients is that when they make their sabzi or dal, whatever they're eating, if they forget to put salt, they add additional salt. So that is type 1. Body is not making insulin at all. Type 2 is a different opposite condition. It is hyperinsulinism. Body is making excessive salt. So when the salt in the dal is more, they have to put something to remove that salt. So that is how I explain to my patients.
Very crucial point to touch upon very nicely, that type 2 diabetes is the condition where we produce excess insulin. I think this requires an underlining of it. Now, doctor, what is wrong with the current system in the sense a lot of starchy foods are actually recommended? How harmful it is? What is the consequence of these, especially in the diabetes population when they eat a lot of starchy carbohydrates?
Yeah. So mainstream recommendations they're not accepting low carb approach right away, but yes, changes are happening. However, I would also like to point out that mainstream has never focused on refined starches like white bread, white rice, sugary cereals. They also have always asked to consider the glycemic index of the starchy foods. However, things have not panned out the way they were supposed to be. And when we talk about the long-term effects of taking such starchy foods, there is a lot of things that we have to consider. So if we are loading up on refined starchy stuff like white bread, sugary cereals, and processed snacks, the first and major effect is on the waistline. These foods are packed with calories and they're very low on fiber. So it is easy to pile on the kgs. And we know that carrying extra weight isn't about how we look, it's about our health too. Obesity can lead to all sorts of issues like diabetes, heart disease, and even some cancers are now known to be caused by diabetes. For obesity. There is a whole lot of then the blood sugar roller coaster, which we have been talking about. When you're munching on refined carbs, the blood sugar levels shoot up fast, which means the body has to pump out more insulin to deal with it. Over time, this leads to insulin resistance and sets the stage for type 2 diabetes. Our heart health takes a hit too. Diets high in refined carbs can mess with our cholesterol levels. They ramp up the inflammation in the body. Subclinical inflammation also goes up. And another thing that they do is they send the blood pressure soaring. There is growing evidence also now that such diets may be affecting our brains too. Fluctuating blood sugar levels can mess with our memory, with our concentration, and with mood over time. These diets are also not nutrient rich. This means we end up on missing out on various vitamins, various minerals, and antioxidants that our body needs to stay healthy and strong. Therefore, choosing whole, unprocessed options keeping an eye on the portion sizes also can go a long way in keeping us healthy.
Very nice. So one of the processed refined carb which is recommended practically to every diabetic is the ubiquitous Marie biscuit.
Yeah. And the protein powders.
Yeah, so we always have this joke that it is always said that Marie biscuit is very safe for diabetics, and they take, and when you say safe, when you recommend only 2, they will finish 2 packets because they think it's safe. Now coming back to this, we know that low carb option is there in the MNT of ADA right from 2019, or the consensus report of ADA-ESD from 2018. Diabetes Canada also from 2020 has adopted. Diabetes Australia, it is there. And now recently, you know that Diabetes Australia has tied up with Defeat Diabetes and included low carb as one of the best practices. With all these, there still seems to be very reluctance in promoting low carb for diabetes, whether it's type 1 or type 2, irrespective, at least for type 2. Why there seems to be so much reluctance still?
So I'll add on to this. Diabetes Sri Lanka and Diabetes UK have also added on looking at TCR. And it's kind of puzzling. Even though now they know that low carb is the way forward, they're still not, low carb diets are still not getting the love that they deserve from the mainstream community. And I think, this might be also to do with the fact that for years together we have been told that low fat and high carb diets are the way to go. The message has been hammered into us for so long that it's hard to shake off. It's like trying to convince someone that the sky is not blue. It's like going against everything that for generations we have learned. So it is going to take a little time. Then I think there's the food industry. They have a big say in what we get on our plates. And guess what? Carbs are cheap and easy to mass produce. It's no surprise that food industry has been pushing carb heavy products for years. But now I think the tide has started to turn. As you pointed out, ADA is also in its guidelines in 2019. Diabetes Canada, Diabetes UK, Diabetes Sri Lanka, they are starting to accept that low carb might be a good for us. They are seeing the research, and the good thing is hearing the success stories, which you people like you, Anoop, and everybody else, individual, they might call it anecdotal evidence for now, but they've started to look at it and they're starting to pay attention. Still, debate will continue, and at times they might have a point because, to be very honest, in a population like the Punjab population, if we tell patients to go on high fat, so the amount of ghee that they consume is not funny. I have seen it practically. So if you tell them to go high fat, it's like adding 5 tablespoons of ghee to their, dal. So there are pros and cons to both the situations. There are cases where we have seen keto and diet-induced pancreatitis and other complications. So this debate is going on. But I think at the end of the day, it is all about finding what works for you and what works for the entire population. There are people in whom I think low carb diets don't work, but for most people, they're a game changer. And as more and more folks start to realize that, I think we'll see low carb diets become more mainstream. I think it's just a matter of time, and we patiently have to wait for the tide to turn. And with people like Anoop, you, and the entire community, I think it'll happen sooner than we expect.
Anup?
Yeah, Dr. Dipti, carrying on from what Shashi said and what you said in your answer, doctors like David Unwin, Dr. Gary Fetke, they were very open-minded to say, we are sorry, we have been, treating patients wrongly.
Right.
By pushing this industrial, I would not call it, standard American diet. It's basically industry push diet.
Right.
Now, do you think that this takeoff of low carb in India is because some doctors or many doctors are not willing to say sorry, we have been teaching you or feeding you wrong, we made a mistake, let's correct it? It's as simple as that. So do you think, is it that way?
See, again, there are two sides to the coin. One, of course, accepting your mistake and moving forward is, according to, I would say, you, me, would be the right approach. But on the other hand, there are some doctors who would, counteract it by saying, we've not asked the people to have burgers and pizzas and all those refined carbs. We are asking, we have been insisting on whole grains, everything. So there has been a lot of, mismatch which has been happening. So expecting a senior person, a qualified person, a person who's been practicing in the same way for 30, 40 years to say sorry is, I think, expecting too much. People who can come and do it, it's hats off to them. But yes, on the overall, if I see, there are doctors who are accepting this approach. We meet a lot of doctors in our conferences, in our meetings. So I see them going off carbs at least at the conference where we are. So the tide is shifting, as I said.
Okay, so now you said, talked about Punjab, if you tell them to eat ghee. I would like to add one point to that point, putting ghee on both sides of roti does not make it LCHF.
Yeah, of course.
Right? So this I've been saying since long, I don't know, maybe around 10 years. Now, coming back to question, what are the challenges that you face from the patient when you tell them to, switch to low carb or, transition to low carb, and what all diseases, are associated with diabetes you commonly see in your practice?
So, Anup, as you have, and as a doctor, I can say that managing type 2 diabetes in India is like a wild adventure. One of the biggest love affair that we have is the love affair with our carbs. So, if I tell you in any patient, if I tell them, it is very difficult for them to resist a plate of piping hot rice or maybe fresh paranthas in Punjab. So it's a very, very difficult journey because it is such a big part of our culture. And speaking of culture, you will also agree with me that vegetarianism is a big here. Lot of folks like to opt for veg-based diets. They don't want to take meat-based diets. So the reasons are many. They're religious, ethical, and you name it. We've got a lot of reasons. But even I try to tell them, even veg foods can mess with your blood sugar if you're loading up on starchy stuff like potatoes or refined grains, especially refined flour, maida, which we use so often in our diets. So it's all about finding that sweet spot between carbs, protein, and healthy fats. Then there's India also has a challenge to access to healthcare. Assessing the right healthcare can sometimes feel like navigating a maze, especially here where it is very limited, and the doctor patient ratio is significantly dependent on the location where the patient is. So again, it is not about medication only, it is about having a reliable support system in place which will help you navigate the complexity of managing diabetes. And we cannot ignore the lifestyle factors. With the pace of modern life, it is very easy to fall into sedentary habits and rely on convenience foods that are available at the easiest. It's super easy to get sucked into a vortex of Netflix binges and takeout dinners. But staying active and making smarter food choices, oh my God, that's a big challenge and a big different ball game altogether. Encouraging people to stay active and make better food choices can be an uphill battle. And I see it every time, it is very difficult to ask them to move, especially in a city like Chandigarh, where we have ample parking. In a city like Delhi, people have to walk maybe to the metro they have to take the stairs. Chandigarh, ample parking is available. There is no need to walk. Even though there we have a lot of green areas, everything, people are reluctant. Then as for the diseases which are associated with diabetes, there is a laundry list. Heart disease, high blood pressure, stroke are the big ones. And the next comes with is the major, now the upcoming epidemic, which is supposed to be, that's fatty liver, NAFLD, non-alcoholic fatty liver disease. Kidney disease is also another one. So then there comes neuropathy, which can cause numbness and tingling in your hands and feet. There are so many people who have that burning feet syndrome where they feel their feet are burning. Retinopathy, which can lead to vision loss if not caught on early. And apart from all this, let's not forget about the mental side effects of things. There's unfortunately too common in people with diabetes is depression. So either that may be related to the mental fog that carbohydrates are causing, or it may be related to their body image and body shape. So lot of complications, and it is not only one system which is affected. From the, as I pointed out, from the head to the toe, every organ gets affected.
So, Dr. Dipti, there are a plethora of drugs available now of late. Earlier, there was only sulfonylurea, metformin, maybe some glitazones, some insulins, but now we have plethora of drugs in the last 1 or 2 decades with introduction of DPP4, SGLT2 inhibitor, GLP1, and even now imeglimin is also available. So with all the availability of so many drugs, are we still able to get adequate control in these patients with diabetes, or is it still off the mark? If so, why?
So I'll give you a data which is Shashi, which is pan-India data. In a diabetes population, the average HbA1c throughout the country in patients who are approaching clinics and having regular follow-ups, the average HbA1c is 8.5. So this data, it's alarming. And yes, as you pointed out, there are a lot of medications available. It's an incredible time. And as a practice means, my practice 10 years back, we had only 2, 3 medications. And now I have almost a list of so many medications in which I can put my patients on. But question is, do these medicines actually help getting patients good control? One, in our country, cost is also a big inhibitor, right? GLP-1, I cannot put every patient on GLP-1, even though I have seen remarkable results with GLP-1 myself. So to give you an example, a patient of mine who tried low carb approach for 2 or 3 months with an HbA1c of 13 could not manage even 1 kilo of loss. So I ultimately had to put him on a GLP-1 agonist. Within 2 months, he did not lose, even on GLP-1, he did not lose weight, but his HbA1c dropped from 13.1 to 8.0. So as a doctor practicing, I would say at least the harm that the high blood sugars are doing, that is being controlled, even though the weight loss did not happen. So many of these medications work in, various ways to lower the blood sugar levels, help in weight reduction, and mitigate diabetes-related complications. When used appropriately and in conjunction with other lifestyle modification, they can help the patients go a long way in achieving their treatment goal. But when we combine medication with low carb approach, there is a right balance that we have to strike. Adopting a low carb approach enhances the efficacy of the medication and maybe even reduce the higher doses that we have to constantly put up the patients on. As all of you know, if a patient strictly follows a low carb diet, medications can be off. I have also done in so many of my patients. There are so many patients who are, maintaining remission for a long time. However, on the overall, that's only a 5 to 7% of the population who can stick to such a strict regime for the rest of their lives. Some or the other reason for the rest of the population, they want to go back to one bite of cake for their son's birthday, or one bite of prasad when they go to the religious temple or the Gurudwara. So ultimately, 95% requires some degree of medication, but that is also related to the duration of the diabetes that they've been having. In my own practice, I will recommend a low carb approach, and if the patient cannot deal with totally a low carb approach, I will often recommend a safer medications. Today, the SGLT2 inhibitors that you talked about are proven to be safe for the kidneys and for the heart. So I would do not shy away from using that. Some patients definitely with the long-standing diabetes benefit more from medication, while most people find success when they focus on intensive diet and lifestyle changes. Ultimately,
It is very
our aim is to empower these patients to take charge of their health. Now, whether it is medication or a low carb approach, or if I have to push them to at least work out, at least 30 minutes of work, 40 minutes of work, I try to do all that.
Yeah. No.
Yeah, I think you mentioned the average A1C was 8 point something, right?
8.5.
Now, that's not surprising because whatever data that we have on community, there also we compiled, I think, for 50. The average is somewhere around that much when they started. But yes, we were targeting 5.6 max as the end target, because we don't believe in the term pre-diabetes.
Right.
Because that's a misnomer or a cruel joke by industry on diabetics. Anyway, now you said you recommend medicines along with diet, and medicines, of course, in certain cases where diet alone fails.
Yeah.
Perfectly fine. So with this approach, I would ask you how many of your patients, get down to 5.6 or maybe 6.5 as internationally it is called remission sort of. So as a percentage of total number of patients that you see.
So, Anup, thank you for asking that question, because when we discuss the pan-India data, and when in my OPD, I use software which can compile all the data. So when we were talking about this pan-India data in the latest conference that it is 8.5, I analyzed my patients, how many patients were in remission and how many patients were, still off mark. So I would like to say, out of the younger population that I deal with, and younger population I would say is below the 60 age mark. So anywhere between 35 to 60, I have been able to get an average HbA1c of 6.0%. I have
Okay.
not calculated 5.6 per se, but at least, my aim has always been below 6.0. So it may be 5.9 or 5.6. I've not analyzed that, but yes, a lot of them are there. And in the older population, my benchmark is 7, because if they have been having diabetes for, let's say, about 30 years, for 20 years, there has been a degree of beta cell failure which has happened. So even if they lose weight, even if they go into remission for 3, 6, 9 months, maintaining a long-term remission for them, because at that age, at 70, 80, 85, I have patients, my youngest patient is 94-year-old diabetic. So at that age, asking them when they're finding, changing their cultural beliefs and not eating, so that's a little difficult for them. But at least if they're maintaining around 7, I'm very happy. So most of my patients, young patients, are in the range of below 6, and the elderly ones above 70 to 95 are below 7. I'm very happy with that.
Yeah, that's perfectly fine, because as you deal with older patients, they would say, "Abhi kitni zindagi bachi hai, kha lene do." Right? This mentality comes in.
Yeah, and somewhere in our country, cost of feeding them also impacts.
Yes.
You can't ask a 90-year-old who's depending on his family to have a high protein and eat twice a day. That cost has to be seen. The family dynamics has to be seen. The environment has to be seen. And so all that keeping into mind, so it is, I do not have a very stringent approach that this is what I want. 5.6 is the cutoff. No, I take it to each person's individualized and, environmental approach.
I think it's remarkable. 6 on an average is
Yes, very
remarkable.
remarkable.
And
Thank you so much.
unparalleled in many cases. With whatever approach you're approaching, a moderate approach with a safer pill, which may not cause hypo, and using all this good. So one question I want to ask, one question it vexes everyone from a medical doctor point of view is, why is the incidence of diabetes rising in India? People say कि हमारा दादा नानी कहानी always comes, nana nani kahani. They were eating the same thing. Why it is coming? What could be the reason from your perspective?
Yeah, so like you said, dada dadis, first, definitely it is the genes. So one thing which I tell my patients is, if suppose my patient X, Mrs. X, is a diabetic at 52 years, so I encourage them to control it at there and then, so that their next generation can say that there is no genetic influence in my family. Right. So that is my first point, that do not go for genetics. Genetics is there. It is 10%, 90% is your lifestyle. If you control your lifestyle, you will not pass on to your further. So don't do it for yourself, do it for the next generation. And we Indians, we have a genetic predisposition. We are thin fat Indians. We are not obese like the Americans. We will hardly come across a patient who's 200 kgs. We are generally around the 90, 100 mark. So then there's a lifestyle. Now there is a lot of, at least in the urban areas, there's a lot more processed food, sugary drinks sitting around more than ever. Advertisements of those Sting and all those drinks, is there. And with this urbanization on the rise, the overall globalization happening, the westernization happening to our culture, we see a lot more people swapping home cooked fresh meals with convenient and, Swiggy options. And the obesity epidemic is going to, it's means difficult. It is, our culinary habits also play a big role. Like I said, Punjabis, you can't go tell them to have as much ghee as they want, because I've seen those meals, the ghee floating on their dals and sabzis. Not on, they say, we roti mein to nahi lagaya, as Anu pointed out, but dal and sabzi, it's floating. So the food is definitely, we are, as a generation, as a country, we are heavy on carbs more than, other option. And cost, as you were discussing in the previous section, carbs are cheaper. Most of our Indian population cannot afford the right kind of fat, the right kind of protein. So carbs are their go-to option. So that is why the incidence and the prevalence of diabetes is very high in our country. The people who can afford, they have a lack of awareness. The doctors also have a lack of awareness. Access to healthcare is, not exceedingly high. And then there are screening programs. The government, even though they are emphasizing on screening, the fact that people acceptance that I can have diabetes, I am gaining weight is very difficult. So screening programs and will go a long way in diagnosing the problems early on. So when I see a patient who's newly diagnosed with an HbA1c of 10, had the screening happened 5 years ago or 2 years ago, he would have been caught on early and treated accordingly. So those are also, it's a mixed bag, but addressing these factors through education, lifestyle changes, we can really make a lot of progress in ensuring that India does not stay the capital of the world, diabetes capital of the world.
Anup?
Yeah, I'll combine two questions into one. Approximately how many patients in your practice, I would say annually, do you see with TCR implemented? And can you talk a few of your memorable cases where the success is beyond belief?
TCR, as in you mean
Therapeutic
patients?
carbohydrate restriction.
No, I know. But patients whom I treat on TCR, is that the question? 100% of diabetes.
Yes. How
My
many number
recommendation is
per annum?
100%. Number per annum would be around, maybe I would say around 4,000 patients per annum.
Per annum.
Yeah.
So that's 10 patients per day, roughly.
Sorry?
That's 10 patients per day.
More than that, yeah. So yeah, so I am taking of around 15 if I put an average. So that number of patients and multiplication, doctors are bad at math. So around 4,000 patients and annually I'm seeing, which I'm encouraging them to restrict their carbohydrates and take care of their diets. And trust me, many patients, if you go in a stepwise approach, like my approach to a patient who's on 5 meals, maybe like the earlier advice, 5 small meals, I would first ask them to stop snacking. I would say you take 3 meals and one of those meals should be 0 carbs. Means either you have only eggs in the breakfast, no bread to accompany your omelette. So that is one. Second, I will not switch your roti, or I will not shift your, of course, rice, I tell them, and starchy vegetables, I tell them to remove. But my mainstream is first meal, you go off carbs. Then when the patient, I call them after 1 month for follow-up, is comfortable with that, then I will switch the carbs off at night also. So it's basically 1 carb-loaded meal in the lunch and 2 meals, which are maybe one is egg-based or protein-based, and the other one is vegetable, salad, sprouts-based. So that is a kind of approach which I'm dealing with, and this has gone a long way. And my memorable cases, my God, I have so many of them. I can't be taking my patient's name on a public platform.
Okay.
So let's call one patient Mr. Rajesh. So Rajesh was 45 years when he was diagnosed with type 2 diabetes. And this was a newly diagnosed patient. And as I said, newly diagnosed, screening had not happened before 45 years of age. His HbA1c was 10.9 and elevated triglycerides. So concerned about his health, he came to me and decided to take action. What we did was at that level, 10 plus HbA1c, I did not want to wait for the TCR and his habits to change and to kick in and then wait for 3 months and then see the change in his. So I put him on the SGLT2 inhibitor. So that SGLT2 would not let the high sugars cause further organ damage. And also the discussion with him was that medicine will be only till the time he achieves remission. So with encouragement over a period of 2 months, he also, decided to make a change. He's adopted a total switch to a low carb diet, focusing on the good proteins and the healthy fats. He incorporated, luckily for me, he incorporated physical exercises, aiming for at least 45 minutes of exercise, which was sustainable for him in the long term. Over a period of 6 weeks, he was able to gradually reduce his medication. And he could afford, so we had put a CGM also. And his sugars were 98% of the time, they were time in range. So time in range that we call is 70 to 180, but my level of time in range is 70 to 150. So ideal, the recommendation is 70 to 180, but I tell my patients, your postprandial should not peak above 150. So he was able to be in time and range for almost 98% of that time. And after 3 months, his next HbA1c reading was 5.6. By sticking to this habits, and he also was committed to his health goals, he has now reversed his diabetes, and he has been on no medication, what we call remission, for the last 3.5 years. He has been very active, and the only thing I told him was to get his weekly fasting sugars checked, so that we can, if it comes back, we can catch it early, and also to keep an eye on his waistline. So weekly waistline measurement has to be done for him. So those numbers he keeps in check. And apart from that, I don't think I've seen him for diabetes for the last 3.5 years. Another patient has been a very memorable patient was basically my first patient. She, let's call her Priya. She was on 124 units of insulin. So she's a 52, when she came to me, she was a 52-year-old person, very scared about, and as a female, her scare was, I have to see my children get married, and I have to see my grandchildren. So that was the motivation point for her. And slowly she started to incorporate low carb in her diet. Total vegetarian, no protein, no meat, no egg. So that was a challenge, how to get her off insulin. So again, with her, working with her, I learned that, I can put her on, 2 meals. So I brought her down from 6 meals, snacking every time, Mary biscuits and all that. I brought her down to 2 meals, restricted her time window from, I told her that after she finishes her household work, from 11 o'clock to 6 o'clock, she can eat. Apart from that, she's only going to have water. So, and she also, very diligently cooperated with me. She adopted those lifestyle changes and started to notice positive results. Because she was on high doses of insulin, she has a lot of hypoglycemic incidents also. And her, daughter used to, before starting all of this, her sugars used to fall at around 40, and while sleeping at 2 a.m. And at 2 a.m., her family used to check her blood sugars, that is she sleeping or is she, comatose? So that was the condition. So when she switched her diet, she noticed that hypoglycemia episodes started to, they were not there. Together, slowly, we were able to work and reduce her insulin doses one by one. It took a year, 124 to, coming down to 0 HbA1c, maintaining that. It took almost a year, I think 9 to 10 months it took. But even today, after I think 5 years, she continues to follow her low carb lifestyle, small eating window, restricted eating window, TRE as we call it. And she's very happy with her progress. So these patient journeys, I think, will highlight the lifestyle interventions that we need in managing diabetes and improving overall health outcomes.
And that's very amazing, because you are one doctor who's combining the best of all, the best of medication and lows and the best of dietary practices. Whatever you are reaching where they are.
Yeah. So my point is, see, you cannot put everybody in one same, and like I tell my patients, God did not have a mold where he, put us, and all of us do not come with the same metabolic health. So it is a customized, individualized approach where I have to see low carb may not be sustainable for one because of the religious belief or the cost effective. So somewhere I try to draw a balance where these patients, ultimately my aim is to have a diabetes complication free life. So diabetes is there, okay, fine, but maintain it around 6, have 0 rate of complications. That is what I aim for. And when they overshoot that goal, when they stick to the lifestyle and come to me with a report of 5.6, trust me, I am the happiest person.
Now, very important question. Did you ever face pushback or criticism?
Oh, a lot of it. From my own colleagues, from, so my worst criticism was a patient of mine recommended his friend who's a surgeon to me. So that surgeon, I will not take the name of the surgeon, renowned surgeon in the city, 120 kilos approximately weight. And I started him on TCR. And his point was, I have to stand all day. I need between surgeries, I need to have a sandwich. So I counseled him. I worked with him for maybe around 6 months, tried my best what I could do. And then he went back to some other doctor who was practicing the conventional approach, and told him this all is all fad, it will not work. So I think that has been a disappointment coming from my own community, a person. But yes, there have been other doctors who have been my friends in my medical college who have been able to reverse their diabetes. So that's okay.
Anup, since
Yeah,
we are
just as
coming to
I
the end
said,
almost, yeah.
just as I said, to say sorry we were wrong, it takes a lot of courage, and that's unfortunately missing, at least in India. Let's hope that this changes for the future with doctors like you, providing evidence and ground up approach, because top down it won't work. So all the best and thank you for coming.
Thank
And
you
we'll
so
have
much for
more.
having me.
Want
Yeah.
to ask you, what is your message to India through this platform?
See, my message will be of empowerment and hope. I want to tell people you are in charge of your lives.
Right.
Diabetes is a significant health challenge with the rate of prevalence that we have, but it is not insurmountable. By coming together as a community, as both of you are doing commendable work, we need to teach people to embrace healthy lifestyle choices and prioritizing preventive healthcare and early intervention. And with all this, we can turn the tide against diabetes and its complications. So I would want to make India a diabetes-free country. And if not a diabetes-free country, at least I want to ensure that it's a diabetes complication-free India. So I do not want to see patients with CKD, with eye disease, with neuropathy. So at least a complication-free India is what I would like to have, at least in my
Just one
lifetime.
point to add. You mentioned about that patient takes on 125 units of insulin.
Yes.
Now, 125 units of insulin would be around about, I think, 250 per day. That is including the cost of consumables.
Yeah.
Right? 7,500 per month.
Yeah.
Anybody with a sense of calculation and dedication can do low carb in that 7,500.
Of course, I agree. But again,
So
that
it is not costly. It is
Yeah.
not costly.
And anything is not costly if it costs you your health.
Right.
So I tell my patients, if I may say it in Hindi, I tell my patient, अंडा खरीद लो, डॉक्टर को पैसे क्यों देना है?
That is right.
है ना?
Thank you.
Thank you.
Doctor. So
Thank you.
we hope to meet again and have good collaborations with each other so that we can help more and more people in this country. So thank you very much, Dr. Dipti, and we look forward again. Thank you.
I'm looking forward, and it's so nice connecting with all of you today.
Bye-bye.
All the best for your endeavor.
Thank you. Please get Dr. Alex in and Jasmeet.
Hello. Welcome to the India's second Metabolic Health Conference. I'm Dr. Jasmeet, a metabolic health coach and a proud member of Dlife, which is India's only award-winning low-carb platform. And I'm honored to be the part of this conference, which has been organized by my esteemed mentors, Shashikant Iyengar and Anup Singh, just to bring or to provide you people a scientific feast on the metabolic therapies. And today I have with me Dr. Alex Petrushoevsky. Dr. Alex, he's a practicing low-carb doctor in Sydney, Australia, and along with his wife, Dr. Deepa Mahananda, he runs Sydney Low Carb Specialist, which is a multidisciplinary metabolic health clinic, and where they have a team of doctors, dietitians, health coaches, and even exercise physiologists. So Alex is also a foundation member of the Society of Metabolic Health Practitioners, and is also one of the directors of the Australian Metabolic Health Society, which is a non-profit organization founded in 2023 that is to help or to teach the health practitioners about the metabolic therapies. Alex is so passionate about the preventative health that he incorporates improving the lifestyle changes in the patients to improve their chronic diseases, even without the medications, if possible. So prior to his work in the low-carb space, he worked as an oncology training for several years and maintains an active interest in the cancer. So welcome again, Dr. Alex, to the India's first platform for the Metabolic Health Conference.
Thanks for having me again, Jasmine. Good to be here.
Yeah, Dr. Alex, you were there in the earlier conference as well. So this is the second one. So welcome.
Thank you for having me.
So, Dr. Alex, I have seen you people, Dr. Deepa and you both, you cover a wide range of metabolic health issues and you use the metabolic therapies for their treatment. Can you please talk about how your clinical practice has evolved over time?
Yeah, sure. So as you mentioned, early on in my career, I did several years of oncology training as a radiation oncologist. So that was really looking at cancer from the other end of the spectrum. So no prevention, it was too late by then, but, treating patients who are often very sick with radiotherapy and other standard cancer therapies. After several years, I actually changed careers and went into general practice because I wanted more variety in my practice. And I did that basically at the same time as my wife, Dr. Deepa, who you mentioned. So when we got into general practice, it's a bit different from hospital practice. So patients on a whole are not acutely sick typically, but you are then also struck with a tidal wave of chronic illness. So all the diabetes, hypertension, heart disease, dementia, all of these things that is usually the realm of the GP we were seeing. And we're seeing all these people, we were following all the standard treatment guidelines, and a lot of patients were just not getting better. They were getting put on escalating doses of medications, and there was a lot of polypharmacy, and just everyone was not really getting better. So that was what prompted Deepa and myself to really pursue other therapies, was not out of any particular ideology, just out of necessity to try and find something for these patients. So that's where we stumbled on low carb and ketogenic therapies, and really in the last 6 or 7 years, that's where our practice has really taken off. So that included starting our own low carb clinic and building a team around us to help us manage patients. And so along the way, it wasn't actually at the start, but along the way, this idea of using metabolic therapies for cancer and this notion that cancer is a metabolic disease came up. And with my background in cancer, there was something that came to me quite naturally because I could understand cancer biology relatively well, having had studied some of it in the past. So that is, over the last 2 or 3 years, we've built up a patient population of people with cancer who are either going through active treatment, or they've been through treatment, or they've got no other treatment options, who are looking to pursue ketogenic therapies and other metabolic therapies to help with their cancer. So that's really how our practice has evolved over the years.
Yeah, so Dr. Alex, we will come to the metabolic therapies for the cancer, but it would be great if we can start just with a definition, like what cancer cells are and how they are different from the normal cells.
Yeah, sure. So cancer is really a disorder of abnormal cell growth and invasion. And so in the past, there have been several hallmarks of cancer that have been described. So we describe every cancer based on its tissue of origin normally. So we'd say it's a lung cancer, or it's a prostate cancer, it's a breast cancer. And normally we divide down subtypes of cancer based on the particular cell line. So it could be an adenocarcinoma or a squamous cell carcinoma or a melanoma or whatever it might be. But whatever kind of cancer it is, they tend to all follow these same hallmarks. So that includes replicative immortality. In other words, the cancer cell can divide indefinitely. It includes invasion and metastasis, which is one of the more concerning aspects of cancer. So cancer cells can spread to other organs or foreign distant organs. Resisting cell death, sustained proliferative signaling. These are all classical hallmarks of cancer that have been well described for 20 or 30 years. And basically every cancer will follow these exact same patterns. But over time, the hallmarks of cancer have expanded. And one of the newer criteria that is being increasingly acknowledged is this idea of dysregulated or deregulated cellular metabolism, which is really aiming to really quantify that the cancer cell accesses energy in a way that is fundamentally abnormal. And this has really been described well back since the 1940s and 50s by Otto Warburg, who was a German physician who correctly described that cancer cells predominantly ferment for their energy. So whether that's glucose or sometimes lactate, they will ferment fuel for energy, whether there's oxygen there or not. And that's quite different to normal cells. So in our body, outside of red blood cells, most of our cells are typically gaining energy from a process called oxidative phosphorylation. So that involves the mitochondria, and as the name implies, it involves oxygen. So with one molecule of oxygen and glucose, we end up with 36 molecules of ATP out of that. So that's our fundamental energy source. So that's actually quite an efficient way to get energy. So 36 molecules of ATP is pretty good outcome. In anaerobic situations, and most people listening will understand what that is if they've gone for a sprint and there's not enough oxygen getting to the muscles will also ferment.
Yeah.
Either glucose or lactate. So they will use that for energy if they must, when there's not enough oxygen around. But to do this, you only get 2 molecules of ATP. So it's not a particularly efficient way to get ATP. It has the advantage of not being oxygen dependent, and it has the advantage of you being a quicker way to get energy. So you actually get the energy much quicker. So for a cell that needs it here and now, it can be quite effective. But unfortunately, that process is not going to be enough to sustain our whole body. And there's a really easy way to tell whether that's going to be the case. And because we can give a rat or an animal cyanide, which basically blocks oxidative phosphorylation, and that rapidly causes death of any organism in essence, because you're turning off oxidative phosphorylation. Now, if we, sorry?
So it's like if we give a people a cyanide, so all of their cells will die and just the cancer cells will still survive.
For a short period of time, yes, but within a dead host, they can't survive very long. But yeah, correct. So if we give cyanide to many cell lines in a lab, they're not that fast because they're not oxygen dependent necessarily. As long as they've got available substrate of fermentable material, then they can access their energy. So in that way, cancer cells' fuel source is different from most normal cells. Now, a couple of decades later on, the work of Thomas Seyfried, who I know you've had speak at this conference this weekend, has really identified that not only is abnormal fermentation issue, but the fundamental driver of this abnormal energy behavior is that the mitochondria in the cancer cell is abnormal, is not functioning well. So with oxidative phosphorylation, we do need healthy mitochondria to get the job done, whereas with fermentation, we don't necessarily.
Do you think, Alex, do you think it could be an adaptive mechanism like inside our body that the cells, they just want to survive and then they follow this inefficient pathway of the metabolism to survive and further to grow as well? It's like some triggers must be there.
Yeah, so that is I think a very good working theory for what's going on. So a healthy cell is not going to start engaging in this behavior out of the blue. So as you say, it's very likely an adaptive stress response where a cell is saying, well, I'd rather do this inefficient method of energy production rather than dying. But over time, that's going to increase potentially stress within the cell. And if you have a cell that's chronically stressed, then that's when things can break down. So the prevailing theory or the prevailing way of thinking about cancer in most modern medical circles is to think of it as a genetic disease, because we can pinpoint that most cancers have many predictable or varied gene mutations, whether it's P53 or KRAS or any other gene mutations. And if we take a biopsy of a cancer, there'll invariably be some abnormal mutations. The problem is they are down the track. They're not the primary driver of the pathology. So they come later as a response to this chronic energy dysfunction. So yes, there are many pathways to metabolic dysfunction that can cause cancer, and we see this in epidemiology. So common carcinogens, so chemical carcinogens like cigarette smoke, asbestos, alcohol, they all are chemical toxins. We can have.
So what does this carcinogens do in our body? Like they are there to they disrupt our mitochondrial health?
Correct, yes. So they are often described in terms of their gene mutation potential. But again, the core driver is metabolic and mitochondrial dysfunction. So there aren't really any carcinogens or any factors that drive up risk of cancer that are not linked to metabolic or mitochondrial dysfunction. So we've got several viruses that are known to induce cancers in susceptible people. We've got other metabolic factors like hyperglycemia or hyperinsulinemia, which will drive increased risk of cancer. Even things like cortisol might potentially through an indirect route. So all of these factors, they are all going through a root cause, which is the mitochondrial dysfunction. And that is what drives everything.
Yeah, so carcinogens could lead to the mitochondrial dysfunction, but do you think that the underlying health conditions does matter? Because, the people who are exposed to the carcinogens, not everybody get cancer.
Correct. Yeah. So I think to a degree, your genetics do play a bit of a role, but again, in what way they play a role is probably down to how metabolically healthy your mitochondria are. So yes, a perfectly healthy mitochondria is not going to get an Epstein-Barr infection or not going to be exposed to one cigarette and suddenly turn into a cancer cell. So it is really death by 1,000 cuts. And if you have a cell that's chronically dysfunctional, then that's when it's more at risk of being tipped over the edge into carcinogenesis.
So let's come to the mitochondrial health. How one can improve their mitochondrial health, and what are the other health conditions or the metabolic disorders, like how they impact our mitochondrial health?
Yeah, so that's quite a complex question in many ways. And unfortunately, as a clinician, we don't really have good ways of measuring what's happening at the mitochondria at a subcellular level. But if we think about what our mitochondria need to be happy, they need good energy balance. So you want appropriate energy partitioning. We want an absence of chronic inflammation, because chronic inflammation is, again, one of those things that can cause dysfunction of metabolic health and mitochondrial dysfunction. And we need appropriate nutrients. So we know there's many cofactors that play a role with mitochondrial function.
But when we talk about the diabetes, in case of the diabetic people, they have really very high blood sugar numbers, but like there is glucose, there is a fuel which is available in their blood, but still the mitochondria is not able to use it. It could be due to the mitochondrial dysfunction. It could be due to the insulin resistance. So, but the mitochondria the cells are really starving. So it means the diabetes is one of the prominent factor that could lead to
Absolutely. So yeah, that appropriate energy partitioning is a major driver of mitochondrial dysfunction. So absolutely. So we need good insulin signaling to make sure that glucose can enter the mitochondria or into the cell if it needs to. And if it can't enter, as you say, because it's building up in the blood because the insulin signaling is abnormal, then we're going to run into problems. Now, one of the things you sort of see with mitochondrial health is a healthy mitochondria doesn't seem to be as fussed about whether it's using glucose or ketones for fuel, whereas a stressed mitochondria or a dysfunctional mitochondria strongly is going to favor ketones, or it's going to work much better when there are ketones. And you can see this with Alzheimer's, you can see this with diabetes clearly, and other neurological disorders as well, such as epilepsy. So on that front, ketones offer us a very advantageous way to access ATP from the mitochondria if the mitochondria is stressed or dysfunctional.
Okay, so you mean like using ketones instead of glucose is the more efficient way to get energy?
Correct, yeah. In simple terms, yes. So someone who's got perfectly healthy mitochondria is very likely to be able to access energy from either glucose or ketones. So, average toddler is going to have no problems accessing energy from either.
It's about whatever fuel is available.
Correct. Yeah. So the easiest fuel we can access for a stressed mitochondria is ketones. And that really dovetails well into the cancer discussion, because to use ketones for fuel, we do need those mitochondria working. And we know cancer cells have mitochondria that are not functional. So in many ways, ketones are not a very good fuel for cancer cells, or they're not a fuel source that cancer cells can use appropriately. So the thinking behind the metabolic theory of cancer is, why don't we leverage this to our advantage? So we'll really focus on a fuel source that our body will happily use, but our cancer cells cannot use. And then with whatever small amount of glucose is left in the body, then our normal cells will, again, they'll happily use that, but they're competing against a cancer cell that is very hungry or very addicted to that glucose.
Okay, so before we get into this, it's better that we can start with what are the fuels on which the cancer cells can actually survive and grow?
Yeah, so they are fermenting. The primary fuel source for fermentation in the cancer cell is going to be glucose. So that's far and away the most important one. They do have access to some amino acids they can use for fermentation. The most important one is an amino acid called glutamine, which is the most commonly circulating amino acid in the blood. So that provides an important backdoor for the cancer cell to get access to energy, unfortunately. There is some evidence that certain cancer cells can use arginine, which is another amino acid for fuels. And there is some fermentation with lactate as well, but that's less common and less relevant.
Okay, so glucose, lactate, arginine, and glutamine. So with the help of the metabolic therapies, we will go one by one. Okay, let's start with the glucose. How using the metabolic therapies, you suppress the glucose levels to starve or maybe so that the cancer cells become more weaker and weaker. So what are the therapies that you use?
So the strongest therapy we can use, and it always is the strongest therapy, is diet. So a ketogenic diet is the best way to limit circulating glucose as much as you can and increase circulating ketone bodies as much as you can. So this has been around for over a century now, and is really the best way of controlling cancer from a sugar perspective. And when we talk about ketogenic diet for cancer, we're really talking about quite a strict therapeutic ketogenic diet, or a traditional ketogenic diet, if you will. So we're talking about usually 3-to-1 ratio of protein to fat. So it's very high fat content, usually 70 to 80% of our calories from fat. Quite a moderate protein intake. So we don't actually want protein intake to be too high, and then generally carbohydrates as low as possible. So for many conditions in our clinic, such as diabetes or obesity or certain other conditions, we tell patients you don't have to chase ketones. The ketones are just part of the process. But for cancer, this is one of those rare situations where we really are chasing ketones. We want them to be as high as possible.
Because you just want to make sure that all the rest of the body is using the ketones.
Correct.
And the cancer cells are the one, because they can't use ketones for the fermentation and they are just relying on the glucose levels. So it's
Correct.
very important to make sure that the body is running, is in nutritional ketosis.
Yes, in therapeutic nutritional ketosis, yes. So, and the way we measure this with patients is with blood glucose and blood ketone measurements.
Okay.
And we use a marker called the GKI, the glucose ketone index, which is very simply your blood glucose divided by your blood ketones. So in that regard, we're really wanting to leverage the sugar as low as possible and get the ketones as high as possible to really spread that gap
So what are the numbers you look for then for the GKI, the glucose to ketone index?
So typically GKI under 2 is where we'd like it to be. Basically as low as you can get it. Now, if you think about a GKI of 2, then say your blood sugar is 4, and it's probably not going to fall much less than 4. That means your ketones need to be at least 2. So from simple mathematic perspective, your blood ketones are really going to be the biggest determinant of what your GKI is, because your blood sugar won't change that much. So
how low you get the blood sugar for the cancer patients?
Everyone's a little bit different, but typically, between 4 to 4.5 is where most patients will get them.
4
Some
to
patients will go
4.5
lower.
mmol per
Millimole.
deciliter?
Yeah, millimoles per liter. Some patients will go lower, but often the body just will not tolerate it going any lower than that, unless it's during a fast, potentially. So the ketones, we'd like to get them as high as possible. So typically above 2 millimoles if we can.
Okay. So the first thing that you target is the glucose. And the other one is, as you mentioned, is the glutamine. Glutamine, no doubt that you're also restricting the protein intake but glutamine is a non-essential in the sense that body in itself can produce, and it's, I think, one of the abundance amino acid which is produced in our body. So do you target both of these fuels at the same time, or you first get the person into the ketosis and then you get to the glutamine?
Yeah, that's a good question. So normally we focus on glucose first because that's the first order priority. And realistically, if a patient can't get the GKI right, then it's probably not that relevant to talk about the glutamine, right? So we talk about the glucose as the front door and the glutamine as the back door. There's no point addressing the back door if the front door is wide open. So we normally do glucose first. Fortunately, with glucose, the diet plays a big role, but unfortunately, with glutamine, we don't have many good dietary options because, as you say, it's a non-conditionally essential amino acid, and diet doesn't seem to play a big role there. So we don't have many good dietary levers on the glutamine. And in fact, we don't have a huge amount of drugs we can use either. So with glucose, we do have some drugs we can use, but with glutamine, it's not so easy. So back in the 1950s, there was some research with certain glutamine blocking drugs, and the most common one is something called Eldon, which has been used for cancer in the past. So that's 6-diazo-5-oxo-L-norleucine. That's Eldon. It did show anti-cancer effects in vitro, but the problem is it's highly toxic because unlike glucose, our normal cells, they need access to glutamine.
Yeah.
So significant glutamine blockage is actually quite toxic to the gut and the immune system, a few other things like that. So it's not as easy as glucose. We can't just deprive the body completely of glutamine. And I know there are some studies in some labs using Eldon at a lower dose to see whether maybe it can be useful when combined with a ketogenic diet. But I practice in Australia and we don't have access to any Eldon here, so we have to get creative and look at other potential options for addressing glutamine. But
I think you mentioned that there are some supplements that can also suppress the glutamine or maybe the glutamine uptake in the body, like.
Yeah, so this is probably a good time to dovetail into talking about repurposed drugs, I guess. So if we're pursuing a metabolic therapy for patients with cancer, then there are some other drugs we can use that help things along. In of themselves, they're not going to cure cancer, but they do potentially have advantageous effects. So one of the most common ones we will use is a drug called metformin, which is commonly used for diabetes, and a lot of people will know what that is.
Why you use metformin? To prevent the gluconeogenesis?
So metformin works on both the glucose and the glutamine front. So it appears to inhibit glutamine uptake as well. So it works on that, and it works on reducing circulating glucose and, as you say, inhibiting gluconeogenesis. So metformin is a drug that sort of covers both bases, and it's cheap. It's well tolerated by the vast majority of patients. And if you look at the clinical data, so not even by people thinking about cancer from a metabolic perspective, but if you look at clinical data, patients on metformin with a whole variety of different cancers are more likely to live longer or survive their cancer. So to me, using metformin in this way is a no-brainer. Whether it's brain tumor, lung cancer, breast cancer, it's increasing the odds of survival, and it's also just pushing things in the right direction.
So do you mean that taking even a metformin for a normal person, like who's not a cancer patient, like it's not a good idea, because you said that it suppresses the glutamine uptake as well. Yep. But glutamine is essential for our immune system, for our gut health. So correct. Does it mean that mitochondria?
Potent glutamine inhibitor. So it's not anywhere near as potent as Eldon, but it's a weak glutamine inhibitor. So,
but people are consuming metformin for years and years.
Yep.
That's why we see, people really destroy their gut with metformin. And then they start taking glutamine supplements, Glutamine supplements, they are very common nowadays.
Yeah, and they can be useful for gastro or for repairing gut microbiome and things like that. But during a metabolic therapy for cancer, we'd be a bit nervous about using high doses of glutamine. But yeah, anyway, metformin is one of those drugs that has well-established benefits. They are mild, but they are there for cancer. So yeah. One of those drugs that we find very easy to recommend for patients who are undergoing metabolic therapy for cancer. One of the other drugs or supplements we would use for glutamine inhibition is EGCG, which is a compound found in green tea extract. So it has in vitro activity against glutamine as well. And again, it's going to be a weak glutamine inhibitor, but it has that effect. So because we don't have many options for glutamine inhibition, it's something that's easy to recommend as a fairly cheap, non-toxic supplement that patients can use. The only downside of EGCG is it does potentially interact with certain chemotherapies. So we tell patients to just make sure that their oncologist is happy for them to be on it if they're having chemotherapy.
Okay, but how long do you provide these supplements that suppress the uptake of glutamine? Because are they just suppressing the uptake, or they're also like, the suppressing the production of glutamine in the body?
So the studies are done, a lot of the studies are done on, in vitro assays. So they're pressing glutamine uptake in cells.
Okay, so but how long we can give to the cancer patients all these supplements, as glutamine is essential for many in our body?
I don't think there's any clear answer on that. So a lot of these metabolic therapies, we don't have a lot of long-term data. So I would say if a patient is undergoing metabolic therapy, typically when they see me, they've either got stage 4 cancer or they've got a glioma, or they're in a situation where there aren't many easy or good standard therapies. So in that instance, we typically say if things are working, so if your progress imaging is looking good, tumor is shrinking, then we're not going to change anything. We're going to keep going. And if things are not looking well, then we might say, look, this treatment strategy is not working. So in that case, you might not need to take it anymore. So at the moment, we're still working within a framework of limited evidence or not enough evidence. We'd always want more evidence, but it's one of those areas that's quite hard to convince people to study. So people like Thomas Seyfried have been trying to get clinical studies approved for some time, and there are some coming, but there's not enough. It's much easier to get an oncology trial off the ground if there's a pharmacotherapy involved or if there's money to be made from a new drug. So unfortunately, that's just how it is.
Okay, that's great. So Alex, in your clinical practice, you are dealing with some cancer patients, as you mentioned, like in collaboration with oncologists. So is it like the both of these treatments go in parallel, like you are giving the metabolic therapies and at the same time maybe taking some radiation therapy or the chemotherapy?
Correct, yeah. So in my practice, I know there are some clinics out there in other countries who are using Eldon and metabolic therapies alone without any standard therapies. But in our clinic, we aim to work alongside the patient's oncologist. So everything, and that's the beauty of metabolic therapy, is everything we do works in parallel, and you could argue in conjunction with standard treatments, whether it's surgery, chemotherapy, radiotherapy, immunotherapy, hormone therapy, all the standard treatments. So absolutely, we work with patients and with their oncologist to be doing everything at the same time. And I think thinking about treatments against cancer in that way is quite advantageous. So this idea that we're going to hit a cancer from every angle possible, if we can, I think that's quite appealing. So there was a time when we were thinking about using, targeted agents or very narrow focused drugs to kill cancers, and that just hasn't worked because all you need is one cancer cell to be resistant to this one therapy, and then all of a sudden you've bred a new resistant cancer cell line. So cancers do need to be attacked from several different angles. And metabolic therapies really work well for that because they're non-toxic, they're generally well tolerated, and they have other health benefits anyway. So absolutely, we combine treatments with a patient's standard regimen.
So do you think, I just want to ask, like, what are your thoughts, like, for a cancer patient, does the metabolic therapies should be the frontline treatment? And if needed, the conventional treatment can be associated with this?
I think it's very reasonable to offer it as an option for patients. I tell all of my patients that see me who want to talk about metabolic therapy for cancer that this is not an accepted gold standard of treatment yet. And there's not enough evidence there to suggest that a ketogenic diet is necessarily going to cure cancer for lots of people. I think it's an important adjuvant treatment to be added in alongside everything else. So I tell my patients typically that whether it's surgery or chemotherapy or whatever it is, to incorporate that alongside metabolic therapy. Now, again,
in the sense like, does it make the chemotherapy or the other therapy more effective?
Well, that's the thinking. So there is some evidence that combining it is well tolerated and increases success rates. So I think that's the angle that we would take. So there's no real studies comparing standard of care and metabolic therapy. And to be honest, I don't think we need to do that because they can be done together. They're not mutually exclusive.
Because as I have heard Dr. Thomas say it, because he was saying like if we really start to look the cancer as a metabolic dysfunction, there will be complete change in the treatment. The paradigm, whole paradigm can change.
Yep, and that's what makes this a very disruptive, almost like disruptive technology. It is quite a big change in how you think about it. So, most of the oncologists that I work with have no idea about what the Warburg effect really is. I didn't learn it at all during my training. So it is a very different way of looking at cancer. But I think the glutamine issue is what gives me a little pause. So if we have a good, elegant way of blocking glutamine in cancer cells, then I think I'd have a lot more confidence. As it stands, it's not quite clear to me that a ketogenic diet alone is going to be enough to cure a cancer once it's established.
It's just like we are putting some kind of stressors with the metabolic therapies on the cancer cells. And when they go for the therapies and, the cancer cells are they are already weak and they don't have enough energy, to prevent from the radiation therapy. So it's easy to kill them.
Yep, correct. So that's the idea of combining things. So often what we will say to patients is we'll do the press pulse in terms of, we'll do ketogenic diet as the press constantly. And then pulse will be something like chemotherapy. So say a patient has chemotherapy once every 3 weeks, then before their chemotherapy, we may want to add in a fast. And fasting is another tool we can use that's a very potent metabolic treatment. Because if we put a patient on a fast for 48 hours or 72 hours before their treatment, then by the time the chemotherapy is going through the vein, then glucose is as low as it's going to get. Ketones are typically as high as they're going to get. So the cancer cell is maximally stressed from a dietary point of view. And then if you've got a cancer cell that's already weakened, then that chemotherapy may work stronger then. So again, it's very additive, synergistic treatments. They work together in that regard. And the same can be said for other holistic or other alternative treatments, such as hyperbaric oxygen or hypothermia. So these are also hormetic stresses on the body. And if we combine them all together, we may end up with a more successful treatment. And again, there's limited evidence on how all of these things interact and whether they are truly synergistic together. But there are case reports of patients with metastatic cancer going to remission following similar protocols of ketogenic diet, fasting prior to chemotherapy, and using hormetic treatments such as hyperbaric oxygen and hypothermia.
Yeah, but the foundation is a diet. And then later on, we can add on the another therapies, as you mentioned, the hyperbaric oxygen therapy or hypothermia to put the extra stresses on the cancer cells.
Correct. Yeah, correct. I think if you're from a metabolic perspective, if you can't get the diet right, then it's a bit hard to see how all of the other things are going to have a major effect. I think the diet is such a potent metabolic intervention that it's likely to be the main driver of certainly the glucose side of things.
Okay. Okay, thank you so much, Dr. Alex. So I think now I can invite Shashikant Iyengar and Anup Singh. And I think if we have few questions from the public, we can, because we have time, we still have 10 minutes.
You still have 10 minutes, Jasmeet. You can take up the questions.
Yeah, better. Okay. I don't see it here. Like if we have any on YouTube, let me just see on the YouTube.
In fact, there is also one question which has come out is the correlation of the seed oils with cancer. How far is it true? Because there has been some discussion in the social media on this.
Yeah, I must say I haven't looked too much into that, but seed oils, they cause metabolic dysfunction. So anything that causes metabolic dysfunction should should in theory increase your risk of cancer because it's a mitochondrial stressor to not have access to appropriate energy and to not have healthy energy partitioning. So yes, seed oils are likely to cause a problem, whether it's indirect via their increased risk of diabetes or obesity or insulin resistance, or whether it's another direct means. I'm not quite sure on that. One thing that's probably relevant for a lot of people in India who are using seed oils is when you fry them, there are some volatile compounds that come out of the seed oil under heat. So anyone who's gone to medical school knows the classic lung cancer patient who's a non-smoker is an Asian female. And one of the reasons is they're most likely frying a lot of seed oils. If you look at these,
isn't that the seed oils, they are in itself inflammatory?
They are in themselves inflammatory, but when you heat them to high heat at their smoke point, they release volatile compounds that you are going to breathe into your lungs. And so it's very likely that one of the ways that you can induce a lung cancer from that in someone who's susceptible is through inhaling these volatile compounds.
Yeah, I would like to share one of the incident. I was invited in the World Cancer Care Organization, which is a global organization. They are dedicated to raise awareness about cancer. I was invited in a camp, and suddenly when I just get to the section where they were just checking the blood sugar levels for the public who are visiting just for the checkup. So I see like the glucometer number, it was showing something around 400, The clinician who was present there, to my surprise, what he said is, he said, nothing wrong with you. What you have to do is just try to avoid a little bit of sugar. And I think you had your breakfast. That's why it's that high. So I got very aggressive. So I thought, I'm here. I don't know why they have invited me. So I just went to the organizers and asked them. So then they asked me to give the public, there was a media person, and he asked me to just give a bite to the media, like they are doing very good work and all other things. So in front of the media only, I said, like, these people are raising awareness. That's a great thing. But the one thing, first, they should be aware about the facts, because the number 400, that is the critical number and need to be addressed. And all these metabolic disorders and diabetes, which is one of the major factors that can trigger cancer, it lead to the mitochondrial dysfunction. I don't know, the people are really not aware about this, and they are organizing camps, almost 20 camps in a month in the various part of India. That's why such kind of conferences, such kind of sessions need to be done, so that the people should get aware, at least the organizations which are participating, to raise the awareness.
Yeah, it's a huge blind spot with these organizations. When even if you don't understand the mitochondrial aspect of cancer, just epidemiology shows if you're diabetic, your risk of cancer is doubled.
Yeah.
So how many diabetics there would be in India? You just think of how many extra cancers that adds into the health system. It's huge. So I think if we just want to think about not getting cancer, then our priorities are don't ingest carcinogens. So don't smoke, don't drink to excess, don't have exposure to asbestos, and then don't be metabolically unhealthy. So don't have diabetes or insulin resistance. If we can achieve those two things, then the rate of cancer in the community is going to be significantly lower.
Yeah.
There's one more question in the front end in the YouTube that meat causes cancer. The position of WHO, meat causes colon cancer especially. So they wanted some clarity. You may have discussed this, but again, there's a question that has just come up.
Yeah, sure. So yeah, it's a well-worn position statement now. It's been around for a while. There's no convincing evidence that red meat causes cancer. That's the simple summary. When you look at the data that's been used to blame red meat, it's consistently low quality and it's consistently based on nutritional epidemiology. And consistently, when we look at higher quality data, or when the data is filtered for higher quality or newer studies, there is no relationship at all. Nor should there be. So red meat doesn't really make it into the colon. It's absorbed higher up in the gut. So there's many reasons for why it shouldn't even be biologically plausible. The only caveat there is if we are charring our meat or eating a lot of blackened meat, then that might be a problem. But the studies they use to criticize red meat, or some of the potential mechanisms they use to criticize red meat, chicken is an issue on that front as well. You know, chicken's got heterocyclic amines in it, but it's not associated with increased risk of bowel cancer. Chicken can char and brown just like red meat can too. And again, there's no association with bowel cancer. Even some of the lab studies that are done that the WHO report quotes, the lab researchers, they do these studies and they actually found that chicken caused some abnormalities in the rat guts as well, but they just try and explain it away because it's inconvenient to talk about it. And these rat studies, they are incredibly flawed to begin with, because what they do is they give these rats carcinogenic compounds and they give them a diet that's designed to be, in essence, pro-carcinogenic, and then see what happens. So it's a very artificial situation. And you understand why. You can't have 20,000 rats living a healthy life and then monitor how many cancers they get. It's hard to study carcinogenesis, but the long and short of it is that even if you took that data as real data, the relative risks they're talking about in these studies are minimal. They're very small to begin with. And there's no way of accounting for healthy user bias. So I imagine it's the same in India as in Australia. Red meat is criticized for 50 years, so therefore health conscious people don't eat it because they think it's not healthy, and therefore health conscious people tend to be healthier. And however, when you look at a country like, say, or a place like Hong Kong, red meat is not vilified in Hong Kong. It's a sign of wealth. People really prize red meat in Hong Kong. When you look at people in Hong Kong, there's no association with red meat and cancer, because the healthy people in Hong Kong, or the health conscious people, they still eat red meat.
What about the position of the processed meat? They say that it adds nitrate or nitrite. Will it have any adverse effect? Maybe sausages and all, which is cured meat or something.
Yeah, the effect again is actually quite minimal. So I tend to not favor cured meat for patients, simply because it's not as nutritious. But there's no specific need to avoid cured meat, and our ancestors have eaten it for thousands of years. The nitrate compounds, our body uses those compounds. It's exposed to those compounds whether we like it or not. It's in celery. It's in lots of plant foods as well. So again, very unconvincing when you look at the data on that.
Fine. And I think WHO also, they also say that they consider as a probability that it might cause cancer. It is not the surety. I mean, it is not in that sure character. That's how it is. Fine. Anyway, we are coming to end of the session. I'll request to get Anup Singh also inside. Anup, you're there? Fine. Till he comes, Dr. Alex, thank you very much, and you have come again for the session. Please get Anup in. So for the second Metabolic Health Conference, and since this conference was dedicated to the metabolic therapy, specifically in cancer, CKD, neurological, mental health, and we thought, since you have a significant experience in this field, that you should come again and speak to us. And thank you very much. And Jasmeet, as usual, you have hosted very well. And I think we'll get a very good takeaway message from sessions. Thank you. Anup.
Thank you, Dr. Alex, for coming again. This is your second appearance with us, and I'm sure there'll be many more going forward. So thank you for accepting our invitation and sparing time with us. Thank you.
Thank you.
Thanks, guys. Good luck for the rest of the conference.
Thank you. Thank you so much, Dr. Alex.
No worries. Take care, guys.
Please get Dr. Tanmoy in. Arun Kumar, Mandar, Kunal Jain.
Everybody else.
Not everyone will just. And so get Sucralose also in. And Ira in. Get Ira in. Arun Kumar also in. Get that Sucralose also. So, yeah, Ira, you can start.
Yeah, so good afternoon, everybody. Almost good evening, and we have come to the end of the 3-day marathon conference, the second one from India. 36 sessions, and all, as I say, every session is worth reading 10 books on that subject. And it's a new perspective on a lot of things that we didn't know existed, how we are looking at cancer, mental disorders, like Alzheimer's, and so many other spectrums as well. Each host has done a wonderful job. Each guest has done a eye-opening session. And personally, I've been very enriched. I'm sure all our hosts and all our audiences have been extremely enriched. It's a whole new perspective, and I think
Ira, we still have one session, so we will say all this for the end. So we have Dr. Tanmoy.
So we can, so that's
You can
okay.
introduce Dr. Tanmoy.
No, it's okay.
Ira, yeah.
So Dr. Tanmay is a very prominent doctor from Kolkata. He's practicing at Apollo Hospital in Kolkata, and he's also a low carb follower. He encourages people to follow low carb. He himself practices low carb, and he's an anesthetist. Welcome, Dr. Tanmay. And this is an open session for all of us.
Yeah, thank you. Thank you, Sashi. Thank you, Manu, for inviting me for the second time. This is the second time I'm here. And I'm very happy to be amongst all of you who are so knowledgeable and experienced about the entire low carb phenomenon. As Ira was mentioning, I do follow low carb myself, and I do have a small practice also. I don't have much time to go out of my mainstream and do, but I do have a small practice where I use the low carb method for reversing obesity, diabetes, and few other diseases. So even my experience has been wonderful, and the results have been absolutely awesome. And I'm very happy to be with you here today in this session.
Yeah, so this is supposed to be an open session, and we can take up all the questions. So we have an expert, Dr. Tanmoy, here, who can answer many of the questions. And I think there has been, some questions already here. Okay. Why cold press oil is required when heat generated in machine is well below smoking point of coconut oil? So would you be able to address this?
Once again, what is the question?
Why cold pressed oil is required when the heat generated in the machine is not very much?
Actually, if we are talking of the refined oils which are available in the market, they have been subjected to very high temperatures. And that is why cold pressed oils are a much better alternative. Cold pressed oils available from the Kachi ghanis, as we have seen, has been a part of our culture for many, many years. Even the Harappan civilization reports sesame oil. So that is to prevent oxidation or to prevent the seeds from becoming inflammatory. I think cold pressed oils are required, and anyone can add on to this knowledge.
Yeah, I think I'll take the next question. Is it required to take beef, pork for nutritious carnivorous diet? You can answer this, Dr. Tanmoy.
Yeah, beef and pork also form a part of very nutritious food, and it can be a part of a carnivorous diet. Yes, why not?
Is it required to be? Is the question.
Not necessarily. Not necessarily, because many of us have may have a mental block or a religious belief which may not allow us. In our country, I think if you are talking about red meat, goats, lambs are the mainstay of our carnivorous diet.
So 90% of the world population are not capable of taking ketogenic diet. So is it necessary? Is it needed to find a change metabolism of human body to suit high carb and seed oil? Are scientists and researchers not interested to change the metabolism of our body? So this tends to be a very paradoxical question. So someone says that scientists should change our metabolism so it suits refined carbohydrate and seed oil. Okay, and I think it is very
no, one cannot go against evolution.
I don't know. It is not a logical question at all. I think
at least they can eliminate the seed oils, na? Seed oils are the one actually.
Yeah, but this question is something they want the scientist to change our metabolism to such that it is we can take
that
seed
I
oil.
understood.
The question is different. Okay. Now, this one more question. I think as a doctor you can answer. It is very difficult to reduce type 2 diabetes while taking statin. How to avoid statin that are prescribed by doctors to reduce diabetes? So what will you say to this, Dr. Tanmoy?
I would tell this gentleman that first of all, you must learn a fact that this cholesterol and saturated fat, they do not cause heart disease. Most of the patients who are getting statins are not benefiting from it. It is totally unnecessary. And if statins are unnecessarily given, then there is no need to take it. So there is no need to fear cholesterol in your diet. No need to fear saturated fat in your diet. None of the recent studies and meta-analysis have proved that saturated fat and cholesterol causes heart disease. So what was the question? Once again, I will be more specific.
Fine. So there is one more question which has come in, and which are the sweeteners we can use in low carb? And I think I'll give this to Sanjeev.
Yeah.
Sanjeev, you can answer this. Which
Hi,
are the sweeteners that
hi.
are available can be used in low carb?
Hi, good afternoon. Well, I mean, we're programmed to have a sweet taste, and I'm glad we saved this question to last very metabolically healthy, to have the sweet at the end of the meal or the end of the session. So that's a good thing. But to answer your question briefly, you've got choices between high intensity, non-nutritive sweeteners and natural nutritive sweeteners. So in the high intensity, you've got the familiar ones, which are like stevia and monk fruit. And the problem with them is that they are high intensity, so they have to be used with erythritol usually when they're sold, and that causes some problems in function. When food manufacturers look for sugars, even to reduce them, they're looking for taste and function first. So everybody compares it to sugars. So when we have all of them compiled, you find that really allulose is the closest to sugar in terms of taste and function. So that is, a new sweetener that is on the block and it's growing fast. In fact, Tate & Lyle, a large company from the UK, has basically stopped their entire sugar business, and they're now focused mainly on sweeteners, and allulose is a key component of their offerings. So, to answer your question, low carb, you've got a number of options, but you have to be careful of what they're mixed with, how to use them, and what function that you need them for to apply them. The advantage with allulose, it's closest to sugar in terms of taste and function.
Yeah. Is allulose available?
Yes, it is. It's available in the US. In fact, Tate & Lyle rations their customers every year because there's a huge demand. It's one of the fastest growing uses of a low carb sweetener in the Asia Pacific region. So it's a small market at the moment, but it is growing.
Fine. So there is one more repeated question which is coming, and this will be addressed by Dr. Tanmoy. Again and again, this question will always come. How many eggs can we take in a day?
In short, any number, whatever you feel like or how much you have the attitude to take. If you calculate your protein requirement per day, and if you are a 70 kg man, and if you calculate 6 to 7 grams, so 10 such eggs can satisfy your protein requirement. But rarely does one take 10 to 12 proteins, 10 to 12 eggs per day. But answering your question, there is no upper limit of taking eggs per day. There are reports of people taking 30 eggs per day and causing absolutely no harm to the patient. And as discussed in this conference, if you are going on eggs, go slow and adapt it or adjust it to your gut, how your gut tolerances. Nothing to fear about the yellow of the eggs to add on to it.
Fine. So I think this question Jasmeet can answer. Can arthritis be treated with low carb? Now, this is just a question. We don't know whether it's osteoarthritis or rheumatoid arthritis. So in the context of both, Jasmeet, can you just...
See, arthritis, it's an inflammatory condition. So the thing is, the first line of action is, of course, that if you are even taking the steroids, if you have already started the steroids, the first thing is that you should correct your diet. At least you reduce the inflammation which is coming through your diet. Because most of the plant-based diets, which are mostly inflammatory, And even people like who are vegetarians, they go for a high amount of nuts and seeds, and they are very inflammatory. So just correct your diet first, and then try to reduce your steroids, because steroids and the anti-inflammatory drugs then can be reduced. You can talk to your doctor, and we have already treated few of the arthritis cases, both in a vegetarian and the non-vegetarian, like the carnivore diets as well, even the vegetarians as well. So it is possible. Yeah, Anup want to say
Yeah, I
something.
wanted to come in on the egg question. Eggs in isolation, if we decide the number, it is not the correct way. If you're on a low carb diet, then the number is irrelevant. If you're on a high carb diet, then everything goes for a toss as far as saturated fat is concerned, because ultimately you're on a high carb diet where fat won't be metabolized because of elevated insulin levels 24/7. So if the person who has asked this question is on a high carb diet, I would say take not more than one per day. If you're on a low carb diet, then there's no upper limit.
A very good clarification.
Yeah, there is one more question for Dr. Kaur specifically. Does low carb in itself improve gut health, or they should take some steps necessary to improve gut health before switching to low carb?
Yeah, so it's very important that you first correct your gut health, because if you are on high carbohydrate diet for years and years, you don't have a good gut health, because the human gut is actually meant to digest protein. And on low carb, you prioritize proteins. But with a high carbohydrate diet, what is happening? You are not producing enough of the stomach acid. You don't have mucus layer actually. Even people destroy their mucus layer with a high carbohydrate diet. And what they do, when they switch to the low carbohydrate diet and they start adding a lot of stomach acid, they take the betaine hydrochloride, they take a lot of apple cider vinegar and all other things, they actually lead to the condition of the gastritis. Even I have seen few cases. People, they don't have gastritis, but when they switch to the low carbohydrate diet, they get gastritis. It's not because of the diet, because you don't have a mucus layer. First, correct your gut. It's very important to correct your gut. At each and every step of your digestion, there should be right amount of the enzymes, right amount of everything, like which is digestive juices, which are required to digest your food. So low carb, people always blame low carb. Low carb, you shouldn't blame. First, you have to correct your gut. You just be on like a diet which can be easily digested, but not high carb. And gradually you switch from the high carb and start adding the proteins.
Yeah, Jasmeet, there's a question. How do you correct the gut? Because you told correct the gut first. How? Do we take supplement or how?
See, I don't recommend supplements. I
Yeah,
have
how
never
do we do? How
recommended
do we
any
do?
supplements. The thing is, when we have to correct the guts, the various factors one have to consider, which is the one which I feel like sometimes even, just addressing the mind, that helps correct the gut, because mind plays a huge role over here. Because, everything, whatever activity we perform in our body is driven by our mind. And for the rest and digest, for resting and for digesting, our mind should be in the parasympathetic state. If you are already in a sympathetic state while you eat, or your sympathetic state is overactive, you won't be able to digest the food. You won't be able to move the food, because actually it's not the food that is moving. People, they switch to the low carb diet, they start adding protein, they say like they feel like the protein eggs, we had an eggs, it seems like the eggs are stuck over here. Why? Because the food has to move now, but it's not the food that is moving, it's the gut which is moving. It's the gut motility. If your gut is not moving, if the muscles of your gut are not healthy, and what are the nutrients your muscles needs? Amino acids. They need vitamins, they need minerals. And from where it comes? It comes from the diet. You were on the poor diet, you don't have these nutrients. So your gut muscles are not healthy, your mind is not connected with the gut. These are the factors first need to be addressed. And just by adding supplements, it will never help. Just by adding enzymes, and people just need a pill. By taking pepsin, by taking amylase, lipase, that is never gonna help you. Yes, Anup Singh, you can add to this.
Yeah, actually, I wanted to come on to that cold pressed oil versus the regular oil. oil manufacturing process to make it commercially viable at industrial scale, they use solvents. And one of the solvents used is hexane, I think, if I remember correctly. Now, exposure to hexane is not healthy. Whatever the science says, whatever the papers say, funded by industry, of course, never go by them. So that is why the importance of cold pressed oil comes into picture.
Now, Dr. Tanmoy,
I wanted to ask Jasmeet, what is the role of fasting to heal the gut?
Yeah, fasting plays a huge role, but the thing is, see, our gut cells can regenerate in 15 days. This is what the research says. But 15 days, is it with fasting or with food? Nobody knows. Okay, they just say like it is in 15 days, but if the gut cells are already damaged, we need the right nutrients. Okay, and at the same time, they need some rest.
Yeah.
Okay, so fasting is the one part but we can never put them on the longer fast, because all the people who have gut issues, they're already nutrient deprived as well. Okay, and the oral supplements like the vitamin B's and all, because that vitamin B1, B12, B6, B3, they all are required to connect our mind to the gut. And when we give them the oral supplements, they don't have a healthy gut, they don't even can absorb those supplements. So longer fast I never ever recommend. Like the intermittent fasting, like 15 to 16 hours, that is good enough.
Fine. So, Dr. Tanmoy, there are two questions for you. One is, in your experience regarding millets in diabetes, how far beneficial it is?
It's not beneficial at all. I would avoid it, because though millets are, compared to sugar, it may be a little low in the rice, but you have to remember that all these are grains, and ultimately they break down into sugar. So whatever remission of diabetes is to be achieved, millets cannot be a part of it. I usually take patients off not only of rice and wheat, but also of millets. If they are
If I can add, if I can add what I've been saying since I know ages, this complex carb, simplex carb, pure glucose nonsense.
Yeah, it doesn't make sense.
Yeah, it has to go, because apply basics to it. If you are processing, let's say 300 grams of glucose in a day, whether it is coming from pure glucose or it is coming from so-called complex carbs or simplex carbs, body will need same amount of insulin.
Yeah, you can't
So
fool
get the maths right, the science will follow.
Yeah, and look, these complex carbs are actually damaging our guts, now.
Yeah, that is another factor. And
Yeah.
complex carbs is again, as I think it was in Akmal case from Pakistan. He clearly quoted studies where he says, all the micros and vitamins and everything is suppressed. And as I keep saying, fibers are not intelligent. Fibers, if they slow down glucose, the PPG as they call it, if it slows down that, it will slow down everything. Because fiber is not selective, that it will attack only on, take action only on glucose. So fiber is again an industry push nonsense.
Yes.
Yeah, so there is one question addressed to two person here, Dr. Tanmoy and Ira. What does your plate look like? Dr. Tanmoy, you first.
Maybe just one item, meat, fish, or eggs. And once a day, that's it. Sometimes twice a day.
Fine.
Very, very monotonous, very boring.
Fine.
So I think everybody has had a look of my plate here, everybody who's on the screen. I really enjoy my meats, and it's not never boring for me, and I don't get tempted to take anything else on my plate. So I really love fatty meat, red meat, and I don't like chicken that much, but I do enjoy it once a while. And it's fatty fish. Today, for a change, I had some coconut chutney. And so these kinds of things, but I rarely choose carbs. I mean, they are not on my plate since years now. And I did have dairy till recently, a few months, 6 months back maybe. I don't have dairy except for a few, or 1 off cups of coffee or maybe once in a month tea that I may want to have. So I think those kinds of things everybody enjoys once in a while just for diversion. But my usual plate looks like just fatty red meat, which I enjoy. I am mostly on 2 meals, and a lot of times, depending on the goals that I want to meet, I also do 1 meal a day, which doesn't typically mean that I, eat just out of one plate, but I restrict that eating window to 2 hours, which works well for me. So I divide my portion and I finish my meals and whatever chutney watney jo bhi hai for that occasional one-off days when I'm trying to change a bit. Although it's not required, but just for diversion. So I close my eating window in say 2 hours. I also do when I'm on 2 meals, then I close my eating window within 4 hours. That works the best for me. And so 12 to 4 is my typical good time to eat. So I eat my breakfast at 12 p.m. or 1 p.m. maybe, and accordingly I close my eating window 4 to 5. So that's on 2 meals. On 1 meal, I keep the eating window for 2 hours and fatty red meat.
And my eating window will be from 6 p.m. to 10 p.m. So I might take 2 meals also. Main aim for me, a person of my age, is to meet the protein requirement. So I did 1 meal a day for nearly 10 years, but recently I found that it is to meet the protein requirement in 1 meal, maybe a bit too much. So I've kind of widened my eating window in the last 6 months.
Yeah, Mandar, you can ask.
Yes, Dr. Tanmay. So we are told to not eat for about 6 hours before we go under anesthesia, right? So how does this go with people who may be on drugs which slow down the gastric emptying, or on some weight loss drugs, etc.? Does it complicate the anesthesia?
Not really. If the patient is usually these drugs which slow down the GI tract should be also given 12 hours before the previous night.
Okay.
When the patient, we advise patient fasting for anesthesia, we tell them don't take anything after 10 p.m. So, and morning also, if the patient is on anti-diabetic drug, which is a concern, we omit the anti-diabetic drugs in the morning. Incidentally, this fasting is what logic with what I use to convince patients of diabetes. Imagine that you are a patient undergoing surgery, and that day morning you are fasting and you don't need the anti-diabetic drugs. So that is the fastest way to let you know that if you don't eat that food, you don't need the drugs.
Thanks.
Except for one care. Except for one care. If you're a type 1 diabetic, never skip the basal. Because post-surgery, it might spike. And then to correct that from that high spike, it takes a lot of, quite a lot of effort.
There's one more
check
question.
the morning blood sugar in every patient.
Yeah.
There's one question YouTube as to which fruits can be taken for gut health. So who can, Sandesh, you want to answer this?
Was that about fruits, Shashi?
Yeah, which fruit can be taken for improving gut health?
Yeah, I'd say low fructose fruits. So some examples. One of my favorites is the guava, which is not fully ripe. And unfortunately, most people in India like the ripe guava. But a semi-ripe or a unripe guava is one place to go. Sometimes papaya is okay, but not like the best. It's still in the mid-range. I would also obviously the avocado. In South India, we call it butterfruit. That's great as well. All berries are great. In fact, the polyphenols in berry, there are very few studies, weak studies about the polyphenol in berries and its impact on gut health. Not very conclusive, but especially some of the Indian tropical berries are great places to go.
Fine. So there is one question on what are the options for veg people. So let me answer that. Or Dr. Tanmay, you can answer this. What are the options for veg people?
You have more experience,
Or
Shashi,
I
with
will
the
answer.
vegetarians.
So I'm a partial vegetarian. So see, the options are, first of all, we have a wide range of low starch or non-starchy vegetables you can take. And then you can add these dairy proteins in terms of paneer, yogurt, cheese as our protein source. Maybe some, soft nuts and seeds are all okay. I know that the carnivore here will always say that, these Some of the seeds and nuts may not be good, but when it comes to vegetarian, the choices are less. So I don't mind having this, stocking them and using them in the right way can actually minimize this. Though it may not be optimal, but it will get you in good health. So dairy proteins. See, in some cases, I would recommend even a small bit of rice is also okay in one of the meals. I mean, if you cannot do all with those things, drain the starch, use it. Sometimes I use resistant starch method. Drain the starch and keep it in fridge. Take it out the next day, and make it some. Add some those biryani or pulao masala with vegetables in it. Don't heat it, but you can mix it. So it has a lesser glycemic impact, is what we have seen. See, this is highly individual. For some people it will work, for some people it will not work. So it is highly individual. So I might recommend, maybe some small one meal is all okay. So the choices are restricted, but nevertheless, you can do it. So, and for vegetarians, there are many vegetarians who also opt for eggs. And we know this in our country. So if you can change that thought process and add up eggs and dairy protein like paneer itself will be, will be satiating for you, and you can carry on. In fact, you can be on a ketogenic diet also. Forget low carb, you can actually be on ketogenic diet with only eggs and paneer and yogurt and non-starchy vegetables. So it is not easy. It is difficult. It is not easy, but it is possible. And many of us have been doing it. Yeah.
One thing I would like to add to this, Shashi, like as you mentioned, nuts and seeds are okay. Yes, they're fine for the vegetarians, as you mentioned, by soaking and roasting them. But one shouldn't go for the processed low carbohydrate food. Like nowadays, the people are selling in terms of the low carbohydrate diet. All these nuts and seeds, they just grind them with a lot of other seeds. And I think we shouldn't recommend all these things for the vegetarians as well.
Fine. Arun Kumar, you wanted to add something?
I have a question from our speakers that they told that they are not recommending long fasting. My question is what they think about autophagy. This is for the Dr. Tanmay, and this is for the Dr. Jasmeet.
You mentioned that why we shouldn't go for the long fast.
No, you mentioned just recently that I'm not recommending long fast.
Yes, I never recommend long fast.
Why?
To most of my clients, I never recommend.
No, I'm not going to client. If in case of the autophagy.
In itself as well, there are many things. The one thing is due to the stress.
No, but my question is for autophagy. My question is for why not long fast for autophagy? And Dr. Tanmay can also reply.
Autophagy is set to start at least after 20 hours of fasting. So one autophagy in the long term has been, going by the reports, has been beneficial in prevention of cancer growth, has been very good for weight loss and other purported benefits. I myself have fasted up to 72 hours. I used to do it once in 3 months, and 36 hours. I used to do that once in a month. I would say I did not have any problems. I did not have any issues because long fasting, I would say, is like marathon running. You have to start, get trained in that. So my initial fasts were 16 hours and then 24 hours, 1 meal a day, which I said I practiced for nearly 10 years. And then on that level of fasting, going into a prolonged fast for autophagy benefits was not a problem for me. I managed to lose the weight, maintain the weight which I wanted to, and also feel very energetic throughout the fast and even after breaking. So I don't know, it's very difficult to measure autophagy, but going by literature, it starts at around 20 hours after fasting and continues, and it peaks off at 72 hours.
Yeah, doctor, that is after 72 hours is the maximum autophagy occurs. And in my experience, I did many times from 48 hours to 72 hours. But I was just asking whether there is any detrimental effect on our body for the long fast.
I think that as the Dr. Tanmay mentioned, one should be trained enough to do the longer fast.
No. Question of training or not. There is a detrimental effect on the body. Even if it is same, if it is a detrimental effect on the body, why should you go for the long fast?
See, because I feel like, there are other factors that one should consider when they go for the longer fast. And people are not trained enough, but still, they are just seeing other and they are going for the longer fast.
Question of training. It is
See, the studies were done under the ideal conditions.
if there is a detrimental effect, even if you are trained, then there is a detrimental effect on the body. I
Under
just
the ideal conditions, it won't be
can you please
detrimental.
speak slow? Sir,
Yeah,
can you please speak
I
slow?
think
We
you're
cannot
little,
hear.
yeah.
Yeah. Can you
You're
please speak slow?
Yeah, see, there is one more question which has come in is fasting must for all? This is a question which has come in YouTube. So let me answer this. Okay. Fasting, especially from the perspective of vegetarian, is I think is a must and beneficial. The reason is the choices are less. If you plan multiple meals, you will not have much choices. But if you plan 2 meals, it is possible. So if you do fasting, it is good. If you have blood sugar issue, your numbers will be much more stable with less peaks and all. Okay, so this is true for everything, even for vegetarian, even for egg-based. But vegetarians, it will be even more beneficial, not simply because you are reducing the number of, the meals you had since you don't have choices. Okay, so and people who are non-veg, they have so much animal protein that they don't feel like eating much. For example, Dr. Tanmoy here, he takes only one meal. So fasting is beneficial. While it is not a must, it is not a must, it is beneficial if you take. So there's one more question. This question will always come in all programs every time you log in, and that is, I will leave it to Dr. Tanmoy. Please mention what oils we should use. And you can also answer on that controversial, debatable topic of mustard oil. Yeah.
Okay. The person must be meaning cooking medium.
Cooking medium, yeah.
Cooking medium. Okay. For our country, traditionally the cooking medium has been ghee for a very long time. If you go back a few hundred years, ghee and butter and cold pressed local seed oils, and it has been coconut oil, which is not exactly coconut, is also a big seed in the south, and then sesame oil. Sesame oil, as I said, is a very ancient oil in our country. It has been found even in the Harappan civilization, and such other like I will come to mustard oil the last. Mustard oil is also cold pressed oil which has been used in our country for centuries. Now, the mustard oil is very high in omega-3 compared to the other refined oils. So I don't see it as a health hazard. It has been used and it can be used while ghee and coconut oil and butter, I would say, is number 1, number 2, number 3 recommendation. But those who have been traditionally using mustard oil, I would say, okay, not much against it, but use it as little as possible.
What about the presence of erucic acid and the
Yeah.
of it causing dropsy? Because this is something which is unaddressed.
I don't know. This was due to some contamination in processing, I believe.
Dr. Karma, there is erucic acid present in the mustard oil, and that's why it is banned in the USA and total European countries. But in India, it is strictly going on. Whether it is cold press or whether it is, packed by the company, the erucic acid is there, and that too, it varies from 45 to 55%. It has some effect on that, and I think Sasikant had just reported. So, what do you think about that?
I have not come across any issues in my practice or personal use of this kind of complications from mustard oil. I don't know if anyone has some experience they can say.
Fine, take it. So we need to research a little more and get back on this. Yeah, Anup wants to say something. Anup, unmute it and say, unmute.
Cannot.
I think
audible now. Audible now.
Yeah.
Yeah.
Okay. If it comes to my choice of grading the 3 cooking fats, of course we are on common ground: ghee, butter, and coconut oil.
Yeah.
I would place coconut oil first for the
Definitely.
simple reason that it is 2/3 is MCT, and MCT is shunted through portal vein to liver, where it is converted to ketones. Ketones cannot be stored. It can either be used or expelled. So even as North Indian, I'm using only coconut oil, virgin.
Fine. So there is one question which is migraine patients find fasting very difficult. I think Jasmeet, you can answer since you took up the migraine session.
You're muted.
Unmute. Unmute, Jasmeet.
Yes, fasting is the one thing which Dr. Angela don't recommend for the migraineurs. There are two things. One is because, while fasting, if you have to take enough of the salt, and you also have to hydrate well. You have to take enough water as well. And the other thing is you must be fat adapted at that time. If you are in a high carbohydrate diet, of course, that are the one of the trigger for the migraine attack, because as Angela mentioned, like glucose, which are like the carbs, which are nothing but the glucose. Glucose is the one thing that trigger trigger migraine because the electrolyte imbalance that it create. Okay, so the thing is, what migraines are? Migraines are nothing but the electrolyte imbalance. More specifically, it's the lack of sodium in the intracellular space. So anything which can trigger that, while fasting, if you have high levels, high stress levels, there could be like lot of gluconeogenesis in the body that could lead to the migraine attack as well. So you should be fat adapted. You have to take enough salt. You have to hydrate well.
Fine, thanks. So, Mandar, you can ask one question. Just after I ask, there's one crucial question coming in. Is this again one of the hotly debated and always asked question? And I want Dr. Tanmoy to take up this question. Is which salt we should use? The plain Tata salt or Senda Namak or Himalayan pink salt? What is it and why?
Salt, first of all, salt is essential. And at the end of it, when you grind it, it really doesn't matter. Though table salt is said to be refined, it can be used. And the Himalayan pink salts and the other fancy salts which are available are, I don't think they add on any extra benefits other than extra minerals. I may be wrong.
And they're lacking sodium, iodine as well.
Yeah, no, I'm just
Iodine,
coming to
which
that
is very
point. I'll
important.
come to this point because, see, in India, we are primarily vegetarians. The source of iodine
Yeah.
becomes very less. We
Yeah.
use even less milk. Everything is defatted and skimmed milk. And we have come across cases where if people switch to uh, uh, Himalayan pink salt, they have seen a disturbance in the thyroid level. And couple of person even sent me the lab report where they say that suddenly the sodium level in blood seems to have gone down since they have started using Himalayan pink salt compared to when they were using plain salt. So I think the recommendation is always to use iodized salt. In fact, Angela Stanton also specifically recommends not to use these pink salts and all. She recommends for especially migraine patients only iodized salt or plain sodium salt.
Plain salt, yeah.
Sea salt, of course, is best. Sea salt is best.
The rock salt also having some metal, detoxification. Hello, metal toxification is there in the rock salt. What do you see there, Dr. Tarmay?
Metal toxification.
Metal impurities are there in the rock salt.
There would be impurities, okay, yeah, that is gone.
So
Fine,
I
yeah.
have a question from Twitter for Anup. Is there a after this tweet, why is there a perception that LCHF is expensive? Anup?
Well, am I audible?
Yeah.
Yeah, there are a few reasons for it because when we look at cost, we look at in independent silos. Nobody calculates the cost of avoiding pills. Nobody looks at the cost of reduction in insulin.
Cannot hear you.
Adjust your setting.
Plus, session, there was one patient who went off 125 units, that's 7,500 per month. Now, in 7,500 per month, even the poorest of the poor, in the sense that who's working and eating 5,000 rupees worth of crap, can do a 7,500 worth of healthy diet where there is no risk of landing into being a diabetic, right? And if I look at my case, 8 kgs of
Voice gone again. I think battery is low.
Battery
is
issue.
avoided. Just a minute, I'll just take this one. Now clear?
Yes.
Yeah. So 8 kg of pills avoided. No chance of landing on insulin in this life. And from 2012, no doctor visits, no hospital visits. I do my test once in 2 or 3 years. So imagine if I calculate the cost of my meat also, which I am now on, and then add up all these extraneous costs which nobody looks at. Even carnivore is cheaper than compared to, following high carb, which is perceptibly cheaper, but in totality it is very expensive. And one cost which nobody can quantify is the monetary advantage of getting your A1C down from 9 to 5.6 and below. One stent in life can cover your 10 years of low carb cost, diet cost easily.
Fine.
Another
So
brilliant statement.
Sandesh, you can take the last question. And I think 4:30 we are going to invite everyone in for the closing ceremony. Sandesh, you raised your hand now.
No, I just wanted to answer that question.
Okay.
I mean, now obviously what Anup says is, picture perfect. The other part we miss in a low carb, high fat is it's very unlikely that you can have 3 meals a day if your LCHF is well formulated. So in that essence, you're going to pay only for 2 meals and not 3 meals. So you're going to save a lot of cost in that. Second is the other part is the paying the doctor in the future. The third most important part, which I love, is the time you get back to do other things, which is also if you want to factor that, it's also $1 or a rupees, because you're not spending time in the kitchen 3 times a day versus 2. So I think those are factors that we don't tend to see.
Fine. I think so. So I think we have come to the end of the session.
Shashi, there is a question if you want that Prajakta is asking from Kunal. If you want.
No, we can share. I think.
Okay.
Kunal, if you can answer in 2 minutes, she just wants to ask a weight loss journey. That's all.
Actually, she want to ask, like, because you lost some weight on high carbohydrate diet as well, and now you switch to the low carbohydrate diet. So what difference does it make?
So answer in a minute.
Your
voice is not clear.
Volume is weird.
There's some issue.
Sound is weird.
Is it better now?
Yeah.
Yes.
Yeah, Prajakta, to answer your question, the journey on a weight loss journey on a low carbohydrate diet, along with intermittent fasting and strength training, you just transform yourself from someone which feels a lot of lethargy, and your mental state, everything improves on a low carbohydrate diet. You get more energy, everything improves. So it's a tremendous journey if you go on a low carbohydrate past 6 months in a healthy way without taking any sort of fat burners, nothing. And I'm halfway in the journey. I want to lose another 20 of diet.
Thanks, Kunal. Can you take Dr. Ansari in? Trusha, please take Dr. Ansari in.
Yes, sir.
And we'll take the rest later. Dr. Ansari, welcome.
Marhaba, thank you.
Ira, you want to address?
Yeah. Dr. Ansari, welcome to the session, and we are almost at the end of the session. I gave an introduction of you in the morning.
Yes.
Would invite you to introduce yourself.
Yes, thank you very much. I'm Dr. Salih Al-Ansari, family and community medicine from Riyadh, Saudi Arabia. And I attended the last conference in October, and I really enjoyed it and supported somehow in the region with my Twitter account. with more than 40 tweets that brings a lot of good notes that were mentioned. And after that, I had a good session with a podcast with Dr. Shashi, and I published in Arabic a summary of the last conference on how to build advocacy for low carb, and to complete the introduction, I am very much interested to support low carb, and I do advocacy for 4 main areas in the lifestyle: walking, intermittent fasting, sleep, and low carb intake. And really, I find it very good for me as a public health consultant to advocate for the main important behaviors: walking, low carb, good sleep, and intermittent fasting. And I really find it very good to publicize in the Arabic states.
So thank
So
you.
you've stressed a lot on walking. I don't know how much of the low carb is implementable in your country, because as I understand from our last conversations, you said it's a bit difficult, but nonetheless, you're trying from your end to motivate people to adopt a healthier lifestyle, and to that effect, you have introduced a lot of walking squads in your area, if I understand correctly.
Yes, this is true, and I really managed to be a good advocate for walking in the Arab states. I have an Twitter account which followed by more than 139,000 people, and I managed to do a lot of walking groups. By now, I can talk about 250 walking groups in different areas of Saudi Arabia, and the spread of the world has become wider than Saudi Arabia. The Gulf states, Jordan, Turkey, those people who know what is happening on walking in Saudi Arabia over the last 10 years has helped me a lot to spread the word among other Arab states more than Saudi Arabia. And now really we find a good move in our country and Arab states to, whether it is walking in nature or walking as an indoor for treadmills and these things, as well as hiking and going for mountains and nature walk, and it's becoming very much prevalent and enjoyed by more and more people in the Arab states, especially in Saudi Arabia over the last, we can talk about 5 to 7 years. People are very much enjoying this, and the message is propagated.
Do we have time for one question, or are we done?
Yeah.
I said, are we done with the time? Or
Yeah. So thank you, Dr. Ansari, for coming.
Can I add?
Anup, Anup.
Yeah, Dr. Ansari, walking, yes, you talked about it in our last interaction also. Now, since this is more of a metabolic health, which covers diabetes primarily, associated with it is obesity and everything else. What is your benchmark of assessing the success of this activity that you are promoting as far as diabetes is concerned? My question is 2 parts. Are you just looking at weight and blood sugar, or are you also looking at blood sugar and insulin?
I'm talking about the weight mainly, because this is the most important push that we can do for metabolic health. And I'm talking about walking plus lifestyle, especially good nutrition and concentrating on low carb. And what I can talk about very much is the success stories that I do manage and publicize. I'm now talking about more than 200 stories of people who managed to control their diabetes, their chronic disease through walking as well as lifestyle. And I have a special Twitter account, Walk Stories KSA. It is mainly in Arabic about people who managed to do it through walking as well as low carb and intermittent fasting and other lifestyle changes. But before I leave, I can just talk about quickly about advocacy for low carb. We need to invest much more, because I can notice that lots of the people who attended this conference are talking about the case by case or face-to-face education. In the public, we are talking about different attitude. We are talking about tweeting, content, training, publicity, and these things. And really, we need to push more on advocacy, because this means lobbying, it means awareness, it means creating more and more active people to push with us on low carb mediation, because I feel that talking to several people in your practice is limited to the people who are learning and doing the change in themselves. But the people in the public, in the social media, we need to have a different approach. And I was following all what you have presented, you and the speakers, and really we want to make low carb as a word of mouth. People should be able to teach themselves and teach the others. And I really followed Dr. David Cavano and Thomas Seifried, who are really giving me a lot of things to think about. How can we advocate for low carb? And probably you can consider maybe in the future to have another similar conference that talks about advocacy, building support, convincing people, not only case by case or clinical practice alone, which is all of them are doing very good thing, but publicity in the social media and nowadays are really helping us to fasten our steps toward a good earth with low carb.
Yeah, but Dr. Ansari, somebody has to pay for all this. Somebody has to pay for all these, because we cannot be doing it. We cannot be doing it till eternity from our pocket.
I totally agree. Thank you very much.
So Dr. Ansari, thank you very much for coming in for the closing ceremony. And I think we can take everyone in, or we can remove spotlight so that everyone comes in for the final closing. The entire D-Life, all of us can be here in one screen maximum. So all of you can please keep on mute, but you can open your cameras. We don't want too much disturbance. Ira, you can give the closing talk.
Yeah. So as I said a while back, before we had Dr. Tanmay's session, we come to the end of the 3-day marathon and historic again Metabolic Health Conference from India. This is the second that we held. The first one was in October 2023, which was again made a great impact. We hope to achieve the same impact and the same outcomes with this Metabolic Health Conference as well. I think it was a learning experience and a great shift in perspective and how we look at critical ailments like cancer and mental health and all of that. It was groundbreaking, to say the least. I think wonderful hosts, everybody, and wonderful guests. And we hope to create, again, history with this conference. Thank you, Shashi and Anup, for organizing this for India. Thank you all the hosts for doing your best. It was a back-to-back sessions for 3 days, so we started late this time. But congratulations to all for achieving what we did. Thank you.
Anup, you're unmute. Please unmute.
All I'll add is, team wins, and thank you, everyone.
Yeah. So
we'll repeat it someday later again.
Yeah. So Ira, as you said, it was of course a 3-day non-stop event. Of course, we didn't have any break. And this time, unlike the last time, it was more specific, much more specific into the ketogenic approach, carnivorous approach, into mental health, neurological health, cancer, CKD, because there are a lot of misconceptions or not adequate information is available on this, that it's a treatment option. And I think that's what we wanted to do this, so that public will know that there's one such option which is available to them. And I'm sure that this will go a long way. And without forgetting, first, I wanted to thank, first of all the supporters for this event, starting from Siddharthi Goa. Neeta is not here, unfortunately, our hosting partner. So all the conference, last conference and this conference went very, very smoothly. Thanks to Neeta, thanks to Siddharthi Goa, thanks to all the chefs, Chef Balaji as well as Chef Biswas, for providing us for all the nice low carb foods, low carb treats which are available. And Imagika, of course, our event partner. The glitch-free, smooth event was there last time as well as this time also. So thank you, Imagika. Thank you, Arti, Trusha, Himanshu, and all the others. I may not remember all the name, but thank you very much. All of you, you have done a fantastic job in keeping this very nicely. And of course, our event supporters, Fitter You as well as Sucroless. And thank you very much for even South First, our media partners also. So they were media partners. Yeah. Ira, you recall anyone else?
Yeah, I think we've covered pretty much everybody. Neeta, thanks so much for hosting us. Wonderful keto food and refreshments being served throughout our sessions. All the staff, the names, maybe we'll miss out one or two, but you know that, you are in my thoughts. So thank you, all of you, for doing what you've done for us. Because of you, we've been able to do it so well.
Yeah. So Dr. Tanmoy, any last word? You're mute, Dr. Tanmoy, you're mute.
Yeah, this was a fantastic conference. A lot of knowledge and information sharing. And I hope the message goes out to the public that this low carb is certainly therapeutic, and it is an option which should be offered to them. Only when the public gains awareness, they will demand it from their doctors. It is then that the change will come. So I believe this conference plays a vital role in making the people aware.
Thank you. And I want one line from the others who are here. I will name them as per how they appear in the screen. Jasmeet.
Yeah, thank you, Shashi. So I'm honored to be the part of this conference. The one thing I would like to say, like this time you people have chosen a wonderful topics, and through this conference, I think now the people will start to relate their conditions like cancer, neurological issues, CKD, and the other things that we have covered with the metabolic therapies. So you have provided them an option. Like it could be the first line of action as well, like before they get into the conventional treatment. But thank you so much.
Thank you. And before I forget, before I hand it to the next person, I want to thank all the hosts. Everyone has hosted excellently, kept the timeline very strong. So I really appreciate this. Arun Kumar.
Yeah, Shashi, first of all, thank you, Shashi, organizing such a huge metabolic health conference where the leading low carb proponent of the world has come and they express their views. And meanwhile, we have cleared many of the myths in which the general people are living, like in CKD or in the low carb or in the keto. So thanks a lot to you, Shashi, and other team members who are organizing this. And my sincere thanks to all those guests also. So once again, thank you, and we hope that we will again meet and having some views of the leading low carb proponent of the world. Thank you.
Sandesh.
Yeah, thank you so much, Anup, Shashi, Ira. I was fortunate to be part of the hosting group the last time also in the first MHC. I think the devil was in the details this time. So you were able to double click and go into the level of detailing that we couldn't in the last time as an introduction session. So I think this was very, very good. I love the detailing, and thanks to everybody for making it such a successful event.
Mandar.
Yeah, thanks, Anup, Shashi, Ira. I think this was a one of a kind event again, and I think D-Life team has proven what we can pull off together. So thanks to all of your leadership. Of course, we had brilliant guests, and all my D-Life friends. Very thrilled to be here. Thank you again.
Prasanna.
Thank you for making this event possible to each and everyone involved. And I think the compounding effect is going to be seen a little while from now. It's going to be compounding exponentially. That's what I think is going to happen. And thank you once again.
Thank you. Kunal.
MHC 2.0 is bigger and better than the previous one. I'm really grateful to Anup and Shashi and Ira to letting me be a part of this, and the amount of knowledge we have shared, it's going to reverberate across the globe. So I'm hoping that the next edition is going to be even stronger. Thank you.
Thank you. Priyanka. Mute. Unmute.
Sorry, I don't know. Yeah. So thank you, everyone. I think it was a great session. Thank you, Shashi. Thank you, Anup. And thanks, Ira, for leading this. You did a great job, as always. And I think personally, last time, I was very new to this. And so this time I had much more, experience. So I really enjoyed. I think we really did get into a breadth of topics, which was very important for, because when we get clients, they think it's just weight loss. They do not understand, so now we can use these videos to tell them that it goes beyond weight loss. So
Yeah,
that was
thank you. Sanjay. Sanjay Balasubramaniam. Unmute. Unmute.
Okay, yeah. It was a fantastic session, as good, if not better, than the last one. I just only have a question. The whole sessions, are they going to be split up into episodes?
Yeah, that will be done as last time. Yeah.
I have to show it to my family member. I can't show them a 10-hour slide. Thank you very much.
Thank you, Praveen.
Yes, hello everyone. I feel very proud to be a part of D-Life team, and I congratulate each and everyone from the D-Life team, especially Shashi sir and Anup sir, and also Ira. And all the hosts have performed excellently. So I have watched all the sessions, and all the sessions were really great. And the selection of topics, especially this time, was excellent. So thank you everyone, and I am really feeling proud of being a part of D-Life team. Thank you.
Dr. Parul.
Yeah, thank you so much. Thank you so much. I'm feeling really proud to be a part of the life, and a big salute to Anup sir, Shashi sir, and Ira ma'am for hosting it so well.
Thank you. Bharti.
I think it's a wonderful team effort, and kudos to everyone involved. And it's been a great team spirit. I see, being new person, it's quite a lot of learning for me. So this would be like a reference that I would like to go back. And though I couldn't see all the topics but Saturday and Sunday it fell very well, so that I was able to catch up with many of the sessions. So I'll go back and refer. But hats off to everyone. Super duper effort from all of you. I'm very happy to be part of this particular community where I can also contribute in coming days.
Thank you. Dave.
Yeah, wonderful event, and kudos to you, Anup Singh, Ira, Mandar, Kunal, Arun sir, Satyajit, all of them. Wonderful effort from everyone.
Thank you. Satyajit Das.
Yes, history has been created. That had happened last time, this time also. So 30 hours of content, which is as good as 300 books. I would say much more than that. So a lot of content for not only the common people following LCHA, but for the medical fraternity also. Great effort. Thank you.
Thank you. Naveen.
Yeah, very inspiring, Shashi. I think it gives a lot of hope for people suffering from these metabolic diseases that were discussed in this event. So it gives an alternative option to them. And also, I think for us metabolic coaches, it's kind of reiteration that we are on the right path, because the guests who had come and they spoke about all the different metabolic diseases. So I congratulate the whole team for the great event. Thank you.
Dr. Neha.
Hello, everyone.
Yeah.
Hi. Thank you, Anup. Thank you, Shashiji. Thank you, Ira, for creating such an amazing event. And I feel it is such a groundbreaking thing that now normal people have access to this information, and just this being available is a blessing, I feel. Thank you so much.
Thank you.
Proud to be
Kedar.
part of this program.
Fantastic conference. Absolutely glitch free, smooth, and I think even better than the first one. This will go a long way in making low carb mainstream in India, and D-Life as it is the face of low carb in India. Fantastic, absolutely fantastic.
Thank you. Prajakta from far away.
I think the breadth and depth and details were simply amazing. But the simple message, I think we have been successful in sending across through these different experts that we had invited, that metabolic therapy can be and should be the first line of treatment for diseases from cancer till mental health. It covers a wide range of diseases and it can be used successfully.
Thank you. Puneet, health coach. Vinith.
Congratulations, Team D-Life. Like, it's a huge success, and trust me, sky is the limit for us low carb coaches. I congratulate everyone, each one of you. Thank you.
Thank you. So from my side, of course, you want to talk something or मैं बात करूं?
पहले आप करो फिर मैं लास्ट में करूंगा.
ठीक है. So let me talk. So Anup, thank you for being the rock solid foundation support for all of us. I think all these programs are possible only with you as the father figure. So nothing has been possible without you. So thank you. And icing on the cake, of course, Ira, thanks to you. Your tremendous effort in hosting has carried this program in both the events very successfully. I think, but for you the entire hosting, because of you, the entire hosting, the Tuesday session has gone excellently, and you have really raised the bar. And I don't think anyone will come close to you in managing these 3 days and the kind of fantastic work you have done. You are being recognized nationally, internationally, everywhere for the kind of hosting you do. So kudos and thank you. And before I close in, once more, I want to appreciate the Imagica team. I think without them, nothing would have been done. Fantastic team and my full praises. Yeah.
I would like to put in a word to Imagica, to Nita and the Taj staff, to the South First, to the green room guys, Mandar especially. Mandar has 4 hands. So he was controlling the keyboard, he was controlling the screen and everything. Mandar, Kunal, Prasanna, Satyajit, they were continuously there. So thank you guys. Thank you for what you did. Very grateful.
Whatever I have to say, most of it has been said by Ira and Shashi. Now, the only thing I would like to say is thank you, super host, which again has been said by both of you. The only thing which is not said is let Goa know that there is a certified low carb nutritionist in Goa. So please don't hesitate to contact her. And that is our super host, Nita Britt. Thank you, Nita. Thank you for being there always.
Thank you. Thank you. Thank you all. See you. We'll see you in next MHC 3.
Till we meet again.
Yeah. Till we meet again. And we'll meet with more surprises in MHC 3, which will come after some time.
Thank you, everybody. Assalamu alaikum.
Thank you. Thank you, Dr. Saab. Thank you. Thank you, Dr. Tanmoy.